I'm the current chair of KP Nairobi. This is our second annual symposium, and I really want to thank you for taking time out for this. This is going to be a yearly event. Now, next year, because our annual symposium is going to be in August and we'll release a save the date flyer, we're going to be having this in June. We'll release even those dates in the coming months. I would like to acknowledge the president of KP. He has really been supportive in planning this Nairobi branch symposium, and I can tell you Nairobi branch works very closely with the national office. I'm not here alone. I am here with my vice chair, Dr. Ajua, who is a consultant physician gastroenterologist, and actually he's an excellent player of football, and he's going to be organizing actually football for the physicians. You know, we can't be preaching all this and we're not practicing. So in the coming months, those are the things that we're going to be launching with regards to KP Nairobi. It's not restricted to only physicians. As you can tell, some of us are too busy in our offices. So we'll invite, including pharma, and we have competitive teams going forward. So he's in charge of sports. And then my secretary, Dr. Irene Nganga, who's a consultant physician and endocrinologist based at Kiambu Hospital. She's also an honorary faculty lecturer of EXACOP. And she's very passionate about, she says, football and loves her potatoes. But I've never met someone as brilliant as her. She knows how to balance it very well. So I won't talk much because we're already running late. But I would like to invite Dr. Irene. She's the moderator for the morning session, and she'll take us through and introduce our first speaker for the day. We will try and keep time, and during the tea breaks, if you're at home, feel free to go into your kitchen and get something, but we've also served for the people here. Welcome, Dr. Irene.
Yeah, I want to put it on Zoom.
Morning, everyone. Thanks, Rosie, for that kind introduction. As Ajua is going to be the football keeper, I also would like to be a referee in the same game. That's usually my passion. So just to start off our morning, we are going to have Dr. Sioka Ilovi, who is a clinical geneticist. I hope I pronounced that correctly. She's going to talk about genetics for the physician. So Dr. Ilovi is a physician and clinical geneticist lecturer at the University of Nairobi. Her goal is to promote genetic testing among families, training of healthcare workers, and research in Kenya. Dr. Sioka Ilovi's 2 to 3 most impressive and relevant achievements include systematic review on autism spectrum disorder in Africa, acceptability of premarital screening for sickle cell among university students in Kenya, utilization of genomic services among physicians in Kenya, rates and predictors of cascade family testing among sickle cell and hemophilia in Kenya. She's a fellow of the Aga Khan University Supporting Women in Science Program, 2023 to 2025. You're welcome, Dr. Ilovi.
Thank you, Daktari, for that kind introduction, and thank you for KAP for allowing me to do this presentation. So over the next 15 or so minutes, I'll just give an overview of what a physician in their practice can do to provide genetic services to the patients who come to their clinic. So when we talk about clinical genetics and genomics, it's a clinical specialty that deals with the prevention, diagnosis, and management of genetic disorders in probants and their at-risk family members. And typically it starts pre-conception right through conception, supporting couples to conceive through pregnancy and throughout the lifespan, all the way until death. And it doesn't stop at death. In fact, sometimes in some families, it's at the point of death that we take on genetics so that we can offer services to the remaining family members. So I'd like us to spend a bit of time on going through some clinical scenarios just to give you an overview of what our genetics practice will look at. So we'll start with preconception. So we have a 20-year-old female who's a C class, so we know she has 2 copies of the pathogenic variant who presents to the genetics clinic. So her main concerns is that she desires to have biologically related children and is worried about passing the disease to her offspring. She's lived with this condition. She knows how devastating it is. She's seen what it has done to other family members. She wants to know as much as possible, can I have children who are biologically related to me? But are there ways I can mitigate for passing the disorder to the offspring? Of note is that she's currently single. So we evaluate what she understands about sickle cell. It's an autosomal recessive disorder. So that we tell her for your child to have a sickle cell, we know you're obligated to pass the sickle cell variant to your offspring because you only have that to give. So it will actually depend on the status of her partner. If she gets married to somebody who has sickle cell disease, her children are guaranteed to have sickle cell. If her partner is a carrier, then the chances of having a phenotypically affected offspring is 75%. However, if she marries somebody who is homozygous negative for sickle cell, then she has 0 chance of having children who are phenotypically affected. All her children will be carriers, none will have the phenotype. So once we discuss this, we now explore what her desires are. And through that, she decides she will source for a partner who is free of either being sickle cell or having the carrier status. So when we come to premarital screening, it's a genetic disease prevention strategy for autosomal recessive traits because you are trying to minimize the risk of high-risk couples, right? So that you can have you can have two categories where you're performing population-wide premarital screening. So you look at a country like Kenya, which are the common autosomal recessive trait in circulation. That would be sickle cell and beta thalassemia. So you can go out into the community and offer people to know their sickle cell status, their beta thalassemia status for people who are at risk of carrying those disorders. And this is something we evaluated with one of our residents this year. We looked at university students because, like we said, premarital, you want people to get into coupling when they know their status and subsequently of their partners. And we found the acceptability was pretty high amongst our final year, 5th and 6th year medical students. It was at 82%. BSc computer science students, so we went and picked another population who's not exposed to any medical curriculum or patients with genetic disorders. It was pretty high at 65. Can it go higher? Probably with education. We've seen how acceptable HIV testing, premarital HIV testing had been taken up, right? So it's something that is feasible and acceptable to our populations. Then you can have targeted premarital screening depending on family history. So let's take a gentleman, Mr. Tom, who is phenotypically unaffected, but mentions that he has a niece who has the autosomal form of oculocutaneous albinism. So he has the risk of being a carrier, right? So the only way we can know whether the risk of albinism in his offspring is first is evaluating his carrier status. If he's free of having the albinism trait, then we don't even need to test the partner because we know he has no risk of having a child with albinism. However, if he's a carrier, then we need to test his partner so that then we can start discussing what are the risks. Another area of practice now, genetics is strictly speaking not limited to either pediatrics or adults because you're dealing with families, right? So then let me talk about a patient. We have a middle-aged lady who presents for genetic evaluation because they have a very strong family history of hereditary cancer syndrome. She tells you 3 of her first-degree relatives have succumbed to colon cancer in their 40s. She's worried about her own cancer risk, and more importantly, she's worried about the cancer risk in her offspring. So when we look at the family tree, pedigree, we're able to tell that it's demonstrating an autosomal dominant inheritance. But when we evaluate the phenotype, we're able to tell this looks like familial adenomatous polyposi. We test both Emma and her adult child, and we find them to either have the genetic variant or not. And that allows the patient now to take decisive measures, because if somebody now, before she was thinking, do I have this genotype, do I not? But now that you have confirmed, your patient will be much more likely to adhere to whatever early prevention or therapies that might exist, right? However, in genetics, typically we do not test children for adult onset disorders that lack a childhood intervention. So for her young child who's 4 years old, we cannot do genetic testing. We tell them we'll wait until the child is 18 years old so that she can make an independent decision on whether she wants to get tested for the genetic disorder or not. We can aim for earlier if the gastroenterologists tell us, look, we want to start doing screening at 16 years. So then for that girl, we'd lower the age of looking for the genetic variant to age 16. So another area of practice, I decided to pick on monogenic diabetes disorders because typically it's a disorder that is very easy to miss. And I'll even use a case we had in my hospital, because now my residents and my students draw a pedigree anytime a patient has a genetic disorder, whether polygenic or monogenic. So we had a family that had the typical middle-aged family of type 2 diabetes. So we had a 60-year-old lady who had been admitted for a diabetic foot. On evaluation of her children, she had 2 children who developed diabetes. One developed at age 17, another one developed at age 10. Now that is highly suspicious of monogenic diabetes. Then when you evaluated the extended family, there's another cousin who also got it in her adolescence. So that monogenic diabetes tends to be masked by the polygenic simply because polygenic diabetes is ubiquitous in the environment. So we really need to look for the monogenic diabetes. Another area, pharmacogenomics, is gaining a lot of prominence. So our bread and butter is dispensing drugs. I give a patient 500 milligrams. It's only a third of patients who will have what in my mind I think is the expected outcome. Some might have poor response, some might be hyper response. At the ends of the spectrum, some might not respond at all, and some might actually succumb to that 500 milligram. So that is dependent on the patient's genetics polymorphism that determines how they metabolize drugs. And there's recommendations that are coming out strongly on what to do. One of them, I'll just give one example, is clopidogrel, which is a prodrug. So you can imagine a patient comes with an ischemic event, you give clopidogrel, and they have no response. So that their cause of death might not necessarily be due to the ischemic event, but they simply were not able to metabolize the prodrug to its active metabolite. Postmortems are a very big part of our practice, and it's one of the genetic emergencies, right? So I'll give an example of a young lady who suffers a sudden cardiac death. Postmortem shows an aortic root aneurysmal rupture, which is pretty unusual for somebody of that age group. So it triggers a genetic evaluation. Thank you, Dr. So it triggers a genetic evaluation in the deceased. And then that one is able to help us inform, because critical illnesses are death are devastating to families. We want as much as possible from preventing recurrences in other family members. So then we're able to do cascade testing to other family members and decide on the way forward, right? And genetic evaluation should be considered for unexplained deaths, right? From miscarriages, it's becoming standard of care. People having recurrently pregnancy losses, we should find out, are these miscarriages due to some genetic abnormality, so that people understand what has gone wrong, all the way to neonatal death. In fact, in neonatal medicine, genetic evaluation is becoming standard of care. Children who are being admitted in NICU, ideally, when you're trying to figure out what makes a baby who's born, one goes home within a day, and another one has a STOMI ICU stay. So genetic evaluation just becomes as standard as looking at UECs and BGAs in the neonatal. Sudden infant death syndromes, a lot of them are starting to being attributed to channelopathies, largely due to cardiac or maybe neurological events. So essentially, any unexplained death and an inconclusive postmortem, we should start thinking, should we carry out a genetic evaluation? And why it becomes an emergency, we can only extract DNA from cells. If they have been fixed in formaldehyde, we'll not be able to extract. If they have been fixed in formalin, we'll not be able to extract DNA. And of course, if the person has been cremated, then there's nothing we can do. And typically also an anesthetic death and adverse drug reactions, like we said in the previous presentation. So I keep talking about families, families, families. So do we owe a duty of care to other family members? You have patient A in front of you. Is your duty of care only to that patient, or are you obligated to extend care to other family members? Maybe let me have a poll. How many think we are not obligated to extend care? It's a suggestion, it's not an obligation. The people in the room? Okay. So we'll go through a couple of scenarios, right? So you have hypothetical patients who are coming to our clinic, right? They are siblings, they are both in our care for the usual diabetes, hypertension, right? So then we have one sibling who goes and develops a hereditary cancer syndrome, but out of her own reason says, please don't tell my sibling, right? We maintain confidentiality, or do we have room to break confidentiality? The question, right? As you think through that, if I told you these siblings were monozygotic, would that change, right? Because if we have the genetic profile of the other, we are almost certain we have of the other one, right? So then fast forward a few years later, we didn't disclose. Maybe we chose and said, you know what, our patient, her hands are tied. She said, this is her personal information. Let's leave it, right? Subsequently, the other sibling you didn't disclose, not even her child develops breast cancer and decides to sue us, right? She says, with the non-disclosure one, there was an intervention. She could have had prophylactic mastectomy. She could have elected to have non-biological children, because some people say, you know what, this genetic risk is too much. I can choose other ways. Will that hold? Let's go through a few case law studies. So this is the landmark case in genetics that determined how we should handle families, right? So we had a dad who developed Huntington's disease. And he was under the NHS, and the NHS had contact with the daughter, right? So he forbiddingly expressed, he said, please do not tell my daughters. And the hospital discussed and said, look, we'll keep the old man's confidentiality, right? And at some point, the doctor actually came and asked, because she was pregnant, what my father has, is it heritable? Am I at risk? And they actually felt compelled to just keep the father's confidentiality and say, look, we don't know, right? So subsequently, later she found that it was hereditary. She was tested for it, the daughter. And then because the child is underage, the child has not been tested. So she decided to sue, right? And she actually won on appeal. So that now the feeling is that you actually have a duty of care to give to the family members. So typically what we do in a case is perhaps give somebody, I'll give you a couple of months. If you're not able to disclose to your sister, I'll be compelled to disclose, because I have this, and this also plays into, because people don't come to clinic alone, right? You might be taking care of so and so, but he's always in the company of his brother, sometimes the son. So those are things to think about. So another case, which now is on the other side of the ocean, but also highlights the same thing, is that there's a young boy who died from hypertrophic cardiomyopathy, and his dad's physician was sued because dad had had an ECG 2 years prior, which working back should have triggered an evaluation for a genetic evaluation. And perhaps the boy would have had an ICD or some intervention done to prevent this death. And they actually won. And note, the father had never seen, the physician had never seen this boy. So that is how genetics is. It's a family practice our obligations extend beyond the patient that we are seeing. So now we go back to our family. So the next time, should we have handled them differently? What will you do with the next family we encounter? Food for thoughts, right? So scope of genetic testing. So they are broken down largely into three: cytogenetic testing, genetic sequencing, and then you can also go and start doing, so these are the older cytogenetic tests. This is where we are at either gene panel, whole exome, whole genome sequencing. And sometimes you can do transcriptomics, where you go and measure the mRNA components or even the proteins, which is what, because I know rheumatologists are doing TPMT when they're trying to determine whether they're going to give azathioprine and the patient is at risk of, I think, myelosuppression. So there are some rapid tests, and that one, they measure the protein content of that gene, right? So what are the pitfalls? So genetics is not black and white. You can have a family that has 6 siblings who have, let's say, a dementia syndrome. Their parents had, but then you go and do the test and the test is negative. So people, I am certain, have the genetic disorder, but the tests are negative. So then we start evaluating. If we did a limited panel, do we extend the panel testing? Or is it that this family has a pathogenic variant that has not been described? And then we tell them we'll need to repeat this test in maybe 6 months to a year to see whether it has been recategorized. Then there are some that come out indeterminate. Sometimes, because sometimes you might do the whole genome. If you test, let's say, a child who came with autism spectrum disorder, so I decide to do a whole exome sequencing. Then I start finding out things that are completely unrelated to autism. Perhaps they have a gene that is predisposing them to hereditary cancer syndrome or retinoblastoma or Huntington's. Then how do we approach that? So there are some guidelines on how, there's some disclosure criteria, whether you're returning results in an individual patient or in a research setting, right? And then the big one, the elephant in the room, a lot of this will be excluded from insurance. Those clauses of congenital, pre-existing. So those are things you need to discuss with your patient so that they don't end up losing their insurance, right? And then there's quite a bit of self-blame and even guilt and being blamed. So that I found the biggest hindrance to a person accepting to undertake genetic testing. They can see it's running in their family, because once it's confirmed in them, they have to face the realities. Did I pass this off to my offspring? Sometimes they even say, will I pass it off to the offspring? So that is the biggest hurdle that you have to overcome to having people accept genetic testing. When you start digging in people's family trees, looking at genetic makeup, you might start finding out family relations are not what they were portrayed to be. You might find one or both parents might not be the biological parents of that child, and maybe they didn't know. Sometimes you might unmask incest. I'll give a very distressing case. Someone was presenting to us, a child who presented with a genetic disorder in the workup of the parents, because typically sometimes we do what we call through a testing test. Baby mom and dad. Mom and dad found out they were half siblings because they both grew up with absent fathers. So that is something that had not been envisioned, but can be quite distressing. And it's because that they were closely related that the child ended up inheriting 2 very rare autosomal recessive traits. So there are quite a bit of things you might be prepared to encounter. So what I'll mention about treatment is that they're in the pipeline, right? And the principles fall in where you're targeting. The only cure for genetic disorders is if you go and alter the DNA, whether you are altering the host DNA or introducing a complementary DNA. Anything else after that is a stopgap measure, right? And there are various therapies that are in the market to try and counter that, right? And they're not only being limited to genetic disorders. So this is a molecule, an RNA interference molecule that has been developed for hypertension. And the premise is that it's trying to reduce the production of angiotensinogen. Angiotensinogen is a protein. Behind every protein is an mRNA and a DNA sequence, right? We probably don't want to go and alter the host DNA. So the target is at the mRNA. If we reduce the mRNA, we can potentially reduce the amount of protein. And these are called RNA interferences. There are two. There's small interfering RNA or antisense oligonucleotides. For this, they're actually being tried out in hypertension. And they are, I think this was being given either 3 months or 6 months injection. So these are coming into the sphere of just all areas of medicine. So what would I like to summarize? There are a lot of genetic disorders that nobody knows all of them. What genetics aims to do is give you a roadmap to how to approach genetic disorders. They are very common. They'll affect 1 in every 50 person you encounter. Pharmacogenomics will alter drug metabolism in 2/3 of the patients you give. And our patients, we all have a genetic profile that is unique to us. It will alter whether we have a genetic disorder, how we alter disease presentation for everything. There must be a reason why somebody comes with pneumonia and lands in the hospital and another. So it just alters our genetic makeup, alters our interaction with the environment. And it, of course, will alter drug or vaccine response. And like I'd already alluded to, a parental guilt is something we need to look into. And the principle of genetics always conducts initial genetic testing on family members with the phenotype. So if you're considering to undertake genetic test or referring, because sometimes I've had a family coming to me when Mzee was sick, when the siblings had sort of come to terms, there's something wrong in the family, let's go and see a geneticist. But they said, let's deal with Mzee because he's sick, the 6 months, he passes on. So when they're ready to come, so you're saying it's very tricky, since we don't have a fresh frozen sample from Mzee, does he have a brother? So now you're starting to ask them to go and try and talk to somebody else. So if you're referring to patients, please start when the person with the genetic disorder is available for genetic testing. And cascade testing or premarital. Once you have somebody with a genetic disorder, please consider extending the testing to other family members. Even if it's obvious they don't have the phenotype, they could be carriers. So if you have a child with spinal muscular atrophy, you probably want to extend cascade testing to the parents, then to the offspring. The ones in red would be people I would encourage to get testing now because they're still in their reproductive age, right? There's like our partner who's also a carrier, they can get another child. These other ones who are young probably need to wait until they are 18 to consent whether they want to get carrier testing or not. And the young girl is an adoptee, so then she doesn't qualify because she's not biologically related to the family members. So this is a survey we carried out also as an MA thesis this year, where we sampled 190 physicians and trainees. So what I would like to point out, most of us are seeing genetic patients in our clinic, about 80%, right? And 73% of those sampled felt that there is need to incorporate genomic medicine into their practice. However, only 13% of those sampled had training in genetics outside embryology, which is pretty low, and it's something probably we can improve as KAP to give our members that, right? And then the last one, only 7% had performed carrier testing in parents of a child with a confirmed genetic disorder, right? So that if we improve genetic uptake, perhaps we can start changing the outlooks of our patients, because genetic disorders are devastating. Recurrent genetic disorders are absolutely devastating. If we can alter that in any way, we can start making a difference to our patients. Thank you very much.
Check.
Thank you, Dr. Ilovi, for that interesting presentation. I mean, I didn't know what to expect, and I'm sure most of us are quite impressed. So Rosie here has a question for you.
First of all, thank you very much for agreeing to come for this symposium and be our first presenter. That was an excellent start to the symposium. I have a couple of questions, like pertaining to this last lady, the mother of Graves. We hear a lot of mothers who have given birth to children. They have up to 5-6 miscarriages and they're still coming, but they can't afford. So there's the issue of cost, because you'd want to do that for the mother, but she can't afford. But on the other hand, what if she doesn't want to do it, but you as the clinician want her to do it? That's one question. The second one is, I think from a policy point of view, if I am the one sitting in Ministry of Health and I want to introduce the concept of genetics, I mean, it's now here with us. And it has, there's a lot of gray areas in terms of like the father whose son, the son sued because the father was tested and you have never seen that child. What are the implications then going forward for the healthcare professionals? Because I cannot be sued for someone I didn't see. And we do, like say, ECGs on so many patients. So the concept of someone is suing based on an abnormal ECG. So it's introducing a lot of possible litigation, which I think would be quite tricky. My final question, I promise. You mentioned about like say monogenic diabetes for our patients. Majority of our patients, I can tell you in my practice, I come and the father is seated by the bedside, he has diabetes, his brothers, his sisters and all. If you tell me that maybe I should introduce that into my practice, what are some of the key things you'd want me, what would be the high index of suspicion that I'd say maybe in this family, perhaps we'd need to consider?
Okay. Thank you very much. So let me start with the last question, right? So what pointed us is that most of them had type 2, like you're saying. So it just comes down to family history. And for us, a family history is a pedigree. So what I've found, rather than saying, oh, you have two, because those children who had gotten it at 17 and 10, actually one was 13, now one was 18. So when did it start? So it's just starting to be open that it tends to hide, because if you look at any extended family, there is quite a bit of diabetes, some more than others. So it's just going back to family tree and not just nuclear family. It forces us to extend to extended family. So it's just taking time and looking for it. The first question you asked, cost is a big issue on genetic evaluation. In fact, it's a stumbling block for quite majority of our patients. We hope as the technology it's actually becoming cheaper, because as it's being, people are recouping their money. It's what it was costing 5-10 years ago is not what it's costing now, but it's still a hindrance to quite a number of our patients. If somebody doesn't want to do testing, and that's why I enjoy being an adult physician. Most adults are allowed, I mean, adults of sound mind have a right to self-determine what they do for themselves, right? So that for that lady, what might be a stumbling block, because recurrent pregnancy losses for somebody who's looking for a child is very devastating. It's highly unlikely she'll refuse to do the test. What might be the limiting factor is perhaps cost, right? If she's having fears, there might be something else. Maybe it's starting to confirm a family history.
It can break a marriage if they discover.
It does. That is, it's not it can. A lot of times it does, because now it starts, this is not, it didn't come from me, it came from you, right? On your side of the family. So there's quite a bit of unpacking to do with genetic disorders that goes around. The middle question was on policy, on being sued. So why I highlighted those cases is just to tell you what is out there. Litigation is not limited by geographical boundaries. So that what has been accepted in another jurisdiction can very well apply to you, as even if it's the first case. So it's just to tell you that it has to extend. So perhaps as physicians, it's good to document. You tell them this is good, and it doesn't just end with you. You need to discuss with your blood relatives. They also, so that people are aware. Then at least you've done your part in relaying the information that, because what I've seen, if I'm fine, let's say like the child with spinal muscular atrophy or an autosomal recessive disorder. So people tend to think it's a new disease. So it's sporadic, right? So just conveying to people, it could be running in other people, it just hasn't shown. So the risk of recurrence is quite high. So it's education and leaving up to people to decide what their destiny will be. I don't know how we'll approach.
I don't know that we have another question from the audience before we go online. Yeah.
Thank you, Dr. Ilavi. Mine is a comment. Number one, we in the gastro field, in the public sector, we get a lot of people who want to be tested for everything. And they tell you cost is not an issue. Test me for everything. Most of the time, there are people who suffered a devastating loss. Yeah. And they tell you, nataka treatment for cancer. If you give them a bill, whether it's 1 million, 2 million, they will pay, especially from the northern part of Kenya, tribe withheld. I wanted to ask, number one, what is the ethics around that? Because we can say we will test you for everything. Some of them have heard of PET scans, others have heard of genetic testing. So that's my first question. Secondly, my comment is when you're doing these genetic testings and genetic counseling, you need a psychologist, because at the point of which you work, it's very sensitive, especially in our community. You're breaking marriages, probably. No, you're not breaking marriages, but they may inevitably break, or families. So perhaps a multidisciplinary approach. I'm sure you do it, but just from your presentation, I thought that would be an important addition. Thank you.
Thank you very much for that comment. I completely agree with you. It needs to be multidisciplinary because it goes far beyond the science of medicine. When it regards to test me for everything, when it comes to whole genome sequencing, whole exome sequencing, I will not do it because we are bound by certain criteria, because we know the pitfalls. So that if somebody came to me and told me, because I've had people who have done it, I've seen cases. So people are not even doing it for their newborn children, not targeted, because newborn genetic screening is there. It looks for certain genetic disorders. So some people are doing whole exome, whole genome for their children. I would not requisite without a clinical indication, because we know the pitfalls. So that if somebody brought me results, because somebody has brought me results for whole genome, I will interpret, but I will not ask, because when I'm asking for a test, I see, okay, you have this, we can do this, right? Our clinical guidelines currently tell us we probably don't want to do whole genome sequencing on a child, because you're possibly testing them for disorders that they might live and opt out to. And one of the, let me give Huntington's, it's a devastating disease, so that when they offer it to somebody, your family has Huntington's, only 20% of at-risk relatives agree, because there's nothing that can be done. So it's felt if parents make decisions for children, they are removing the option of that child saying, I don't want to know, I want to live my life. I'll meet that fate when I get to 50. So that whole genome, whole exome, for me, I wouldn't requisite it unless there's a clinical indication. I don't know how to access the online.
Sorry?
How will access the online question?
Oh, yes, I have the online questions. So I'll ask 2 questions before we close the session. So one of the attendees is asking, how do we deal with intermarriage between first cousins in terms of genetic testing? And the other question is asked by Anthony Wanyoro. He wants to know, in normal circumstances, you want to test for a condition you can treat. Please comment on testing where treatment is currently out of reach to the persons being tested in low resource settings.
Let me start with the first one. So genetic disorders, quite a number of them, we can't treat them, right? Vast majority, right? But it's not only treatment that we are looking for. It helps us cascade testing to other family members. It helps people plan their reproductive choices. It helps people understand. Again, it's people to make a choice, because like if you have a patient with a heritable cancer syndrome, finding a germline mutation will not change how you manage, apart from maybe TP53, but it will not alter. So it's for people to say, do I want to know, so that my family can understand what is at the at risk of. Consanguineous unions predispose people to a slightly higher risk of particularly autosomal recessive traits. So that is one of the things we look out when you're taking a genetic evaluation. So that even when you read a paper that is written about a child, there are only 2 kinds of coupling: a child born to a consanguineous union, a child born to a non-consanguineous union. So it helps us understand the risk of what could be ailing this child. So it's just something that we have to note. And there are definitions of what qualifies as a consanguineous union, what doesn't, because there are scientific reasons to why that might be clinically relevant in terms of genetics. I hope I've answered the questions.
Thank you very much. A round of applause for Dr. Ilovi.
Thank you. Thank you very much for having me.
So next, I'm going to introduce Dr. Eugene Genga, who was my classmate in undergraduate. Incidentally, all of us seated on that table, plus Rosie, were in the same class. So I'm really happy to introduce him. So Dr. Eugene is a lecturer at the Department of Clinical Medicine and Therapeutics at the University of Nairobi. He's a physician, rheumatologist. He undertook advanced training in rheumatology at Aintree University Hospital in Liverpool, as well as in India. He further went to complete a 2-year EULA course in rheumatology. Beyond medicine, he's a basketball player. He played for the national team in the year 2007 to 2011. He's also played for Corp Bank as well as the Kenya Premier League. And he was also captain of the University of Nairobi team, which was called Terrorists. Beyond all this, he also runs a student athlete program. Welcome, Dr. Eugene. Thank you.
Thanks, Irene, for that kind introduction. Actually, my talk could be more of a follow-on to what Dr. Ilovi has said in terms of in lupus, and a lot of the stuff will be around genetics and how we can improve outcomes for our patients. Let's get from that. Okay, thank you. So I was given an interesting topic on updates in lupus. I thought I'd rephrase it into look at what are the current trends in how to manage your patient better in terms of how to achieve a low disease activity. So I got this meme from one of my classmates, Grace Wamba. Apparently, there's rheumatology lab with a lot of steroids. And I hope by the end of this presentation, probably have changed our perception of rheumatologists that we don't just do many tests and put patients on steroids. So the first slide, when we look at lupus, we have a lot of unmet needs in terms of lupus management, partly because our targets are not like the diabetes, which is very straightforward, sugar, hypertension, the same blood pressure. So in terms of lupus, we try to get our patients what we call low disease activity or remission. Unfortunately, in practice, it's not as easy as said than done. And actually, we have a lot of our patients who tend to have high disease activity, and this has led to a lot of issues in terms of mortality, organ damage, a lot of steroid use, and poor quality of life for our patients.
Sorry, Eugene is a bit too tall for this, whatever was.
Thank you. So what's the impact of all this? When you look at, these are scores we use in rheumatology for lupus. The BEAL score looks at disease damage, and SLAC looks at disease activity. Longer time to diagnose our patients. Actually, when they come to diagnosis, tend to have a lot of disease activity with the SLAC score, but also damage that is already there prior to even starting on treatment. So what is the situation in Kenya? I've done a few studies here and there. mainly in Kenyatta. The time to diagnose is still long, 0 to 13 years. We're still not doing the best. But in terms of, if you compare our data and what's out there in terms of presentation, it's largely the same. It's largely female in the reproductive age group. And generally, most patients, our profile will be a young lady who presents polyarthralgia, hematological, and cutaneous disease. In terms of how we are doing, we're not doing the best, partly because our patients come a bit late and they tend to have a bit of aggressive disease. One of the studies done by Nyambane a few years ago found that 50% had moderate to severe disease, which is a lot. Quality of life is also impaired. A lot of our patients tend to have a lot of pain, fatigue. The scarring from the disease tends to really affect the body image and all that. In terms of medicine, a very interesting quote she did from a study was that we tried to compare patients who had renal disease, patients who are in the nephrology clinic, and those who are primarily in the rheumatology clinic, and ensure that we don't have teamwork, because some of the medicine are actually different in terms of the patients who have renal disease in the kidney and those who are in the rheumatology clinic. So in terms of diagnosis, I'm sure you've seen this before. This is the latest that we're using right now. Over time, we've tried to refine the diagnosis. I think when you're an undergrad, the ANA cutoff was about 320, and then master's 160, now it's 80. And the reason is because we're trying to catch our patients early. Apart from that, I think we emphasize a lot on the ANA and forget just pure history taking for our patient. Because you can see, if you look at on the extreme right, a lot of it are their symptoms, the joint pain, neurological issues, serositis. You can see the score. If you score more than 10, you get the diagnosis of lupus, even before you get to a very expensive test on the left. So we usually have these kind of patients also, who sometimes baffle us. For example, find a 24-year-old lady, ANA over 100, joint pain, arthralgia. Nowhere on that criteria. Another one, fatigue, which is one of the most difficult symptoms managed as a rheumatologist. ANA 1 in 80, borderline. What do you do for that patient? The sad cases are a para 0+2, very asymptomatic. You do the antiphospholipid panel, everything is negative. What happens to such a lady? Another nascamu just ANA 1 in 160, photosensitive dermatitis and fatigue. As you can see from all this, how to put and classify these patients becomes a bit of a challenge. So this is a very nice paper that was done a few years ago, and basically showed us that a lot of our patients who tend to have SLE tend to have these antibodies prior. And so this can go up to 10 years prior to diagnosis. So I think having the positive ANA earlier, the thing would be, who do we monitor? Who don't we monitor? That would be the question, because if you don't monitor the patients closely, what happens is that they get the full-blown disease and tend to have the complications later. So in terms of how we classify it right now, things are a bit different. We have a new group called undifferentiated connective tissue disease. And this will lump most of these patients who have 1, 2, 3 symptoms that don't make sense, an ANA, weakly positive. And generally how the flow is usually that either they will proceed to form the full-blown disease, for example, lupus, scleroderma and everything, they may remain stable as undifferentiated, or may just actually abort. And actually what happens, the resolve and everything gets back to normal. So in terms of predictors, a very nice study here done by Dibal, and there's actually a meta-analysis of about 49 studies, and they're looking at just patients who had undifferentiated connective tissue disease, and what they're trying to see is to predict who most likely develop a connective tissue disease. And they picked 2 things. They picked SLE and they picked scleroderma. And the SLE have a young age, serositis, positive double-stranded DNA, most likely may evolve to SLE. So in the moment in these patients, that's some of the things you should be able to advise your patient. Scleroderma, Raynaud's, something which we tend to underdiagnose, especially in our setting in Africa. Nail fold changes, that in particular can point you towards a scleroderma. So in terms of what percentage, usually that's the question, because sometimes you get these ANAs that don't make sense. So I think the take-home message from this particular slide is that an ANA without symptoms means nothing. An ANA with symptoms, you must be able to pick who to follow, who you can reassure, but also advise the patients. And what I tell my patients is that, yes, you may not have everything right now, but if you develop 1, 2, 3, 4 symptoms, come back. Okay, and remember that actually from a very nice study that was done here, they've shown that actually 30% of people may actually develop persistent symptoms. So we actually have a very interesting classification, something called incomplete lupus. I came across it the first time when I attended some Nigerian conference and somebody came with something like this. And actually, it makes sense for some of our patients. For some of our patients, you don't know what exactly to do with them because they have some symptoms, they don't have symptoms, Anna is here, not there, what to do with them. And also, like you've seen, some of the antibodies can come prior to the full-blown disease. And actually, 55% of patients actually progress to develop the full-blown criteria. So there have been a number of proposed criteria for these incomplete lupus patients. Basically, a lot of skin issues there, serositis, renal can also help you there, and hematological. So if you have this particular criteria here, it can help in terms of getting these incomplete lupus patients. So like I was supposed to do something on updates. So I'll give something small on pathophysiology. Sorry, I like cartoons a lot. I'm sure we did a bit of pathophysiology in MED. So in terms of the cytokine mostly involved in lupus, who has any idea what could it be? Was it the B pathway, B cell pathway, type 1 interferon, toll-like receptor pathway, interleukin 17, all of the above? Usually a trick, if there are any MED students here, all of the above usually means that's probably the correct answer. Okay, so I'm sure this has been explained in terms of the pathophysiology for lupus. We have girls who are at risk. And I like how Dr. Love has actually put it here, because sometimes you get patients who a family finds somebody has rheumatoid, other type 1 diabetes, another Graves' disease. And now you see that, you know there's something genetic that they have in their blood. The only thing is that we have things that trigger. The trigger is what we don't know. Usually say environment and all, but to be honest, nobody can really pinpoint as what happens. Then we have the breakdown in autoimmune regulation such that we have damaged DNA. We're unable to clear it. What happens? It sets off the inflammatory cascade, and then bam, we have the what? The symptoms. But the question is, who knows who these guys are? James Bond, isn't it? So for lupus, for those who see lupus a lot, no lupus looks the same. You get, so as much as the pathophysiology is the same, why do they all look different? Some people come with joint issues, others skin issues, others just kidney issues. So it means there's more that we are still trying to do what? To understand. So one particular pathway that's come up big in terms of rheumatology is the interferon pathway. In terms of the autoimmune, any autoimmune disease, interferon really plays a very, very big role. And actually, the signatures are actually high, up to 80%, which is very high. And what does it do in terms of lupus? They found that having high interferon levels actually leads to increased disease activity, severity. All these things that you see here, all associated with the interferon gene. So the question would be, what does it do? So it's like the conductor. It connects the innate immunity. It connects the adaptive immunity. The innate immunity is where we have the natural killer cells, the monocytes, the cells of the inflammatory cascade. The adaptive immunity don't have the antibodies now. The double-stranded DNA and all those things that eventually end up depositing on the skin, on the kidney, and cause the damage that comes with lupus. So they've actually found research that's showing that actually when they have a lot of interferon levels, patients tend to have more skin issues, more kidney issues, more brain issues. So you can see we're getting somewhere in terms of trying to see how we can differentiate to see who gets what. Actually, we have some medicines available. It's a very new drug. It's a new molecule. It's called anifrolumab. Actually, has been very useful in terms of lupus. It blocks the interferon pathway. And actually, patients are doing well. And for us, well, in rheumatology is, one, you reduce the flares. Two, control the disease. But more importantly, steroids, which I come back the first day, which I said, a lot of people think we use a lot of steroids. We want to use as less steroids as possible. So another thing which might relate now to Dr. Ilov is because we've been wondering what really happens in terms of what could be causing the lupus. And actually the toll-like receptor pathway might actually be the key, might be the ground zero, because this is what connects everything in terms of the B cell and also the innate immunity. And actually that's what actually interferon alpha gamma binds to and set off all the inflammatory cascade. Why do they pick on the toll-like receptor pathway? Usually the question would be, where is lupus more in ladies? I know we usually say hormones and everything, isn't it? But actually, they've done some studies whereby we think that the X chromosome may actually be the key. And actually, if you look at patients who are like male patients who have Klinefelter syndrome, if you compare the risk of SLE, because of XXY, with the ladies, actually the rates of lupus are almost the same. And actually, the toll-like receptor and the toll-like receptor 7 is actually located in the X chromosome of these patients. So what happens is that we usually have autoimmune. The autoimmune is actually coded on the X chromosome. So what actually happens, we have an inactivating gene that inactivates the autoimmune. So what usually happens is that the X chromosome on one side will stay, and then you get a balance with the Y. So when you are unable to inactivate that particular pathway, what actually leads to is that we have the toll-like receptor pathway there, and eventually have the what? The lupus developing. So the question would be, are there drugs that target? It's actually what they're working on to see if they can be able to get some drugs target that particular pathway. Another pathway which has been followed is the B-cell pathway. The B-cell pathway is where we have the adaptive immunity with the antibodies and everything. And actually, there's a lot of neural involvement there, high disease activity, flares. And actually, we have medicines trying to target those pathways to see if we're able to reduce the impact they have on lupus. When you look at the B-cell pathway, we have two ways to look at it. One, we have the short-lived B cells, and two, the long-lived B cells. So the short-lived B cells, we have the double-sided DNA. And actually, for us in rheumatology, we use the double-sided DNA to correlate in terms of flares. And it actually makes sense because actually that's more the short-lived. For patients who have more severe symptoms and have the long-lived plasma cell, that's why we have the neutrophilic path and everything. And that's some of the things which have always perplexed us, because you find a patient A will do well, patient will do well, but actually we've not been able to differentiate. And actually, until we discover this, that there's double standard and there's ribosomal. So the ribosomal part of people are trying to see how best we can fine tune that, because that is actually the key for some of the resistant patients we have who don't seem to be responding to treatment. So rituximab is a drug we know well, targets B cells, has been tried in lupus. Unfortunately, first line hasn't been the best, partly because some of the studies, to be honest, the design wasn't the best. They didn't do a good job there. So what we actually use rituximab is for refractory patients who don't seem to be doing well on the normal standard treatment. That's when we use the rituximab. Belimumab is not available in Kenya. It's something which is useful. It targets the B lymphocytic pathway. So that usually belongs to the TF pathway, and usually is useful for B cell maturation. So if you're able to target that, you'll be able to prevent the maturation and the antibodies and all that. So this has also been tried a lot, especially in the lupus nephritis, and the results are good. The only issue with the belimumab is about they get a bit of psychosis, so you have to be aware about that. Yeah. Another drug that's been tried is, it's a very long word, obinutuzumab, but mainly in the kidney. As you can see, B cell pathway is really involved a lot in the kidney lupus. And actually, most of the drugs that are targeting have been tried in the lupus nephritis range. And actually, when you use this particular drug, patients are actually done well. It's yet to be licensed. So hopefully the next 1 or 2 years, it will be licensed. Another pathway which has become something very important to us is the interleukin-17 pathway. The interleukin-17 pathway has a partner. The partner is interleukin-23. So they usually work together, and that usually has been found that maybe markers of progression for kidney disease, and potentially maybe a biomarker for diagnosis, disease severity, and even predicting response. So I think going forward, it looks like maybe if money is available, we'll probably be doing the markers to see which one you have. If you have interferon, give this drug. If you have more the B cell, give this drug. So something which going forward, which I think would be great for our patients. So I think I'll skip this one. This is an interleukin-17. It's still under review. So the next thing is lupus monitoring. Lupus monitoring is very tricky. I'll give you a true story. I had a patient, when you have lupus patients, they're very interesting. They get well, they disappear. And then you get a call one day from casualty after maybe a year, and the patient is saying, I'm under Dr. Eugene, and you're trying to remember who the patient is. So the patient has come after a very long time. So, doc, I'm okay. I said, okay, no, that's fine. Anyway, there are these tests that the Zungus have said we should be doing every 3 months to confirm that everything's okay. Okay, doc, I'll do them. So, as usual, the tests are taken outside Kenya, and then they're brought back. So a day prior to the test coming back to Kenya, I get a phone call. Oh, doc, my hair is falling off, fever, I've lost weight. So I was wondering, in the space of 1 week, what could have happened? So I think the take-home message is that actually from this particular case, we really need to do a lot of the disease activity tools. Sometimes this thing that Mama Kusawa, city management. I think it's a thing of the past because the tools are very good. Like the standard score is a very good score. And I think going forward, that's what we should be doing. Apart from that, the disease damage scores, the SLIC index, we have quality of life scores that can also be done there. Flare index is also there. So I think going forward, this is how we are if we're able to use these particular scores, we can be able to improve our outcome for our patients. So ultimately, the goal is to reduce damage. And actually, a lot of the damage occurs within the first 5 years of treatment. I'll give, for example, I had a patient who presented with neuropsychiatric form of lupus. Actually, was in a psych ward. She had been labeled schizophrenia. I think Rosie might remember her, but she had a persistent anemia. So because of the anemia, they called Rosie with the physician, just to Anna. Anna comes back what? Positive. I'm called in. Of course, you can't take a history because she's psychotic and everything. We work backwards, you do the double standard, everything is lupus confirmed. We give her cyclophosphamide. So unfortunately, ever since we've managed that, she got well, she went back to work. Her disease activity level has been what? High. She has a lot of admissions, kidney issues and everything. And I think it just goes to show that actually, if we had caught our patient a bit earlier, to avoid these things. And I know something very interesting, I'm sure Rosie and Eric will be happy. 80% of the damage from steroid use. So we are really trying to avoid. I know we use this thing, steroids. We are trying. So usually the question is now is the balance. A patient has come with a flare. Unfortunately, our medicines don't work immediately. For example, like MMF, HCQ, what 3 months start working, it's not immediate. So what do? The patient is in pain. So it's a delicate balance. Do you give steroids? Do you give steroids? That usually is the what? It's the question. So these are some of the things that you have to juggle with to give. So usually, in terms of steroid, from the research on the rheumatology side, we like doses around 6 and below. From that on, the damage is less, cardiovascular issues also less. So we usually like 6, at least 10, 6 and below is actually okay for us. Another question which I usually get a lot. I remember for a long time, I used to wonder, this pulsing that we usually give for our patients, sometimes you see pulses of 1,000 milligrams, 500 milligrams. So the question would be, what is the rationale? Because if you look at the studies, the difference between 500 and 1,000, not much in terms of efficacy. The only thing is side effects. Difference between 250, 500 are almost the same. 125 a bit low. So I remember like the first time when I started prescribing 125 milligrams for pulsing, a lot of girls wondering, why is it getting? But actually, it helps a lot in terms of for this patient. So ultimately, like the takeaways from this slide is that we should be able to categorize our patients, mild, moderate, severe, and at least anything above 500 may not add value to your patient. So in terms of quality indicators for care, you must every 3 to 6 months at least do the lab tests, do the scores. Remember, they also have cardiovascular issues. Apparently, rheumatoid, even SLE, is the same cardiovascular profile with diabetes. So we've been told that we're very lazy rheumatologists, so we really need to be up a game there. So we're really trying there. In terms of damage scores and everything, something which should be done regularly as possible. So in terms of what is a suggested plan for monitoring our patients, the scores are there, do them regularly. Blood count, the labs should be done. C3, C4, it's a bit expensive, yes, but helps us a lot in terms of lowering flares, but also how the patient is doing. Annually, quality of life and the disease activity and the damage scores are also very important. DEXA score, again, back to our endocrinology. See, we're not bad guys. I know they always think we steroids a lot, but we also try to look for DEXA scores for our patients. So this is how a SLEDA calculator looks like. Yes, no, and all that. You can Google, so it's okay, I'll skip that use of time. So in terms of treatment, again, like I back to my first slide, we did a lot of steroids. We are really trying. And actually for us, if you are on the lowest amount of steroids, we're happy. And ultimately it's long-term survival, prevent damage, and quality of life. Our patients have a lot. Quality of life is what is the most important thing for our patients. So, in terms of priorities for our patients, this is a very nice study that was done in the States. They tried to look at treatment satisfaction for our patient, for the patients with lupus, and there are different treatment modalities. There's some on biologics, some on steroids, some on DMARDs. And very interesting, the fact that the patient view, what they thought was very, very important to them was fatigue, which is the most annoying symptom for us doctors because we don't know how to gauge fatigue. Is it 10%? Is it 20%? And ultimately, the best treatment is what? Exercise. Ultimately, they don't like hearing, but it's actually what? Exercise. Pain is important for you because pain, there's inflammatory pain, which is lupus, and there's non-inflammatory. They tend to get a lot of fibromyalgia. So sometimes before you up the doses for the DMARDs and everything, you must be able to differentiate the two. Is it inflammatory or non-inflammatory? Flares. Flares means that they end up not going back to work immediately. Especially if you've been in hospital like 3-4 times a year, it can be a lot. People lose their jobs. Bosses get bored of it because every time you're on what? You're in hospital. So as doctors, that's some of the things you should look into in terms of our patients. So question usually for lupus is, people have been saying that we can actually go for low disease activity rather than remission. And they're saying it's okay to be what? Mediocre. But for us, our definitions for low disease activity would be a very low disease activity score, less than 4, no major organ activity, no new disease activity, steroids, very low dose, preferably less than 7.5, and only just standard maintenance for immunosuppressive. For remission now is a bit different, hopefully no steroids. Hopefully no steroids, and probably just on an antimalarial. But getting to remission is not the easiest of things because for our patients, they go through a lot. And sometimes you may be too aggressive getting to remission and affect also their quality of life. So that balance becomes a bit of a challenge. So when you look at our patients, remember that quality of life is very important. Because, for example, like fatigue is so hard. I don't know about, sometimes I wonder I did rheumatoid because fatigue is difficult to assess. That one is difficult. And that's the biggest thing they have, fatigue and brain fog. And how to objectively assess these patients, help this patient becomes a bit of a problem because you on one side, you are thinking, there's no lupus nephritis, there's no arthritis, and the patient, no, I'm okay there, but I'm tired. So it becomes a bit of a balancing act. So whatever we do, that we should be able to factor that in. So in terms of why we're insisting on at least low disease activity, we lower the risk of damage to our organs, that's one. 2, lower rates of mortality for our patients and better survival. So we're really pushing for low disease activity for our patients. So some studies have been done to try and compare low disease activity and remission, and they've actually found that patients who just spend longer periods on low disease activity tend to have better outcomes rather than rushing to remission. And remission, to be honest, the numbers are normally very, very few. So how do we get there now? So we start with this approach. In the ideal world, I wish it was like this, but it's never like this, that every 3 months you assess, you go down like this, but rarely it's like that. So, but ideally is how to want for our patients. So some principles from EULA, that one, patient education. Sometimes you spend so much time prescribing medicines, and the patient comes and tells you, I have no sunscreen. And you're wondering, I'm not talking about what? A sunscreen. And sunscreen is very important for our lupus patients. Vaccinations are also very important. We need to talk to our patients about those things. Balanced diet, usually they come and harass me about the best diet and all that. I just tell them, just don't add weight. Just keep it as simple as possible. Education is also important because some of the medicines we give for our patients might be either teratogenic. For example, I'm planning a pregnancy and not putting methotrexate. I remember when I went to study, it's the first time I thought about cyclophosphamide and ovaries. Was the opposite. You know, when you're the renal unit, we just used to give. But nobody used to think about what are the repercussions later. You give an 18-year-old, an 18-year-old, and then you never tell them that, you know what, there's a chance that this might do this and that. So this is something we need to talk to our patients. And ultimately, early diagnosis is the best. So this is the current treatment regimen that we have. So we divide into mild, moderate, and severe. All patients ideally should be hydroxychloroquine. All patients. They've done some studies trying to see if they're able to withdraw the hydroxychloroquine and see the response. Actually, they did a study where they compared stable patients. And so some were taken off the medicine, some continued the medicine. And then they followed them up for about 2 years and to see how they would respond. And actually, they found the girls who were taken off the medicine tend to have more flares. So right now, the takeaway is that as much as possible, unless they're allergic, they should be on hydroxychloroquine. The other drugs are add-ons, depending on the patient has. For example, if it's a kidney issue, mycophenolate. If there's joint issue, methotrexate can be used. Planning pregnancy, azothioprine can be there. If you have resistance, you feel the patient doing well, you can add now the biologics, the belimumab and the avelumab and the rest. And remember education. We always forget about what? Education. Never forget about that. So lupus nephritis, I think I'll skip this, a bit of a lengthy one. So outlook for the future. So a few months ago, I had a very interesting I had a very interesting story whereby somebody was saying that somebody got cured of lupus. And I was saying, oh, interesting. Of all the diseases, why lupus is interesting, because over the last 50 years, the number of new drugs haven't been many. If you compare lupus, rheumatoid, diabetes, pressure, the medicines are not that many. So the fact that they were able to achieve a cure was very, very remarkable. So what they did, some German scientists, they found a lady who had just severe refractory lupus, who was not doing well at all. She had everything. So they put on this treatment. And interesting enough, it's not that clear, but her scores went well. The C3, C4, which was initially low, actually improved. Disease activity scores went down, and actually is off medicine for the last, I think, now 3 years. So you can see there's a lot going on. So what did they do exactly? Back to what Dr. Lovi was saying, the CAR T cell therapy. So I think we are related with Dr. Lovi. So what CAR T cell therapy, what they do is they remove, in a summary, they take your T cells out, go insert some gene and prime it. Afterwards, they grow many of the T cells, and then now they reduce your immunity in your blood, and they pump you back the T cells. Now the T cell goes in there and targets out the B cells and everything that's causing the lupus. And actually, patients are done well. And actually, there are studies, there's some papers there, I think I saw 5 guys, and all have met the DORIS criteria for remission, no low disease activity. So this is some good news for our patients. The only drawback, I remember I attended one of the webinars where the guy who did this, he said that once they gave the CAR T cell therapy, actually they discovered was that he was talking to his colleague, and then his colleague is an immunologist who gave him the day of the CAR T cell therapy. So when they gave, the lady improved, the German, she developed some fevers that are not making sense. Fever. So I get to him, she just do IL-6 levels. Then did the IL-6, and actually it was high. So they gave her tocilizumab and she had to improve. So one of the issues with the CAR T-cell therapy is what? IL-6. But the major hindrance is the cost. Cost is astronomical. It's about 60 million shillings. I don't know how many guys can afford that, but it's a lot of money. Yes. So a very interesting question I get harassed for in the clinic is, can you prevent lupus? So I came across a very interesting paper where they followed up those many women for about first to see who developed lupus. And they looked into a couple of factors. One, how much alcohol they were taking, BMI, if they're less than 25, smoking history, diet history, and exercise. And actually they found that if you're able to follow a healthy lifestyle, you're able to do what? Prevent what? Lupus. So I think that's something which you can able to tell to our patients who maybe have a feeling that the family member has lupus and everything, that actually just their normal healthy lifestyle should be okay. So as we are finishing, as in we grew up in a very bad era. We were many guys here where we used to have multiple choice questions whereby every option was an answer. So you're told the following are true, and A, B, C, D, E. So if A is an answer, B is an answer, so everything. So in short, if you miss the answer is minus 0.5. If you get the answer is 1. So in a question, you can get minus 2.5, or you can get 5. So really, they're saying there was no guesswork. That was the take-home message. So the same as lupus, because over time, to be honest, we started with a lot of guesswork, to be honest. But the challenge about lupus is that no two lupus are the same. From the immunology, how they present. So getting one drug that fits all has been a challenge. The CAR T-cell therapy at least offers hopes to our patients that hopefully that something will come soon. So, and I think back again to what Ilovi had been saying here, the genes. The genes might actually play a role in how to do what, how to target our patients. Again, the gene therapy, like I attended some BSR conference earlier this year, and we were high on gene stuff. Gene. I think it's the way for the future. So is there hope for our patients? Yes. Just being patient. Thank you.
Thank you, Eugene, for that very interesting presentation. And as from the diabetes world, we are happy to hear that you're really trying to reduce the use of steroids. We tend to see a lot of side effects of steroids, even while I work in Kiambu, because there are patients who go for monthly steroid injections for their arthritis, and they really look forward to those clinics, and they're very busy. So as we take the Q&A, I would like to invite Galaxy to set up. I don't know that we have any Q&A in the audience. Yes, Rosie.
It's interesting that you talked right after Ilovi and then you've mentioned Ilovi throughout. So are you then advocating that for patients who, like perhaps you see someone has lupus in another family member, they have another autoimmune like thyroid, they have type 1, they have type 2 diabetes and all. Are you then saying that these are families that perhaps we should screen and maybe send for genetic testing in terms of, because we're saying that the later we diagnose, the worse of the prognosis. So would you advocate for that? That's one. And then number two, as an endocrinologist, I know you're trying to reduce the dose. My question is, what's the average length of time when you start your prednisone? I find people coming 6 months down the line. Admittedly, I don't do your SLEDAI scores to see quality of life and all. But if they're responding well to the other medication like your HCQ or MMF, shouldn't they then be withdrawn? I'd really like one of your take-home messages be, I mean, at what point should you withdraw these steroids and then allow for the ultimate medication for lupus?
So I'll start with the first question because I usually get harassed in the clinic about family. Mom has this, dad has this. So usually the challenge you have with the lupus is that a positive test without symptoms means nothing. So sometimes if we advise them to do ANAs, it'll just be hysteria in the family. And actually it doesn't make sense because if you don't have symptoms, it shouldn't have an issue. So what I tell the patients that if you've noticed you develop the following symptoms, get tested as soon as possible. In terms of the genetics aspect, we still don't have enough information, but I'm sure the next few years, because now that we've identified the toll-like receptor, we're getting there. So in the amount of time, but we're getting there. In terms of number two for the steroid, steroids are very interesting. Actually, there's some data we have in the rheumatology world whereby some patients we may not be able to completely get them off the steroids, completely. We get them off, they get the flares. We get them off, they get the flares. But ultimately, the way we would prefer is there be no be steroids. But usually, we want, because the challenge you have with our medicines is that they take such a long time to start working, 3 to 4 months. So we want at least within the 3 to 4 months that they're off the steroids. So they start high. By the 3rd, 4th month, they should either be on the minimum, which should be less at 6 milligrams and below, or off the what? The steroids. The problem is that our patients are normally cheeky. And like what Irina said, they can't wait for the clinic to get that high. They get deep profiles and everything because they would prefer to take the injection because the injection is a quicker response. They don't the long story. You know, like I tell the patients, like for your treatment, it's like a movie. And a movie, you'll have to start from the start to the end. And the whole movie, you can't fast forward. So them, they want the quicker what? Response, which is the what? Which is the steroids. Yes, you have to start from the beginning. Thank you.
Okay, let's go online. I'll just take 2 questions in the interest of time. So there's someone who wants to know about lupus nephritis and how and what is the best treatment. And then there's another question. If you're a medical officer in the rural facility, how do you start SLE medication? Like what will you do in a rural setup where you don't have access to a rheumatologist?
Yeah. So I'll start with the easy one. Actually, the easy one is the lupus nephritis. So for for lupus nephritis, we'll have to stage the patient. So ideally, all they should all be on hydroxychloroquine. That's one. Hydroxychloroquine actually primes and makes it easier for the drugs to work. 2, where necessary, preferably they should be on a mycophenolate. A mycophenolate, the challenge with mycophenolate is the dosing. Sometimes we're a bit cautious about the dosing. We start, usually the maximum is 2 to 3 grams a day, but you can slowly do what? Escalate. If they're not doing well, you have the options for the belimumab and the rituximab. Those are the options. But ultimately, biopsy is something which we really push forward for. A lot of biopsies. That helps us staging the patient. In terms of management, management of lupus, I think it starts with, first of all, getting the diagnosis, right? That's one. 2, it depends where actually our numbers are not many, but we have colleagues around. So we have again Kisumu, there's Charles, there's Beryl in Eldoret, Mombasa, there's Sophie is in Mombasa, the rest in Nairobi. Most of us are reachable by phone. But nobody can actually get the patient. I think the first thing is to stage the patient, mild, moderate, or severe. In the mild cases, HCQ will just be enough. If you have moderate to severe, preferably refer. If they can't come, between the two, I know mycophenolate is not readily available and has cost implications. The mycophenolate, the dose is like 80 bob, 90 bob a tablet, which may not be accessible to most people in the periphery. So methotrexate can be an option for those patients, yeah. But preferably at least work hand with the local physician or at least a rheumatologist, yeah. Thank you.
Okay, thank you very much. Before we move on to the next presentation, sorry, a round of applause for Eugene. Thank you. So before we move to the next presentation, we'll have our sponsors. We start with Galaxy and then we'll have Sun Pharma.
Yes, good morning. I'm Thaddeus from Galaxy Pharmaceuticals. I'm going to present to you some of the medications we offer to manage some conditions. But before I do that, let me present to you briefly the history of Galaxy Pharmaceuticals. We began the company began like 25 years ago. We are located in Parklands 3rd Avenue. We're in Doctor's Park, building first floor. We have branches in Mombasa and Kisumu, and our main branch is in Nairobi. What I'm presenting to you this morning is medication for the management of some of the most, should I say, dreaded conditions, that is high blood pressure and diabetes. Each of us in this forum knows that the statistics for high blood pressure and diabetes are staggering. And we know high blood pressure and diabetes are actually categorized as the major conditions of mortality worldwide. So I'll begin with presenting to you a brand of telmisartan.
Canada, and he says that he's had annual pain, and the annual pain has been constant. I mean, it's been there for 3 years, so it's worse on defecation. He denies constipation and wishes to have a routine colonoscopy. So he brought himself before traveling back to his home countries. So I'd like two opinions. What do you think about this? And please be broad. I know the topic is hemorrhoidal disease, but how would you approach this patient? And since we have residents from KU, and maybe other residents, Dr. Kinoti, what do you think? Yes, diabetologist. So hemorrhoids, anal carcinoma, good. Abscess, anal fissure, Crohn's. Wow. Dr. Eric, bringing the genetics. Okay. Yeah. Okay. Thank you very much. Those are excellent questions. So history, physical exam, differential diagnosis. I don't know, maybe it's me, but I used to have a mnemonic in postgrad mostly. Vindicate, vitamin D, vascular, inflammatory, neoplastic, degenerative, they all apply, yeah? So we went on to examine him and he had large external hemorrhoids. Remember, as you're examining, there's something called bottleneck, where if you see something, your mind goes towards it. Yeah. So you need to be open-minded despite what you see physically, and you need to have differential diagnosis. So he had large external hemorrhoids. That's a picture I got from my presentation, not his particularly, but there were 3 and 7 o'clock. They were quite tender. I was unable to complete the exam, the DRE due to pain. So how do you approach this patient? Number one, we've already talked because of time, history, physical exam, explore the differentials. Yeah. And then when do you go for colonoscopy? Do you really need a colonoscopy in this patient? So before I tell you what happened to this patient, we'll go straight to the presentation. Okay. So I know the presentation is focused on hemorrhoids, but remember, keep it broad. But as pertains today, what are hemorrhoids? And I think most patients, or most even us physicians, you get a bit confused. So I hope from today's talk, we shall be able to explain to our patients better. So if you look to the extreme right, we have a picture, an anatomical picture. And what you can see is that we have muscles, yeah? So we have muscles, then we have mucosa, which is the rectum. And then when we do a cross-section, you'll see connective tissue in between the muscle and the mucosa. So as you can see from my cursor, the muscles make up the internal sphincter and the external sphincter, yeah? And in between the mucosa and the muscles, we have connective tissue, and these connective tissues hold blood vessels. So with those blood vessels, we have arteries, we have veins, and we have lymphatics that drain these vessels and the surrounding tissue. And within this, in between the connective tissue connecting the mucosa and the muscles, we have what we call anal cushions. So what are cushions? So cushions are where we have plexuses within this connective tissue. Yeah, and when we have plexuses which are above the dentate line, these plexuses are in cushions, which we call internal cushions, yeah? So if we have inflammation and we have displacement of these cushions and enlargement of these cushions, we refer to them as hemorrhoids. So above the dentate line, which is also called the pectinate line, we have the internal hemorrhoids. Below the dentate line, we have the cushions there which are enlarged. So they have to enlarge, they have to be displaced. So they are displaced anteriorly and downwards. Yeah, so we call those external hemorrhoids. So as I said, internal hemorrhoids arise from the internal hemorrhoidal plexus, while external ones arise from the external hemorrhoidal plexus. Remember, the division is a pectinate line. Now, another thing is that just below the pectinate line, we have the anodam, and that's where it's rich in nerve supply. So external hemorrhoids tend to be very painful. Yeah, because of the rich somatic supply. But internal hemorrhoids, unless prolapsed, passing the dentate line, usually may go unrecognized. Yeah, so you have patients complaining mostly of bleeding. So what's the epidemiology? So this is data from the West. We don't have much, and I know there's a study done in KNH, but 4% of the US population, and you know US is like a continent, it's like half of Africa. So 4% is quite a large number, and a third of those actually seek medical attention. So we're talking about 32,000 annual surgeries, 1.5 million related prescriptions. That's a lot. If you tell Sun Pharma or the other companies that they're going to get 1.5 prescriptions per year, that's good business, yeah? So it's a big business, and it's also a big burden to the medical care, at least in the West. Men and women equally affected. The peak is usually middle age, but we know we are seeing it in the younger generation, more so because of our diets and constipation. And about half of them seek medical treatment, and about 20% go for surgery, and there's recurrence. So this diagram, as I said, when you see a diagram, try to simplify it. So remember, we have the muscles, we have the mucosa, as I said. So this is just a diagram showing you the blood supply. As you can see on the extreme superior aspect, the top, you can see the superior rectal vein, superior rectal artery, and where there is an anastomosis, where there's this curve where my arrow is where it anastomoses with the middle rectal vein. So the blood supply for the internal hemorrhoids are usually from the superior and middle rectal artery, the drainage from the veins, and the lymphatics follow. Of course, around that, there's connective tissue. I think I had alluded to this. Now, for the external hemorrhoids, it's more of the inferior rectal vein. So you have the rectal, just below the dentate line, also known as the pectinate line. So we have inferior rectal veins anastomosing, but the major supply is from the inferior rectal artery. So when we look at pathophysiology, so most of you who are in undergrad or have just finished school, physiology is normal. Patho is what is abnormal that causes the normal to not work properly. Yeah, so pathophysiology. So these anal cushions are there. They are there because we have plexuses in our body. But when we cause them either pathologically to enlarge, displace anteriorly and inferiorly, then we get pathology. Yeah. So as I said, sliding processes are there. There's deterioration of connective tissue. And of course, whenever we have something enlarged and we have blood supply, we cut off the blood supply and decrease the venous return for these vessels. So there's also a component of inflammation. Now, this diagram is very heavy, but I think Dr. Ilavi and Eugene, Dr. Eugene have actually summarized for me. So remember what they say, there's a very big behavioral and genetic component to these diseases, and not so much in developing hemorrhoids, but the predisposition of the connective tissue around the hemorrhoids, how our plexuses intermarry with each other, and how we are predisposed to getting the disease. Yeah, so hereditary bowel or rectal problems or habits and practices that make us predisposed, those are genetic, yeah? But now there's the environmental component, which helps now that's where we can target, because in terms of genetics, as I said, it's a new field and I'm very happy that Dr. Ilavi talked about it. But for the environment, it's usually for hemorrhoidal disease, anything that increases abdominal pressure. We're talking about pregnancy, we're talking about straining, we're talking about constipation, we're even talking about bodybuilders who lift heavy weights. We can have enlargement, anterior displacement, and inferior displacement of these cushions, yeah? So the culmination of all that is called hemorrhoidal disease. Now, there's a big component that is not just simply pressure and displacement, yeah? So there's a big component of inflammation there. Whenever we have pressure, whenever we have movement within the body, and we usually, as Dr. Eugene alluded, there is activation of the inflammatory cascade. With activation of the inflammatory cascade, we have involvement of the vascular and connective tissue. We have components that break down, others regenerate, yeah? And then, as we said, once things now, there's inflammation, we affect the connective tissue, we affect the mucus glands, the sebaceous glands, we have secretion. So this diagram is just summarizing for you what happens. So if you look at external hemorrhoids below the pectinate lines, we have engorgement. After engorgement, inflammation. And with inflammation, inflammatory cascade and things that come up with inflammation like thrombosis. With thrombosis comes swelling, activation of the somatic nerves and pain. For both, we have activation of the secretions, secretory sebaceous glands, which increases the secretions. So we get a lot of itching, a lot of irritation, and of course, with the pressure comes bleeding. Now, when we talk about first to fourth degree, we're talking about internal hemorrhoids. Yeah. For external hemorrhoids, we either say they're thrombosed or not. I know the surgeons talk about other things, but for us, it's whether they're thrombosed or not. Yeah. So for internal hemorrhoids, which we mostly detect on colonoscopy, we have first to fourth degree. And the degree is just to say first is bleeding. And from second degree, there's prolapse and whether we can reduce them. So second degree, prolapse with spontaneous reduction. Third degree, they prolapse, but we cannot manually, and we need to manually reduce, not spontaneously. Fourth degree, they're irreducible. And by this time, the patient is in a lot of pain. So as I said, we've already talked about the pathophysiology, but what this slide is highlighting is that we can have a systemic origin. So remember, it's multifactorial. I think this diagram is just summarizing what I'll say, so I'll skip it. And we've talked about grade 1 to grade 4, more for internal hemorrhoids. So what are the symptoms? So as I said, it depends. So for most of the patients who have hemorrhoids, they're usually asymptomatic. They'll come and tell you, I just feel swelling. And I think because in our population, people are very heightened to things like cancer, they'll tell you, I have an anal swelling and I want it sorted out. But about 4 to 10 out of 10 patients are symptomatic. And as I said, majority have painless bleeding or swelling. So the bleeding tends to be bright red. It sometimes oozes, sometimes spurts, and if you have a swelling in the rectum, most of the time it'll spontaneously recede. But you do get patients who have prolapse. Now, one of the differentials for hemorrhoidal disease is prolapse. If you see when you're doing your DRE, you see a mass that is very red, tender in the older generation, mostly above 55. Keep that in mind, yeah? However, as I said, usually the internal hemorrhoids can prolapse. So this is just a diagram showing what is prolapse. As I said, once they pass the pectinate line, we define that as prolapse. Other symptoms are related to the pathophysiology. So in medicine, everything has a explanation. So we have irritation, we have itching, we have soiling. Some people have fecal incontinence, but not the majority. We have rectal fullness, feeling of incomplete evacuation, mostly because of the pressure and the holding the feces, yeah? So pain is not typical unless there's prolapse. However, pain will tend to be mostly in external hemorrhoids which are thrombosed or internal hemorrhoids which have prolapsed and thrombosed. So what do you get? You get a lot of pain. You can develop abscesses or anal fissures. So how do you evaluate this patient? Remember, I think for us, the reflex is to do a colonoscopy. So where I work, we have so many patients in the clinic that when someone comes with anal pain, it's very easy for you to write an X-ray form saying colonoscopy. But you need to do a proper clinical examination. So remember DRE is part of the abdominal examination. So do a proper abdominal examination. You might be surprised what you get, especially masses. After that, do a DRE. And when you do a DRE, we want to have the correct technique. So I don't know if you can see me online, but basically run your finger along the natal cleft, you're not poking the patient. Just slide along the natal cleft, gently prod and allow, because the reflex is to close the anal canal, yeah? So allow the patient to breathe in and out until they're relaxed. And when the anal sphincter is relaxed, then you can insert your finger. Of course, use plenty of jelly and protect yourself, yeah? Use gloves. Now, when you're examining the patient, we examine like a clock. So towards the belly is what clock? Sorry? Sorry, you can't remember, yeah? 6 o'clock? Who wants to, any other thoughts? Towards the belly button is what o'clock? 12 o'clock. Yeah. So it doesn't matter really, so long as you draw your clock and you know where is where, but it's good to have a reference point, yeah? So towards the belly is 12 o'clock mostly. Towards the back is 6 o'clock. So when we look, when you see any masses, any fissures, it's good to draw a clock in your diagram and label, because it will help the person doing the colonoscopy or future reference, yeah? And why is that important? You might say, why should I draw a clock? I know it's a hemorrhoid or not, but can you imagine an anal tag? You're going to remove an anal tag in surgery, yeah? And if you're confused, there's always a referral system, really. In medicine, it's not about who is right or wrong. It's the fact that you've detected the lesion. Good. So what about, so you're examining for masses, tenderness, and of course, sphincter integrity. Remember, there's also the patients who have been abused, yeah, sexually abused. So keep that in mind, especially in the younger generation. Anoscopy, I think my surgical colleagues may have an anoscope or a sigmoidoscope in clinic, but this has been overtaken by colonoscopy. So it's just an instrument to observe the anus. So this is the diagram I showed you earlier. So who thinks in diagram C, the one labeled C, who thinks the external hemorrhoids? Okay. Who thinks the internal hemorrhoids? Does it matter? Probably not. Yeah. Internal hemorrhoids? External, majority of the people, yeah. They probably don't matter, but these were internal hemorrhoids, yeah, that had prolapsed. So the treatment is the same. However, for internal hemorrhoids, you might not be able to examine properly, yeah? So most of the time when you see something like this, you may need to do a colonoscopy because you don't know if it's pressure. Even a tumor can cause pressure on the rectal veins and cause you to have hemorrhoids. Yeah. So anything causing pressure. For the diagram to my extreme right, those are external hemorrhoids. They are continuous with the skin, but this is in a Caucasian individual. Does it matter? Well, not really, because the treatment is the same, but it would be good to differentiate. So when do we do colonoscopy? So every doctor has their own way of defining when to do a colonoscopy. But I think the major thing is to rule out proximal causes of bleeding. More so if you have tumors, if you have polyps that are bleeding or anything else, yeah, diverticulitis. Yeah. So remember, we have routine screening for patients over the age of 45. So majority of us, if you're a specialist, you're either hitting 40. So please, 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 I think the age has reduced to 40 for most societies. So please, please, please do go for your annual screening, routine screening. And I think Dr. Joa, who's my senior, is also working with the society to put guidelines where we can have early screening. Other indications for colonoscopy, if there are risk factors, like the patient has a risk factor for cancer, and family history, you've had a familial history for cancer or any other suspicious diseases, especially in the elderly population, that would be an indication for colonoscopy, and lack of response for initial therapy. I know in the private world, almost all people, whether they have external or internal hemorrhoids, go for colonoscopy, but good practice is to have an indication for colonoscopy. So how do you manage these guys, the patients? Remember, behavioral, genetic, we cannot influence, but environment you can influence. So lifestyle modification. First line of treatment is dietary modification. So high fiber, adequate water. People will ask you, what is high fiber? What is adequate water? So who has a response? Who would, like a patient asks you, high fiber, adequate water. What should you say? Drink 10 glasses, take lots of vegetables, take lots of fruits. Are there guidelines for this? Anyone? American Association of Sports. I know, Jenga, you must have an answer. You're smiling a lot, especially in diabetes, yeah, or endocrinology. Jenga, Irene, Dr. Rose, what would you tell them when they tell you high fiber? What is high fiber? What is high water intake? There is no wrong answer. Yes. Oh, yeah. Mm-hmm. You've never thought about it, yeah? But what do you tell the patient, doc? Mm-hmm. Okay. Okay. Mm-hmm. Yes. Any other answers? Thank you, Dr. Jenga. So, I was just going through this because a patient asked me, Daktari, high fiber ni nini, high water ni nini. Yeah. So they're actually guidelines. There are guys in the sports academy, those guys who train for Olympics and all that. So they actually came up with a formula according to your weight. Yeah. So, I used to wonder where the 20 to 30, those guys who've done ACLS, 20 to 30 cc per kg come from, yeah? So when you look at a physiological male, you're looking at 75. So if you do 30, or 80 kgs, that's about 2.5, 2 liters to 2.5, yeah? So when you check in glasses, if one glass is 300 ml or 250, put it at 300, that's about 8 glasses, yeah? So they borrowed it from the medical society. So it's about 20 to 30 mLs per kg per day, yeah? Which if you look, we usually say physiological man, that's 8 to 10 glasses, yeah, 2 to 3 liters per day for health, yeah. So when patients come in and we're resuscitating them, I think we use the same, yeah, So that's according to the Sports Academy. For fiber intake, just generally high fiber foods and avoid, as Dr. Jenga said, junk food. Now, counseling on defecation habits. This is also another very interesting thing. So there's a grade 1B recommendation. I'll show you a picture and explain more about it. And of course, you should prevent new hemorrhoids from forming. So just to skip this a bit, let me show you the defecation habits. So by reflex, if you're sitting in a toilet, you do not sit at 60 degrees, 90 degrees, your pelvis and your legs, yeah? So if you want to pass stool, you actually bend forward and strain, right? Yeah, so physiologically, it's about 60 degrees when you look at your pelvis and the spine, yeah? However, for patients who have constipation, we usually do an acute angle. I'm sure we do not advise patients on this, but it would be good. So you can raise your legs on a stool, and reduce this angle. So to about 35, which enables you to defecate, yeah? So another thing is that there's no reading or browsing when you're using the bathroom, because we tend to not concentrate and focus on our habits, defecation habits. So just sit on the toilet, sit in the bathroom. Acutely, if you find you're straining, increase the acute angle, basically. And for fiber, what I was saying is that it's integral to management. It reduces the risk of bleeding by 50%, and it's usually effective more often than not with your lifestyle changes. But for fiber, it's more for improving the evacuation of the bowels. Yeah. So there's no improvement in prolapse, pain, and itching. And it takes about 6 weeks of consistent fiber intake for you to see a difference. So what are the fibers, the synthetic fibers apart from food in the market? We have psyllium, we have isfagula husk, we have unprocessed bran, and you can get this in the supermarkets in our local chemists. So we do need other therapies that are effective in hemorrhoidal treatments. So what about ointments? Now, ointments and what we call suppositories are very common in our practice. Usually they contain astringents, they contain zinc oxide, which protects, remember, the anti-inflammatory effect. They contain decongestants, steroids, and anesthetic. They have usually a pain, some value in reducing the pain. Now, those usually work on the sebaceous glands and locally, so they will reduce your pruritus and irritation. However, we do recommend them for short periods. Majority of them have components that can react, and they are very good for controlling pain. But when you look at hemorrhoidal, the inflammation for hemorrhoids, not a very big role. But we do have this topical nitroglycerin, about 0.4% ointment, if there's a lot of pain. Now, if the pain is more than usual, please keep in mind that we have anal fissures, and we do have things like dilgesic ointments for them, and lignocaine and etc. So keep that as a differential. What about the oral medicines? So just a bit about the oral medicines. So what is available in the market are medications that contain flavonoids. Now, flavonoids are components that act on the veins mostly, but they do have an anti-inflammatory component. So we're talking about MPFF, that is micronized purified flavonoid fractions. We have calcium dobesylate, and we have diosmine as a pure molecule. So for diosmine, we don't have a lot of studies, but we do know that it's in combination, especially in the MPFF, yeah? And sometimes comes in combination with calcium dobesylate. We have them in the market. They are currently available. Which one do I choose? The answer is, it is up to you as a physician. You should arm yourself with the knowledge and choose accordingly. So for MPFF, what we call micronized purified flavonoid fractions, it acts on the venous tone, wall valve, and on the inflammatory components, reducing the free radicals, the capillary leakage, and the lymphatic drainage. Same goes for calcium dobesylate, but the only difference is that calcium dobesylate tends to have little effect on the valve. So mostly for venous disease or venous return, MPFF tends to be a bit superior to that. However, the choice is open to you as a physician. Now for flavonoids, as I said, they are venotonic agents. They have anti-inflammatory and protective actions, and they reduce venous inflammation. And as we said, when you reduce inflammation, you inhibit the synthesis of inflammatory mediators. And when you talk about inflammation, you're talking about improved lymphatic drainage, improved capillary permeability. Yeah. So I think this is what I was discussing. I wouldn't discuss a lot about it here, but just to say that it's in combination with diosmin, hesperidin, as I said, and it's the most common flavonoid in the market. And I think the presentation next will talk more about it. Yeah. So just a bit about MPFF, what is in the market usually. So it can work on acute hemorrhoidal disease. So we see this study. This is a study, it's actually an observational phase 4 study. So they looked at these patients over a period of about 4 weeks. And you can see from the first graph to the second graph, in addition to conservative treatment, there was quite a significant reduction in edema, perianal edema, prolapse, and anal pain. Same thing when you talk about chronic hemorrhoidal disease. How does it work on relapses? So when you look at this, this was actually an RCT done over 8 weeks, 2 months. And what they were doing is that they were using the lowest dose of MPFF twice a day. And what was found is that there was a significant, if you look at the graph, there was a significant reduction in the number of acute episodes, quite significant, and also in the duration and the severity. So this is just to say that oral therapy works, yeah? Can be used in all grades for internal hemorrhoids, and it has been recommended by all societies, the French, American, India, and Russian societies, in addition to others. So I think my colleague will talk more about this, but just in summary for the oral drugs. So we have MPFF, we have calcium dobesilate, we have diosmin as pure molecules. MPFF contains all with diosmin, it's in combination with diosmin within it. Then we have calcium dobesilate. But in terms of MPFF, there's major efficacy in hemorrhoidal disease, stops bleeding, improvement in most symptoms, protections against recurrent attacks. And of course, when we talk about surgery, we have additional effect post-surgery, which I will show you. Now, aside from the diet, aside from the insertables, aside from the oral therapy, what about surgery? Where do we marry between gastroenterology and surgery? So we have minimally invasive therapies, mostly done by both. So we have rubber band ligation, just from the diagram. So what we do is we introduce a ligator, and we do not ligate external hemorrhoids. Remember, it's below the pectinate line, quite painful. Mostly this is for internal hemorrhoids from grade 2, mostly grade 2, 3. So we put in the ligator, suck in the hemorrhoid, and ligate. Ligate means tie with a rubber band, which you can do it easily on just as you're doing your procedures in the clinic. Yeah. So that's rubber band ligation. It's quite affordable. It's available. Infrared coagulation, basically what it's showing you in the diagram, you use a small probe with bursts of infrared light, and usually it's coagulation. So you coagulate and cause thrombosis, and they disintegrate, mostly for internal hemorrhoids. Then we have bipolar diathermy, not shown here, but yeah, not shown here, but it means we are just going to burn and cause coagulation around the internal hemorrhoids and cause collapse. Then we have sclerotherapy. This is rarely done, but used to be done in the past because of the risk of embolization. So we have a sclerosant, much like what we use for the stomach. So we inject the sclerosant, and usually there's thrombosis and disintegration. We have a new therapy coming around, like radio frequency. You use radio frequency waves and cause disintegration of the internal hemorrhoids, etc. What about surgery? Now, proper surgery. We're talking about hemorrhoidectomy, etc. So majority of the times for thrombosed internal hemorrhoids, or prolapsed internal hemorrhoids or thrombosed external hemorrhoids, we refer to the surgeons, and they usually perform surgeries. So as I said, mostly they are for strangulated and symptomatic surgery. So what are the options? We have closed and open hemorrhoidectomy. Then we have stapled hemorrhoidectomy or hemorrhoidoplex available. This is beyond the scope of this talk, considering we have many clinicians involved, but maybe we can explore these options with our colleagues in future. So this is the diagram showing exactly what is the procedures performed. Now, how do the oral drugs work after surgery? So bleeding, that's a major complaint after hemorrhoidectomy. And this is just a study, a randomized controlled study showing you how the MPFF worked post-surgery. As you can see, the control, there was a significant reduction in bleeding post-surgery. And in patients post-hemorrhoidectomy, in addition to the conservative treatment, there was a significant reduction in pain starting from day 1 to day 7. So this is just a simple graph showing you, hey, listen, after the surgery, do not stop your conservative treatment, do not stop your oral treatment. There is effect in bleeding and also in pain scores up to 1 week to 2 weeks post-surgery. So what happened to our patient? So this talk has been a culmination of our patient. So despite our advice, a patient comes to the clinic and he says he wants a colonoscopy. Most of the time we will do a colonoscopy, but we had the discussion. I explained to him that probably what he had was internal hemorrhoids, but I mean, it would be good to check with a colonoscopy. So we did the colonoscopy. He had internal in addition to large external hemorrhoids. So I managed him with sit baths twice a day, which is salt water. So how do you explain the salt water? Put it in a basin and you should taste the salt. So put it in a basin of warm salty water and taste the salt. Then spread your cheeks and allow to sit for about 10 minutes. Yeah. High fiber diet, explained what high fiber was, water. I decided to give him a laxative because most of the time, if he's had constipation, he's had these symptoms for 3 years, although he denied constipation, I still gave him, but he declined. I also started him on oral drugs. Yeah, about MPFF 1 gram TDS for 3 days and twice a day for 4 days. I started him on what is locally in the market, then once a day for 3 months. Now, I discussed his options, and given that he's a diplomat, he's quite well read, even if he was not a diplomat. Nowadays, we have the internet. He decided to see the surgeon. Yeah. So I referred him to my colleague who gave him quite a few options. And once they discussed, he called me, I think he called me the day after, and decided that he would do infrared coagulation in a private facility, even before the drugs could work. Now, when patients say that, usually it's not up to you as a clinician to advise them, hey, look, you can do the medicine and then do this procedure later, see how the medicine works. I was up for it. I gave him the options, the pros and the cons, and they opted to go for it. Now, when he went to the private hospital to do the infrared coagulation, it was really difficult. I don't know if it's the technique or the fact that it's a new technique. I don't know. I will not speak for the surgeon, but it did not go well. So he had difficulty in recovery. He was actually admitted for about 2 weeks. He had a lot of pain. He could not walk. And 4 weeks, he was discharged from the hospital 2 weeks after the procedure. And after the hospital, he came to the clinic after 4 weeks. And I think in my opinion, the hemorrhoids were worse. Yeah, of course, you do not tell that to a patient, but I referred him back to that surgeon and they decided to do open hemorrhoidectomy. And after the hemorrhoidectomy, we continued on our oral treatment and high fiber diet. And currently he's doing well and globetrotting around the world. So this is a unique case, not to say that you should not go for surgery, but just give the patient options and manage as it comes. Yeah. In conclusion, so hemorrhoidal disease, we know what it is. For the pathogenesis, remember, it involves the anal cushions. It has an inflammatory component and there's a lot of venous stasis, so keep that in mind. Lifestyle recommendations are key, they are paramount, and secondary prevention for all grades of hemorrhoidal disease. They may appear local, but have a systemic origin, so remember the inflammatory aspect, which requires a systemic approach. Please note that topicals act locally. Usually, they have temporary relief, and these things usually come back. The hemorrhoidal disease can recur. So the patient still needs treatment, still needs follow-up, and a lot of medications, a lot of follow-up. And among the different treatment modalities, we have MPFF, we have calcium dobesylate. You've seen the advantages. So that you as clinicians should make informed decisions, yeah? For MPFF, relieves the patient from acute hemorrhoidal disease symptoms and protects them from relapses, and usually has been shown to be useful before, during, and after surgery. When do you refer? Refer if you are stuck. Surgery is an option for these patients. And I will end my talk from there. Thank you very much.
And thanks for reminding us that she went and I also understood why the schools provided in terms of the evaluation. So if someone always is asking why do we use the dosage of MPFF, why we can't take it down? Because another curious question for me is men who have sex with men at high risk of
Okay. Thank you for your questions. So for the oral drugs, including MPFF, what they do, they target the first 2 weeks of acute management of the symptoms. Yeah. So you want to hit hard. Remember in when we were talking about resuscitation, sorry, I worked in ICU, but usually you hit hard, deal with the inflammation, deal with the pain. And one thing you should note is that the patient comes to your clinic specifically.
Mic check.
Sort them out. So if you can sort them out, literally sort their symptoms out. So usually you need to sort them. But you can't. Now, for men having sex with men, that's a very good question because they usually have other things. Yeah? So we have infections of the anal canal, we have anal warts, we have ulcers, which usually are either sexually transmitted or not. It could be due to the mechanics or due to the herpes. We have anal fissures, so those are important differentials. Are they more prone to hemorrhoids? You know, for the activity that occurs with MSM, it's in a short period. I don't think, but we do see them. Particularly as a risk factor, I've not seen maybe Dr. Chua, my senior colleague, maybe you can mention about that. Have you seen more of hemorrhoidal disease in MSM?
Thank you. Xavier?
Sorry, I think it was.
Oh, sorry. My bad.
Yeah.
So I typically tend to be a very African man. I don't usually ask most of my patients which way they swing. So anyway, so I really wouldn't know, but truth is, yeah, there is evidence that yes, men who have sex with men definitely have a higher propensity to form hemorrhoids, yes, and among other diseases of the rectum and the anal sphincter. Yeah, so definitely there is documented risk increase for MSN group of people. Yeah.
Thank you.
Okay, for any further. Mbogo, you can talk to Miriam about hemorrhoids over tea. Okay, fine. Yeah, he's traveled from Thika, so I've been told to feel sorry for him.
Hello. Morning. I've just remembered when we were undergrad, somebody once in our ward mentioned manual anal dilatation as a form of treatment. It was many years ago. Can somebody make a comment?
Manual dilatation.
Yes.
Wow. I think, do you have any surgical colleagues here? We do not do that as gastroenterologists. I think even Dr. Joe would, maybe Dr. Joe and Dr. Okanga wants to make a comment.
Dr. Joe?
I don't know that. No.
Perhaps, no, sphincter dilatation, no. The only part where it might have a use is if you're dealing with fissures, but in that case, they do just a sphincterotomy, basically.
Thank you. I just wanted to agree with Dr. Jua that manual dilatation is for anal fissure. For patients with anal fissure, then there's a role for manual dilatation, usually by the surgeons.
Thank you. Okay, thank you very much. I'm sorry we may not be able to, in the interest of time, answer all the questions. So let's have a word from our sponsors. Savia, thank you.
Are the slides up? Perfect. So settle down, please. Settle down. Yeah. There. Myself. No, I'll use your phone. So. Okay, good. So it's 12:15. So let's have a prompt start. So we'll now move to the session. We are going to be dealing with cardiology, and we're going to first have a talk looking at the pillars of heart failure management, optimization for the physician, the good and bad days. And this will be by Dr. Bernard Samia, who is the current president, Kenya Cardiac Society. He's a consultant physician and cardiologist based at the MP Shah Hospital. So he'll take us through the first talk. I also want to introduce the chair for this particular session, and also who will be our panelists will be Dr. Gitura and Bernard Gitura, former immediate president, Kenya Cardiac Society, consultant physician, cardiologist. So once the talk is done, we'll move into the panel, but it's going to be our overall chair for the session. So thank you so much. And without further ado, let's proceed. Thank you.
Okay, thanks, Eric, for the kind introduction, and good afternoon, ladies and gentlemen. It's nice to share this podium to discuss this topic of heart failure. I was asked to talk about the good and bad days of a heart failure patient, so kept me wondering how many of those days are actually good. I realized most of them were bad days, but let's see what happens. So my agenda is to look at the journey of a heart failure patient and make a lot of references to the international guidelines we have in various aspects of diagnosis, treatment, follow-up, and see how to improve outcomes, especially with regard to optimization of treatment, what so-called guideline-directed medical therapy. I'll be asking a few questions in the audience. If you may want to participate in the discussion, please go ahead and do so. What we know, heart failure is a complex clinical syndrome, and you didn't give me, I have to look this way because I don't have a laptop to look at it. Anyway, it's fine. Heart failure is a complex clinical syndrome, and it's associated with significant global morbidity and mortality. What we know is the use of guideline-directed medical therapy has demonstrated quite significant improvements in the targets of treating heart failure. That is ameliorating symptoms, reducing hospitalizations, reducing mortality, and improving patients' quality of life. These drugs have been shown to do exactly that. And timely initiation of the GDMTs, which are routinely 4, has been shown to yield up to 73% relative reduction in mortality over a 3-year period. Question is, although we still have a significant proportion of eligible patients who are not on optimal treatment, and this is a missed opportunity to optimize heart failure care and improve patients' quality of life. I would like to share with you a case here. Mr. Abdul is a really great gentleman, 64-year-old, has hypertension, type 2 diabetes, and also treated for BPH, comes to the clinic because he has these symptoms and is admitted. Difficulty in breathing, and he has swelling of the limbs. He gets occasional chest pain. These symptoms have been worsening over the prior 1 week. He also gets cough and wheezing. Abdul is a smoker. He takes alcohol what he thinks is social parameters. He stays indoors most times watching his favorite football team. He didn't tell me which one it was, but I could guess from his demeanor, the team he supports. And he's been taking his prescription medication regularly. This includes ARB telmisartan at 80 milligrams, metformin, atorvastatin. I'm not sure when I'm facing this way, the camera. Atorvastatin and aspirin. And like many patients, he comes in with a concoction of bottles of vitamin supplements. They are actually more numerous than the prescription medicines. He's at this point fairly sick looking. He's a febrile, blood pressure relatively low, 100/60 millimeters of mercury. He has a regular tachycardia at 102 per minute and saturating at 93 on room air. BMI on the high, 32. Physical examination, among other features, reveals bipedal edema. He has crepitations bilaterally in the lungs and S3 gallop on his CVS exam. So, like every smart clinician, this patient has been admitted. So we've run a battery of tests to see what is going on. We've done among his tests, his HB is found to be low at 11.1, elevated WBC, platelet count within normal. He has renal dysfunction with elevated creatinine and urea and low sodium at 128, mildly elevated transaminases. His sugar is not well controlled at 14 and HbA1c at 8%. His lipid panel is normal. And the other tests that we did for him during the admission, he has a sinus rhythm with a left bundle branch block. Chest X-ray is done, which reveals a cardiomegaly and bilateral infiltrates, probably typical of pulmonary edema in the setting of what he's had for these few days. So I got to learn we have a few residents here who are taking internal medicine. They may help me if they were on the floor admitting this patient, what their thought process may have been. This is a patient with diabetes, hypertension, has those symptoms, and these are some of the features you find. What would be the thinking process? If I have to squeeze my discussion within the time allocated, so if you're going to talk, please talk fast. If you don't talk fast, I will continue. Who wants to try? What do you think? What's going on with this patient?
DM, hypertensive patient, risk factors for possible heart failure. White cell count is elevated at 16. We have what could be an AKI with hyponatremia, possibly dilutional, with elevation of STLT. So possible congestive hepatopathy with transaminitis, poorly controlled sugars. Chest X-ray had a cardiomegaly and bilateral infiltrates coupled by examination findings suggestive of heart failure with an ECG showing a left bundle branch block. Yes.
Thank you. Excellent. So have gone further, given more information there. We have an echocardiogram. I think these days echoes are very easy to do. So one of the key things, parameters you want on echo is ejection fraction. This is found at 40%. So this pretty gives you clear cut one of the diagnoses that you've been considering. But if that EF was above 40%, you may still be considering that diagnosis for the other differential aspect of heart failure. And he has global LV hypokinesia. So just a diagnostic formulation. This is a patient with type 2 diabetes. He's hypertensive. He has a CKD or acute on chronic. He also, you're considering he could be having a chest infection, pneumonia, the COPD, decompensated heart failure. If you did not have the benefit of echo, you may not tell whether this is reduced or preserved ejection fraction. He has hyponatremia, which may be dilutional because of fluid overload. His HB is low. Iron deficiency anemia is a pretty common thing we find in patients with heart failure. And that's where Abdul is for now. And so some of the difficulties we meet treating a patient like Abdul is when you want to diagnose heart failure, how quick is it? There's no single diagnostic test to pick for you. Okay, there. There's no single diagnostic test to detect heart failure. You have to run all those through the signs, symptoms, laboratory features, and so on, echocardiography and all that. And these signs and symptoms overlap with so many other clinical conditions. It is costly and very laborious to investigate for heart failure. By the time you do all those labs and investigations, it's a lot of money and it takes time. And this delay has been shown to lead to poor outcome. The more you delay to diagnose heart failure, the more you delay to initiate treatment, the poorer the outcomes. We do not always get to know what phenotype of heart failure we're dealing with until we have echocardiogram to confirm. And even after echo has been done and it's not fitting the reduced ejection fraction, we still do not know whether this is heart failure or not. So we have a lot of algorithms that try to score whether a patient, the likelihood of there being heart failure. And once a patient has been diagnosed with heart failure, their trajectory varies a lot. There is the outcome of treatment, future mortality, future hospitalization. We quite can't tell, but now we are trying to use a lot of algorithms and AI to predict what is the future likelihood of this patient getting any of these events. Just to remind us, what is heart failure? This has been described by the universal definition and classification of heart failure. So what we have is a clinical syndrome with current or prior symptoms, but you also need evidence of cardiac dysfunction. This is either in elevated natriuretic peptide or objective evidence of cardiogenic pulmonary or systemic congestion. Heart failure patients will not wait until they have that classical definition, which we put it as stage C. We also consider earlier stages of heart failure, at risk heart failure. These are patients without current or prior symptoms, without structural heart disease, but they are at increased risk of getting heart failure. So any patient who is hypertensive, diabetic, has dyslipidemia and so on would be considered at risk for heart failure, and that would be in stage A. Stage B patients would be those who are already having without current or prior symptoms or signs, but there is evidence of structural heart disease, there is evidence of abnormal heart function or elevated natriuretic peptide. And the typical patient we treat like Abdul is in stage C, where he's having current signs and symptoms and evidence of structural heart disease. So we need not just pick our patients with heart failure at stage C, but we need to go step backwards and see those we can pick at earlier stages, because now there are recommendations that certain forms of treatment may actually prevent patients progressing from stage A and B into stage C heart failure. This is the typical algorithm that has been used, suggested by the European Society of Cardiology. We used this example to treat our patient Abdul. If you have your patient with heart failure, usually in the acute phase, the diagnostic priority, you want to take a thorough history, look at the risk factors, likelihood of this being heart failure. Then you do a number of tests, which we did. This includes an ECG, echocardiogram, a chest X-ray to rule out other differentials of the symptoms, and biomarkers, including proBNP, troponin, and so on. Just to share that proBNP is readily available in our setup, but it's just expensive as an echocardiogram. So many of us in clinical practice tend to skip doing proBNP, which is not a good thing because it has its own indication and relevance in management of patients with heart failure. So you need to go through that and be able to interpret what the proBNP levels are, especially for patients who have preserved ejection fraction, and also for prognosticating patients at discharge. If those levels are going to go lower as you continue the treatment, then you know you're on the right trajectory as you're treating the patient. It's not enough to diagnose a patient to be having heart failure. It's also very critical to know what is the cause of the heart failure, because as much as we have the generic treatment of the 4 drugs, it is important to address the prior risk factor and the causation of the heart failure. So while doing the investigations, including imaging. These are the key things one would need to be looking at. Am I dealing with a valvular disease? Is there pericardial disease causing heart failure? Is this patient having high output set causing heart failure or worsening a pre-existing heart failure? Volume overload and myocardial disease. We've done a lot of surveys and registries in our setup to see what is the predominant disease that causes heart failure. And this varies, for example, in the private sector, in the public sector. If you go to a typical rural hospital, you find a lot of valvular diseases related to rheumatic heart disease. If you go to some of the affluent hospitals, then we are getting a lot more ischemic heart diseases causing heart failure. Depends also on the age group. Middle-aged females, we are getting quite a number of cases related to peripartum cardiomyopathy. So you need to run through this, and while you're evaluating, doing imaging and so on, try to figure out what is the causation of heart failure for a particular patient. And history taking and evaluation will also help you to look at comorbidities for your heart failure patient. These are the common conditions that may be occurring with your heart failure patient. Heart failure incidence increases with age. These comorbidities are also found with increasing age. So it's not uncommon for your heart failure patient to be having COPD. Abdul was a smoker many years. He probably has COPD. He has hypertension. He's already presenting with angina, probably as an ischemic heart disease that preceded the heart failure. He has renal dysfunction. He's diabetic. And during treatment for these chronic diseases, patients get depression, sleep disturbances, and so on. So these comorbid conditions may be occurring because of shared risk factors or because of complications of the heart failure or because of complications of treatment that you're going to initiate. Why is it important to understand the comorbids in heart failure? They may affect the kind of treatment you're going to choose for your patient. Drugs used to treat comorbidities may actually cause worsening of the heart failure. For example, patients who have arthritis and you're going to use NSAIDs, they are associated with accumulation of fluid in the body, and this may not be good for your patient. Drugs used to treat heart failure and comorbidities may interact and cause poor adherence. The drugs may affect the kidney, cause electrolyte abnormalities. So it's important that you tease out all these comorbidities and be able to understand how you're going to balance the treatment of heart failure. So how did we initiate treatment for our patient? Like the algorithm for all heart failure patients in the acute decompensated phase, the principle is to diurese the patient. So Abdul was started on IV diuretics. We routinely use intravenous furosemide to diurese our patients. Oral drugs usually do not work well in this acute decompensated phase because of mucosal edema and all other factors. There have been a few studies to look at addition of other diuretics on top of standard of care, which is furosemide, and acetazolamide has been studied in one particular protocol, and it was shown to probably offer a lot more decongestion, but not any benefit in terms of mortality. So if the diuretic furosemide alone is not working, you may consider adding acetazolamide. We did not do that for our patient because he diuresed well with furosemide. Then we initiated our patient on the recommended GDMT, SGLT2 inhibitor, MRA, and thereafter started him on ANI and beta blocker. Key things we were monitoring while treating this patient was to evaluate the blood pressure to make sure that he does not go into hypotension, because these drugs are known to be potent antihypertensives, especially number 2, 3, and 4. Renal dysfunction, bradycardia commonly occurs with the beta blockers, and electrolyte abnormalities, especially since we are doing heavy dose diuretic in the initial phase. So GDMT, which constitutes the ANI, beta blocker, MRA, and SGLT2s, have been shown to significantly improve the prognosis of patients suffering from heart failure. Initially, very high recommendation for reduced ejection fraction. We have some very reasonable level of recommendation for mildly reduced ejection fraction. This is EF between 41 and 50. And later on, we've had some good level of recommendation also for preserved ejection fraction for EFs above 50. But I'll show you that the drugs for the preserved ejection fraction are not as many as those for the reduced one. So Abdul had reduced ejection fraction, so he had the benefit of benefiting from all the drugs that are in actually class 1A recommendation. So according to the ESC 2021 guidelines, management for patients with heart failure, reduced ejection fraction, we should initiate them on a loop diuretic to decongest and thereafter put them on ANI preferably. I know in some clinical setups we don't have the ANI, so some of the doctors may put patients on S inhibitors or ARB, but I think we now have a lot of generic ANIs on the market, and we suggest that you preferentially pick that. Patients should be on beta blocker. The timing of starting of beta blocker, you need to consider that the patient should be adequately diuresed or decongested. Otherwise, it's not advisable that you start this drug during the early phase of congestion. Then you start the patient on SGLT2, and the two classes of drugs that have been approved for this with a very high level of recommendation is the dapagliflozin and empagliflozin, and of course the MRA. We have done the algorithm where we'll consider further treatments for Abdul. For example, if his ejection fraction remains below 35% and he's not still symptomatic, this is a patient who has high risk for sudden cardiac death. So we may consider giving him an ICD. And Abdul had a left bundle branch block. So if we go to the extreme end of the chart, if his ejection fraction remains about less than 35%, he's still symptomatic in spite of optimal medical therapy, is a patient we may consider to give a CRT to actually prevent CRT with pacing or with defibrillation to further improve his symptoms and prevent cardiac death. Abdul had a reduced ejection fraction. We are okay with that. But if you're going to meet another patient who has a mildly reduced ejection fraction, these are the recommendations, the drugs that you may use. In green is the highest level of recommendation. Diuretics and SGLT2 should be used. And we have class 2B recommendation for use of ANI or SARB and MRA and beta blocker for the patient who has ejection fraction between 41 and 50. And if you have preserved ejection fraction, the only drugs that have high level of recommendation after diuresing the patient then is only SGLT2, and you treat cardiovascular comorbidities for this class of patients. When the 4 drugs are used from various modeling studies, it's been shown the best outcome has been realized when you have ANI, beta blocker, MRA, and SGLT2 all on board for the patient with heart failure. This is in terms of reduction of all-cause mortality. The same applies for reduction in hospitalization for heart failure. When you have all the 4 drugs on board, you are likely to get the best outcome. Same thing to reduce cardiovascular mortality when you have all the 4 drugs on board. So we'll really be trying to aim to have our patient like Abdul on all the 4 drugs as soon as possible to realize the best benefits of GDMT. A question in clinical practice is how soon do we initiate these drugs for the patient? He's just been admitted in. We have various considerations we need to make while starting these medications. Is he adequately decongested before you start a beta blocker? Are the kidney functions okay to start S inhibitor, ARB or ANI? Is the heart rate okay to start a beta blocker? Is the kidney function okay, especially K levels for you to start an MRA? So all these are issues that you need to consider before you initiate any of the drugs for this patient. But bottom line is, it's recommended that you initiate treatment as soon as possible during the hospital admission. And this has been supported by the STRONG HF study, which was looking at patients who were put on high intensity care versus usual practice. High intensity care, these were patients who had early or 2 days before discharge, rapid intensification and oral heart failure medication. And these were the classes of drugs. These were compared with the patients who had usual of care. The probably leisurely introduction of GDMTs. And in terms of probability of event-free survival, after these 3 months, you can see the graph separated. So data from the strong HF study strongly recommends, and this is one of the recommendations in the ESC guideline, that intensive strategy of initiation and rapid up titration of evidence-based treatment before discharge, and frequent and careful follow-up of patients the first 6 weeks is recommended to have the best outcome for your patient with heart failure. How did we sequence the medicines for our patient? We've talked about the 4 medicines. Which one do you start with? When do you follow the next? Diuretics come in fast, no problem about it. For our patient, we went ahead to give a beta blocker, and we did consider blood pressure, and eventually started the MRA, and ANI and MRA came in SGLT2. Now, the optimal titration sequence for GDMT has remained a very controversial topic, but the existing heart failure guidelines emphasize that full dose of GDMT should be put in as much as possible, as soon as possible, for as long as the patient can tolerate. These are some of the suggested algorithms you could use. Traditionally, there was argument that during the heart failure studies, each new drug was being studied on top of the pre-existing one. So some clinicians would want to initiate GDMT following the sequence in which the studies were done. S inhibitors were some of the earliest drugs were studied, followed by beta blocker, MRS, and ANI to come and replace the S inhibitor. SGLT2 is the latest drug. So some clinicians would want to use that order. Doesn't really follow any particular logic, because even during the studies, the newer drugs have been initiated on some patients who are not in background prior old drugs. So it's not really that the new drugs can only work if the background older drugs are already in place. So these are some of the authors that have written quite robust papers on how to initiate medication. Rosano says you can start on in any particular sequence as long as you consider the heart rate, the kidney function. Murray, very eminent author in heart failure field, suggests that you can start with this SGLT2 and beta blocker, then move on to ANI and MRA. There's another paper written by Green and Butler, which says you start all of them together and increase the dosage, start at small dose on all the 4 and increase. But bottom line is that at the end of, by the time you're discharging the patient, preferably the patient should be on all the drugs so that you can continue titrating upwards. So Abdullah has done very well during this admission and would like to discharge him. And one of the key things we want to consider, is he ready for discharge? The critical thing about when to discharge a heart failure patient is to make sure that they are adequately decongested. There have been quite a number of studies that have shown patients who go home on discharge before adequate decongestion are likely to be readmitted within a very short time, and this increases their mortality rate. This is very small print, sorry about that. There's strong predictor of outcome between the poor decongestion and discharge. I'll just show you the Kaplan-Meier curve. This one was looking at the survival rate for patients who had no congestion versus the ones who are poorly decongested at the time of discharge. And you can see the graph on top, no congestion had the best survival for patients. So we should try as much as possible to decongest patients before we recommend discharge. And this is one of the key messages in the guidelines, recommended that patients hospitalized for heart failure be carefully evaluated to exclude persistent signs of congestion before discharge. How do you assess for congestion? Maybe my smart friend there, you might tell me just 1, 2 things. How do you tell this patient is adequately decongested, I want to discharge?
So Clinically, from the signs and symptoms, you can check whether there is resolution of any pedal edema. If
Yes.
they came in with respiratory issues, so resolution of the CREPS, if they're off O2, such markers, and if they don't have, and again, their weight reduction following diuretic therapy.
Good. So we have signs, symptoms. If this patient came in with shortness of breath, coughing, wheezing, all those symptoms should actually be resolving. Signs, as you're mentioning, signs of fluid overload, be it in the lungs, be it peripherally, be it the JVD that is up, you want to make sure that has gone down. Then we have biomarkers. ProBNP is very commonly used to check that these levels are coming down, and is a good marker that the patient is improving. Imaging can also be used. If you're going to do echocardiography, for instance, you look at the IVC, you expect that dilated IVC to be reducing in size, collapsibility to be improving. You can do an X-ray, although caution that the X-ray features really delay. They're not in tandem with the clinical improvement of the patient. So just make sure your patient is adequately decongested before discharge. So follow-up of Abdul, he's readmitted 2 months later. And here again, he has shortness of breath and fluid congestion. He had traveled to his rural home, could not access his medicines. He's reporting feeling lousy whenever he takes some of the medicines. The common thing you'll notice, patients get side effects from heart failure medication and they may fail to take them. And you also need to consider, are there other factors that may lead to this patient not being adherent to his GDMT? What is the scenario like? Data from multiple studies have shown very poor adherence to GDMT, even within clinical trials like the STRONG HF. Patients were only taking about 40% taking MRA, only 20 or 30% patients taking S or AB. So it's a real thing that patients don't take their medicines for various reasons, and we need to evaluate this and be able to understand why this is happening. There's a publication that showed patients in low and middle income countries, especially, have very poor adherence to GDMT at the point of discharge and even during follow-up. We have some data from heart failure registry in our local situation here, and I will be hopefully publishing it soon to show just how much adherence to GDMT we have. And it was fascinating that we only have about 30–40% adherence to GDMT in our patient population. So we need to find out what are the issues why our patients are not taking medication. These class factors why patients don't adhere to GDMT, or what we call barriers to GDMT. You could look at it as healthcare related factors where the clinicians seated here, we have the inertia. We do not want to start medications. Maybe we have the knowledge, maybe we don't, but we do not start patients on all the 4 drugs and up titrate to the recommended dosages or maximally tolerated dose. Lack of awareness and medical systems that the drugs are just not there. We have treatment-related factors. Patients may be having renal dysfunction. Patients may be having hypotension, bradycardia, or atrial fibrillations and so on. So this may limit you initiating certain forms of medication for your patient group. And then we have patient factors that might also be key in terms of not being on GDMT. They think they are frail, they are weak, they're depressed. So you need to evaluate all these factors and see what is happening and why the patient is not taking medication. So Abdul, for instance, went home and he went to party and the drugs were not available and he felt okay. That's the other issue. Patients with heart failure improve symptoms and they decongest and they're okay. So they don't see the reason to continue taking medicine. So you need to caution that they should not stop medication. There was a big debate about whether we can actually be discontinuing heart failure medication in patients who have improved symptoms. And one particular study called TRADE-HF looked at these patterns, and it was shown those who stopped medication had a high chance of relapsing into heart failure and poor outcomes. But we have a unique category of patients who have peripartum cardiomyopathy, who usually improve the ejection fraction so supernormally that they stop medication, and a significant proportion of them actually never relapse into heart failure. So you need also to understand. So just to highlight some 3 key barriers to GDMT adherence, hypotension. This is more so marked with this class of drugs, the ANIs, beta blockers, and RAS. SGLT2, probably the least common, MRA, in that order as you come to ANI and beta blocker, the most potent. We do not use ANIs as anti-hypertensive medication, but we've been discussing with colleagues and we realized one of those patients you have with resistant difficult to manage hypertension. You try the ANI and you'll be surprised how well it can actually control that blood pressure. I'm not advocating that you use ANI for management of hypertension, but you could justify it. Maybe your patient has a stage B heart failure. And if you look at the algorithm, some of these drugs are getting class 2B or so recommendation for use. So hypotension induces inadequate organ perfusion, and this increases mortality for your patient. So hypotension may impede the initiation of GDMT, and the current clinical practice is to achieve recommended target dose or maximally tolerated dose. Now, again, it has been looked at how many of the patients on GDMTs actually have recommended dose. These were the dosages that were used in the studies, and you'd be surprised hardly half of the patients in clinical practice actually reach the maximally recommended dose. So what we tend to go for is tolerated dose rather than recommended dose that were used in the studies. Renal dysfunction is another common barrier, and this is highly prevalent in heart failure patients even before initiation of medication. And this may impede initiation of some of the drugs because we have cutoffs for eGFR below which you cannot start the heart failure medication. MRAs, for instance, are not recommended where you have eGFR below 30, and SGLT2s, for some reason, have been shown to slow the decrease in eGFR. So they may actually prime your patient to tolerate the other heart failure medications quite safely. Electrolyte abnormalities, including hyperkalemia. This can be brought on by caution when you are using ANI or MRA, so you need to be careful about that. The good thing is that now we have recommendations for drugs that can use potassium levels, and you can safely use the MRA or safely use ANI or any medicine that you have been withholding because of hyperkalemia. So these are in clinical use, and we recommend that one can look at possibility of independently treating hyperkalemia so that you can initiate your patient on medication. There's a nice graph here that is not so visible, just trying to show those factors: hypotension, renal dysfunction, electrolyte abnormality, AF, and so on, and the drugs that are associated with those factors and how to overcome some of those challenges in order to initiate GDMT. So Abdul is not getting well. He's still visiting the hospital, discharged in 2 weeks. He comes, worsening symptoms, still takes his medicines regularly. We're not sure about the dosage. He wishes to attend his daughter's graduation. So what else can we do to improve his symptoms and quality of life so that he can be able to attend to his social functions? So whereas you're using the GDMT, the 4 pillars as outlined there, these are the other factors that you need to consider for the patient with heart failure. Starting at the top, iron deficiency anemia, like we saw in our patient, and now there's recommendation to use ferric carboxymaltose to improve the iron levels and improve hemoglobin for the patient, and this actually improves the symptoms. There are many other considerations: hydralazine nitrate for the African-American patient who's still symptomatic in spite of the GDMT. You can be able to use that. We have also other drugs like vericiguat that can be added onto the treatment algorithm, and ivabradine can also be added. So this is the American 2022 guidelines. After going through the GDMT, they recommend you can use hydralazine or devices, ICD, CRT we've talked about, but what is here in yellow to consider additional therapies for the heart failure patient. And these are the drugs. Ivabradine can be tried, vericiguat can be tried, digoxin in some select patients, polyunsaturated fatty acid, and potassium binders. So these are the additional things that we'll consider for the patient who is not improving in spite of the GDMT. How else can we be able to improve the condition of the patient? Sorry, my slides have gone off again. Okay. So I just want to share some insights in the next few minutes, strategies to improve GDMT uptake in our patients. In hospital, introduction of medication is really key, and initiation and up titration during the hospital admission has actually been shown to improve adherence. You probably are going to have difficulties introducing new medicines for the heart failure patient, medicines that were not initiated during the hospital admission. But remember the limitations of bringing in some of those medications, as we have discussed. We will continue to do patient information, educating the patient on adherence, addressing clinical inertia for the clinicians. A meeting like this, when we are seated here, to understand, can you focus on the barriers why you're not initiating so that we can overcome that, improve affordability of medication, engagement of quality registries. I think any institution or any clinician who is under a study or registry, usually they're very keen on how they're managing their patients. I wish everybody was under some audit, then you know that you're doing the right thing, because come 3 months or 6 months, somebody will come and ask you, why did you discharge this heart failure patient without a beta blocker, without an SGLT2? So that really would help us to do a lot. And use of telehealth would really help us to improve. Now we have a lot of technology where patients, once they have gone home, they can do remote monitoring of their symptoms, and you can adjust their medicines without them necessarily coming to the clinic, and use of artificial intelligence also to tell if there is any impending deterioration in the heart failure condition. So GDMT has brought hope for management of patients with heart failure. Practical application of GDMT, however, remains suboptimal, and this obviously leads to unfavorable long-term outcome. And initiation of GDMT early and ensuring adequate implementation while considering individual patient factors tolerance significantly reduces cardiovascular mortality in patients with heart failure. And we need to have patient and caregiver education in order to have this cemented journey for improving outcomes for patients with heart failure. Thank you.
Excellent talk. I don't know that we have any questions. Okay.
Thank you, Doc, for the great presentation. Just had a question. Since residual congestion is a poor marker in a patient with CKD, heart failure, how do you go about it? And then how do you look at the proBNP in a CKD patient? Thank you.
So kidney dysfunction with heart failure are correlated. One can predispose the other way around, even before initiation of hypertension, heart failure medication. Then it brings in also the challenge of which medicines to initiate when there's already ongoing CKD. So I think the point is to understand what are the cutoffs for initiation of each of these medications. We always have the dilemma, if a patient is already on medication for heart failure and then they go into worsening kidney function, do you always discontinue the medicines? You have to be careful. For example, we know that the use of RAS inhibitors in the initial phase will lead to some deterioration of kidney dysfunction, and it's allowable up to 30% that you should not discontinue the medication. This is expected. You continue the medication because in the long term, there are benefits to the kidney and the heart. CKD would be associated with electrolyte abnormalities, hyperkalemia, and so on. So again, it's not absolute contraindication. You need to know the targets beyond which you will not, for example, initiate an MRA. Sodium levels are going to be troublesome with your patient. You need to know beyond which you can not give a diuretic. So you need to do all these factors tailor-made to your patient to understand the interrelation between CKD and your patient. And remember, some of the drugs now are actually, we have new drugs like finerenone for the diabetic patient CKD, and this is actually has been shown to reduce worsening outcomes for the patient in terms of CV outcome or renal outcome. So these medicines will actually be helpful. It's a tightrope you're working on, but you need to know how to balance them. ProBNP, yes, it goes it's elevated in certain critical conditions, and so this brings in a bit of challenge how to interpret it. Patients with obesity, with atrial fibrillation, with the CKD, those levels probably would be a little higher than what you have in patients who don't have those comorbidities. But if you're going to trend it, then you can actually tell these figures are going down. I'm getting better results with my heart failure patients.
Okay, so we'll take some online questions. There's a question here. Please advise on the role of digoxin for heart failure management in the modern era of heart failure management. Number 2, what's the maximum dose of diuretics you can use per day in a heart failure patient?
So I will start with the second, diuretic therapy. This will depend on whether this is incident heart failure or decompensated heart failure. If you have a patient who is coming in with decompensation and they have already been using some background diuretic, it's recommended that you are going to double that dose of diuretic to achieve adequate diuresis. And preferably you use the intravenous route rather than oral medication because of mucosal edema and all that. And then you are going to monitor some features of blood pressure, kidney dysfunction as you continue giving the diuretic therapy. Furosemide should not be used long-term for management of patients with heart failure. You should strictly come in, decongest your patient, and you discontinue it. For the patient who are initiating diuresis for the first time you've diagnosed heart failure, again, the dosage, you then are not basing this on any prior exposure to diuretic. So generally what we do, anything 40 to 80 milligrams up to twice a day. Whether you're going to do bolus diuretic or infusion diuretic, I think the studies were done and there was no benefit on either. Depends on the logistic support that you have, which mode of administration of the diuretic you're going to do. Digoxin, as you saw, one of my slides is actually 2B. And of heart failure, reduced ejection fraction, we have select category of patients who may still benefit from digoxin. It's not one of the 4 pillars for heart failure management. We have patients with heart failure, and it's one of those drugs you may bring in as an add-on therapy when you're not improving symptoms. But specifically, if you want to elevate the role of digoxin, if you have your patient with atrial fibrillation and tachycardia, and you want to control the heart rate, digoxin actually has a role. And sometimes the problem is that patients don't have access to any of the other medicines. Then you find somebody using digoxin, but you see the role for digoxin is really, really down there in terms of for the current recommendations.
So this one will direct to our chair, Dr. Gitura.
Actually, really is not a question, but an add-on to what question had been asked about patients with heart failure and CKD. And really, we know that 50% of our patients will either who have kidney disease also have heart failure of some sort. And there are multiple studies like Stop ACE, which have looked at when you stop ACE and when you start it. But in clinical practice, really, we want to start the 4 drugs together, even if, because we know SGLT2 will give you a form of eGFR drop, MRAs might give you a hyperkalemia. And when you're looking at our patient, most of them, the largest risk factor is really diabetes. So all these drugs really add on, and you're really not worried. Even now, we are going down with empagliflozin when your GFRs are less than 20. There are multiple ongoing studies, and actually they're showing benefits of even initiating SGLT2s when eGFR is less than 20. But really, it's a tough balance between right heart, when your right heart is failing, and your kidneys are also failing in terms of initiation of these therapies.
So there's an online question I'll direct to Dr. Gitura. How do you approach initiation of heart failure treatment in terms of medication in a patient who has heart failure with reduced ejection fraction and is hypotensive in the critical care setting? So let's say someone has heart failure, reduced ejection fraction, pneumonia, BPs are low. How do you initiate treatment in that setting?
Thank you. Thank you, Dr. Samia. I think, yeah, you rightfully actually spent some time talking about hypertension. And you must agree that hypertension, one of the strongest reason limit our use of these drugs. Yeah, so in a patients who are in the ward, most important, of course, as Dr. Samia said, is you need to decongest your patients. And there are many times, of course, as you decongest your patients, you'll find your blood pressures are low in the region of systolic of 100 or even 90. So if you, when you are starting these drugs, Of course, you need to come down on your diuretics because at that point, the diuretics role is basically to decongest. And therefore, you need to come down on your diuretics so that your BPs don't get affected. So in terms of the drugs, again, when your patients have those low blood pressures, you want to start with those drugs that have less impact on blood pressure. And I think Dr. Samia did mention the SGLTs, you want to put them up front. Of course, even the MRAs, that's where to start. Small dosage for MRIs, we recommend like 12.5. I tend mostly, as I introduce that, then I tend to use low dose beta blockers, like small dose like Cavedro 3.125. You may start with that. So for the ANIs and the ARBs, of course, we know they are very useful, but they are stronger. They have a stronger impact on blood pressure. So those in a patient who I'm struggling with BPs, then the ARBs, and those would come as the last resort. So start with the SGLT, MRAs, small dose MRAs, and then a small dose of the beta blockers. But just to mention that once this, and I think that this is one of the biggest limitation to manage our patient is people fear blood pressure, low BPs so much. And I would encourage you, don't fear blood pressure. We get a lot of calls from our patients at home. They went to a nearest clinic to check their BP. The blood pressure was found to be 90 or even 100. And immediately the clinicians told them, your BP is very low, talk to your doctor. So when you have a patient with blood pressure, let's say, we look at systolic of 90. Let's say it's 90. Always ask yourself, look at your patient. Don't look at the BP. Is the patient symptomatic or not symptomatic? If the patient is not symptomatic with a systolic of 90, don't shy away from using the drugs. Only in those situations, but yes, the patient, the BPs are going below 90, patient is symptomatic, then you want to reduce the drugs or you may want to withhold. So let's not fear the blood pressure. We can still manage our patient or initiate these drugs, even with those low BPs. Thank you.
So let's give a big round of applause to Dr. Samia, our speaker. Thank you so much for that enlightening talk, and also our chair for those comments. We'll swiftly move to Getz Farmer. Jackson will give us a presentation before we now introduce our panel session. TRH, one of our senior EXACO presidents, now proceeding to final year. So we now are going to have the case discussion first, then I'm going to invite our panelists. We have Dr. Ajua, who is a consultant physician, gastroenterologist, will be part of the panel once we finish the case. And also we have Professor Dilrat Soki from Aga Khan University, Nairobi, consultant physician and neurologist. So we are going to have a discussion and questions after that. And also we'll invite Dr. Gitura, who is going to be part of the panel from cardiology. So we'll have cardio, we'll have neuro, we'll have gastro, then you can be able to look at the case in totality. So over to you, Dr. Morgan.
Thank you very much. So good afternoon. As you've heard, my name is Morgan Moshemi. I'm an EXACO president at Kenyatta University Teaching, Research and Referral Hospital. So I'll make this presentation on behalf of Dr. Anthony Ochola, who's a cardiac fellow at Aga Khan University Hospital. So my presentation is titled Atrial Fibrillation, What Next? All right. So we'll go through a case presentation just to set up the stage for the panel discussion. So we'll go through a case presentation. So a female who's a 39-year-old who was a resident of Nairobi, working in one of the non-governmental organizations, had sober social habits, had good social support initially, was actually married with 2 children, and she was right-handed. So we'll go through a bit of a history, starting from 2018 up through 2024 to look at her current dispositions. So in 2018, the patient was living in the USA. Then in 2018, she suffered an event whereby she had a right-sided weakness with associated mouth deviation and slurred speech. She was able to present to a facility within 15 minutes, and she underwent thrombolysis. And after that, she was commenced on statins and antiplatelet agents with minimal residual weakness. So come 2020, by then she was living in Nairobi, and she presented with similar symptoms, that being right-sided weakness and slurred speech. She was able to present herself to a hospital within a 2-hour period, after which she underwent thrombolysis. So of note is that they picked up atrial fibrillation on ECG, and she was treated with dabigatran with minimal residual effects. So come 2023, patient noted that she occasionally suffered heavy menses, and during the period of having heavy menses, she will withhold dabigatran. So unfortunately, one morning, she woke up with weakness, slurred speech, and of note is that she had been off the anticoagulation for a period of 6 days. So she presented to the hospital, but unfortunately, she was out of the thrombolysis window. So an MRI done, it showed that she had an acute ischemic stroke, so a caudate infarct with M1 cutoff, that being the middle cerebral artery M1 branch cutoff. At this point in time, she underwent a mechanical thrombectomy. So ECG done for her showed that she had atrial fibrillation with multiple premature ventricular contractions. 2D echo was done. She had a normal ejection fraction, just a mild biatrial enlargement with moderate elevated pulmonary pressures. Transthoracic echocardiography was done. So there was no thrombus picked, there was no patent foramen ovale, and normal valve structure. So at this point in time, she had noted social problems. She was divorced. She was separated from her children and parents. Of note is that back in 2018, as a 10, she had very good social support, was married, had 2 children, and support from the parents. So at this point in time, she was discharged on dabigatran and a beta blocker. So this was her ECG. I hope we can appreciate we are having atrial fibrillation, a rate of around 74 beats per minute, and we have widespread premature ventricular contractions. So in 2024, she suffered a witness collapse while in the bathroom. A CT angio was done, and it showed that there was a M1 and M2 segment cutoff on the middle cerebral artery. She underwent thrombectomy, and intra-op, patient was noted to have an atrial fibrillation with a rapid ventricular rate. She had multiple PVCs and also had non-sustained ventricular tachycardias. So post-procedure, she was admitted into the ICU and was put on an amiodarone infusion. So a 2D echo done at this point in time, ejection fraction was at 20 to 25%. She had biatrial dilatation, moderate mitral regurgitation, and elevated pulmonary pressures at 65 millimeters of mercury. So in comparison, in 2018, EF was actually normal. She had a mild biatrial dilatation and mild pulmonary pressures. At this point, she has severe elevated pulmonary pressures. So we could see that there's a significant change in her echo. So this was the ECG. Again, we are having widespread premature ventricular contractions with an atrial fibrillation. So in her hospital stay, it was noted that her GCS dropped while in ICU. A CT scan done for her demonstrated that she had actually suffered a hemorrhagic conversion. So anticoagulation was held. Our patient was not a candidate for decompressive surgery, and she received osmotic therapy just to relieve her intracerebral pressures. Of note is that she also had melena stools, and OGD done demonstrated gastritis. So patient had significant neurological deficits and actually had a prolonged ICU state. So her current disposition is that she's currently bedridden, feeding via a PEG tube. GCS is between 12 to 14. She's on a PPI, on a Pixaban, and currently receiving guideline-directed medical therapy for heart failure. So my question is, so what will we have done for this patient, and what next for her? Thank you very much.
So we'll have an open discussion. So Professor Soki, Dr. Gitura, Dr. Ajua, Dr. Sam, you can also join us. Yeah. Yes. Oh, there are 4 chairs. Oh, yes, there are 4 chairs, yes. So just you can fill in the other one. Anna. Okay, no worries. Okay, good. So floor is open. Maybe you can just start just to get some insights from the floor in terms of the complexity of the case. Yes.
Thank you very much, Dr. Misheni, for that presentation. The question I would have, she seemed to have developed atrial fibrillation at 34 years, if I'm not wrong. So what is the underlying pathology? That for me is the question that I have. And when I start going there, I go to the genetics. So because she's fairly young, right? So that would be where it took me. What is the underlying disorder? Can we figure it out? Could it be genetic in origin?
So what would be the commonest cause of atrial fibrillation in a young female? Endocrine. What exactly? Hyperthyroidism. So that's the first thing that you look for. What else could cause AFib in a young female? Other common cause? Rheumatic heart disease, valvular heart disease. Yeah. Good. So maybe you can, the cardiologist can expound. What other causes should you think about in a young person coming with AFib at 34 years?
Thanks. That's a very interesting case. Patients who present with first episode of atrial fibrillation, this lady was treated appropriately, and I noted she went home on statin and antiplatelet. We try to figure out if there is underlying atrial fibrillation in patients who present with a CVA. It's not always easy because we may have paroxysmal AF. Some facilities, we may have ability to do 24-hour Holter monitoring, which is not sufficient enough. A normal 24-hour monitor does not rule out atrial fibrillation. We may extend this to 7 days, the loop recorders and so on, because it's really critical that if we pick the atrial fibrillation in that CVA event, that anticoagulation is initiated immediately, because the rate of recurrence of this is pretty high, and the devastating effects of recurrence of stroke. So I would also advocate, now we are getting more and more into the AI era. So we may subject some of our patients to some of the devices that could pick very subtle changes on a normal, what we would call normal ECG, the likelihood of there being atrial fibrillation within that background where the 24-hour monitor is not available or has not even picked a problem or related to atrial fibrillation. Probably that's my initial comment as we go ahead. And maybe I would just like a comment on from Professor Soki. I noted this patient had quite multiple thrombolysis done. What is the general practice? Do you have a limit and the time interval of one thrombolytic episode to another where you have a CVA?
Thank you. Just adding on to the question. So yeah, it's important to find out why the stroke happens in the first place, especially in a young woman. It's not clear exactly what investigations were done in 2018 when she had the first stroke and was thrombolized. But I agree with Dr. Samia that you need to really look hard for causes. And in our group, we do a standard sort of collaboration between cardiology and neurology, working out what's going on. But in terms of thrombolizing and doing thrombectomies, there's no limit. There are limits in terms of if someone was recently thrombolized, there's a 3-month cutoff, and whether you can thrombolize again for an acute ischemic stroke. And thrombectomies, again, there is no such limit for doing thrombectomies. But I agree, I think this is a patient who keeps getting stroke. Yes, I think the second time she had it when she was missing her dabigatran. But why she had it again after that is a question that we need to ask.
Maybe about the issue of thrombectomy, timing, if you've had a previous stroke, any considerations to make?
Yeah, so thrombectomy and thrombolysis, I mean, thrombectomy, there's no limits in terms of when and how you do it. There's only very limited contraindications. It depends on the person who does the thrombectomy. I mean, in this country, we only have 2 people who do mechanical thrombectomies from what I know. One of them is at our institution. But in terms of thrombolysis, yes, there are clear guidelines. And you can look up the American 2019 guidelines by Powers et al., which is what we use. And one of the cutoffs for not being able to thrombolize someone is if there's been a recent thrombolysis, be it for an MI or for a stroke, and then that's a contraindication.
Any comments, Dr. Gitura?
Yeah, just going back here to the issue of the etiology. Me too, when I had that case, it struck me at that 9-year-old coming with atrial fibrillation, not common, and therefore I think investigations from the beginning are very key. Of course, yeah, as we all mentioned, there are many causes, the ones that are obvious. I want to imagine the obvious ones, including the thyroid, the rheumatic heart disease. Of course, we know mitral stenosis is very common in the young. Those could have been picked, and I guess they were not there. Of course, we did notice in her ECG, she has PVCs, and I think those PVCs persistent. And we do know PVCs, although for a long time we have thought them to be benign, yeah, these PVCs in her could have been a sign. And of course, we have a lot of patients with now with arrhythmias, which are even seen in very young. So arrhythmias, tachyarrhythmias, tachycardia, induced cardiomyopathy. We see this lady later came with an EF, which was very low. So I think probably this lady, the issues of EP studies, probably those should have been considered very early on. This lady she could have had a tachycardia arrhythmias, now coming PVCs, then AF. This could only have been picked from EP studies. In terms of management, again, 1 year today, I know for a long time we have always talked about rate control versus rhythm control. Today, I think the management is changing. I think rhythm control is very important. And therefore, in this lady, any person who has persistent AF beyond 1 year, that patient should have again been referred for ablation. So I think because we need to manage the rhythm, because no wonder this lady again came back with heart failure. So early ablation, I think, should have been part of management from very early.
Okay, good. So before we move to Dr. Ajua, very interesting point here. So a lady, she's had a stroke, she's on anticoagulation. There's the issue of severe menorrhagia. How do you deal with that?
So in terms of the menorrhagia?
Yeah, menorrhagia. So she's on dabigatran, very heavy menses. So how do you, because you're stopping her anticoagulation during her menses. So what's the advice and what's the practice?
Yeah, so I mean, that's true. As Dr. Jua just said, I think that's where we involve gynecology. You know, so the risk of getting recurrent stroke and being as disabling as she ended up being is quite high compared to how do we now control this lady's menses. And I think that's a discussion that should have happened with indeed the gynecologists. But certainly in the context of an acute stroke, when someone's got active GI or gynecological bleeding, you would then be careful about giving thrombolysis because that can make things much worse. And again, that's a relative contraindication. I don't know if you want to add anything else in terms of bleeding and stroke.
So assuming this is now just long term now, she had a stroke, it's 1 year down the line, but now the issue of heavy menses has occurred. She's at home, she's getting very heavy bleeding. Now she presents with a casualty with, let's say, a HB of 9. So what do we do in that setting?
Yeah, I think, yeah, go on.
Because actually, the way I'm asking, we had an interesting lady. We had a lady who had SLE, was on anticoagulation, got menorrhagia, and now the gynae gave tranexamic acid concurrently with the dabigatran. So I don't know. That's what they do. And we try to look up the data. Is it safe to give tranexamic acid with the anticoagulation on board? But we went ahead and gave the tranexamic acid for the short-term duration. Then we just continued. But actually, there's no risk of thrombosis if you give the tranexamic acid. Yeah. So let's now adjure now. Someone, anticoagulation has been started, massive GI bleed. How do you now decide, once you've done the scope, you've clipped wherever the bleeding is coming from, how safe or how soon do we start the anticoagulation? How do you now have that discussion between cardio and neuro? They want to restart the anticoagulation. When do you give us the go-ahead to start after a massive GI bleed in the critical care unit?
So perhaps I'll give you an idea of what we should be doing in terms of, generally speaking, when you have your patients who are on anticoagulation or on antiplatelets. So unfortunately, there's no actual cast in stone guideline at the moment, even the American societies and the Europeans as well. But what they say is you should have an idea if you're going to start dual antiplatelets. you should at least have a look at the patient's age. If they're above 65, you might want to put a PPI on board with their therapy. If they have bled, if they've had dyspepsia in the past, you want to also be careful with the patient. If the patient is on NSAIDs or on steroids as well, you also have to look carefully at such a patient. And then the fourth one is you have to screen for H. pylori, especially in our setup. So those are probably the 4 or 5 things which you have to look out for before you start your patients on dual antiplatelet therapy. That really helps to reduce the chances of GI bleeding. So like in this case, this was just I think where I helped manage this case, it was just mild gastritis. Was nothing really much. Probably the patient had already had dyspepsia in the past because she was on long-term anticoagulation anyway. So that's a case which should have already been on a PPI therapy, for instance. Yeah, there was another case which we managed also with Ochola last month. Very nice one. Similar issues, AFib, etc, etc. They started her on dual antiplatelets, and she immediately got a massive GI bleed. We did endoscopy and she had a huge ulcer in the duodenum. That one, though, not likely because of the antiplatelets at the moment. She probably had an ulcer already, which just now bled. So in those cases, usually, if you're able to do mechanical management of the ulcer, within 48 hours or so, you're safe to restart your anticoagulation. Yeah, but of course, with PPI cover long term. Yeah.
Sorry, I just want to add on because the question is about what could have been done and what can I do next. I think just looking back and trying to maybe avoid this person becoming so disabled, as is what could have been offered at the time that she came through the door to reverse the stroke. So number one, when she came in, she was found collapsed, she had weakness. We don't know exactly what the time of onset was during the night when she was sleeping because she woke up and she collapsed. So in that situation, we confirmed what time did she last take at the Bigatran? Yes, it was taken last night. Okay. And from the evidence we know nowadays, from the dawn trials and wake up stroke trials, people who wake up with the stroke usually has happened within the preceding 1 or 2 hours. And one way you can decide that is to do an MRI scan, which fortunately at our hospital, we managed to do it urgently for patients because you can look for certain signal changes on the scan to see, did this stroke indeed happen in the last 1 or 2 hours, rather than just assuming that it happened at some point in the night. And that can sometimes sway you in terms of whether you can thrombolize someone. Now, in this lady, there's a complicated factor that she was already on the Bigatran. And she had taken the dose the last night, so thrombolysis is out of the question. And the evidence is still that you cannot thrombolize someone on the Bigatran or any other DOAC if they've taken it within the preceding 48 hours. These new drugs that reverse the Bigatran, like idarucizumab and then the adexanet that you use for rivaroxaban, again, not easily available, and we don't give them quickly enough. So in her case, when she came through the door, the only thing we could do for her was thrombectomy. And that's what she went for. So MRI, and she had a cutoff straight to the cath lab suite. The unfortunate thing with her is, as the presenter was showing the case, is that the next day, she didn't behave as well as she should have. And the reason that was is because she had hemorrhage. And the reason she had hemorrhage is because, unfortunately, the anticoagulation that she was on was continued, with the assumption being made that the thrombectomy had has resolved the stroke. But it hadn't. And after thrombectomy or thrombolysis, what normally happens is you always have to think that there's a part of the brain that may have infarcted, even if you salvage the clot or gave successful thrombolysis. And you must always hold off any anticoagulation or antiplatelets, especially after thrombolysis, for at least 24 hours, get a repeat CT scan to see is there any hemorrhage or not, before considering starting antiplatelets or anticoagulation. And I think the other point, which is important, I think maybe for the audience to know is, and I suppose my cardiology colleagues may chip in with this as well, is there's always the question, okay, this lady, she's known to have AF, she's coming with an acute ischemic stroke. We can't give anticoagulation just yet because of the stroke, because there may be a risk of hemorrhagic transformation. When do you start the anticoagulation? Clearly in this lady, you started at the wrong time. And the old rule used to be the 1-3-6-12 rule. which is if it's a TIA, you can start anticoagulation straight away, day 1. If it's a minor stroke, based on the NHSS score, you can start it on day 3. If it's a moderate stroke, which is NHSS score of up till 15, so you can start it at 6 days, and then 12 days for more severe strokes. But that evidence has now changed over time. So what I'm quoting is 2015, 2016 European guidelines, which are extrapolated from hematology guidelines from a while ago. But there's a lot of new trials that have come up now that are addressing this specific question. Someone who's got atrial fibrillation, come in with an acute stroke, when can you start anticoagulation and not have the risk of causing an intracranial bleed? And the true trials that have come out recently, there's the timing trial, and more recently the ELAN trial, that showed rather than doing 1, 3, 6, 12, you have that timing. So for mild and moderate strokes, can you start anticoagulation within 2 days? And if it's a major stroke, can you start anticoagulation within 5 to 7 days? And the evidence now is that it's safe to do that nowadays. You don't have to wait 2 weeks for a major stroke. I think that's one important change in practice that we can talk about. I mean, we constantly have colleagues, patients we manage with colleagues with stroke who then have an LV thrombus sitting in the heart and an acute stroke. And the question always is, well, for the cardiologist, we want to anticoagulate straight away. For the neurologist, we're like, well, you're going to cause bleeding in the brain. And these sorts of guides of timing of anticoagulation, bringing them sooner and knowing that you're not risking bleeding in the brain are more useful. So I think that's one important one. There was another trial that came out from Japan, from the relaxed trials and the samurai trials, came out a couple of years ago, that made it a 1, 2, 3, 4 rule. So just like I said, it could be either 2 days or 7 days. This one said 1, 2, 3, 4 rule, but it's not been rolled out to the population at large. But certainly I'd recommend everyone look up the ELAN trial. That tells you about starting anticoagulation of an acute stroke in the context of AF, and that it's safe to do it at an early time. Just to add on my last point, there are 2 trials still happening. One's called the Optimus trial, being done in the UK, that's specifically addressing this, but additionally also looking at whether anticoagulation prevents intracranial hemorrhage, because there's some evidence showing that if you prevent embolic events, you also prevent intracranial hemorrhage events. And it's going to address that question too. So that's a trial that hopefully will be published later this year. So I hope the additional value of the ELAN trial helps you make a bit more comfortable when you can start anticoagulation in such a patient. But in her case, when she started on day 1, it was the wrong decision. It should have been waited maybe a few days later, because it was quite a severe stroke.
Okay. So take home, atrial fibrillation, ischemic stroke, 5 to 7 days.
If it's a minor or moderate stroke, within 2 days is fine. If it's a major
fine.
stroke, 6 days to 7 days is fine.
Okay.
You don't have to follow the 1, 3, 6, 12 rule anymore, but I'll hand over to Dr. Samia.
Yeah, so I think that's a very important and pertinent
So, I mean, those are really important points Professor Soki has brought up. I'm reflecting back again to this patient, because the question was, how better would you have treated this patient to prevent this debilitating state that the patient finally has in? I want to bring out 2 scenarios here. Patients with atrial fibrillation who are on anticoagulation might end up, while on medication, re-stroking. And the dilemma we have as clinicians, could I change the DOAC to something better? I think there's no really evidence of any superiority of one DOAC over the other in terms of re-stroking while on hopefully optimal anticoagulation and proper adherence. General practice is one clinician may want to switch from apixaban to dabigatran and so on, but I don't think there's really good solid evidence to back changing those medications based on efficacy. Flip side, a patient who is on anticoagulation because of atrial fibrillation can also bleed, and therefore you want to stop the medication because they have bled, but is there a risk that they will get a ischemic event again in future? Therefore, there are recommendations about for how long you can discontinue the anticoagulation, and maybe reconsider starting, or in some absolute cases, you would never even consider restarting anticoagulation again. So what do you do for the patient who has atrial fibrillation and you cannot give anticoagulation, and we know the risk of ischemic event is there? I want to suggest that what Dr. Gitura said here, we should not rest that patients who have atrial fibrillation, and we have controlled the rate and anticoagulated, they are safe. Remember, this atrial fibrillation has even triggered this patient into heart failure, reduced ejection fraction. This in itself is a morbidity and is even going to compromise quality of life. This patient, the LV has formed a clot because of that reduced function. And we maybe should start considering early enough rhythm control, either with medication or a catheter ablation. Straight away, just ablate that irregular rhythm and put this patient on a pacemaker if so qualifies. And then the clots generally would form in the LA appendage. So we have technologies now where you can actually occlude that part of the heart where the clots are forming, and hopefully you don't continue having this cardioembolic strokes happening. So those are some of the additional, I think, treatment strategies one could do. Block off the LA appendage, ablate this patient, let them go into pacemaker, and completely get them out of the AF situation because they can't use medication, or these medications are not effective, or they are causing a bleed, or this AF is going to cause the patient to have heart failure in the long term.
So two final scenarios. Number one, to the cardiologist, we're an interesting patient. She was diabetic, but young female, rheumatic heart disease, atrial fibrillation, going for mitral valve replacement. And there was a bit of we couldn't have an agreement between the various teams. How soon do you stop your anticoagulation for someone who's going for major surgery like mitral valve replacement and already has documented atrial fibrillation? When do you stop the anticoagulation for the new cardiothoracic surgeons to proceed?
Yeah, of course, these are very common scenarios. I think a lot of patients are on these drugs and they need surgery. So depends on which coagulation you are using. Of course, there is the rule of bridging. If you're on warfarin, many times, of course, the recommendation is 5 days, up to 5 days to 1 week. But you need your INR. With warfarin, you need your INR to make that decision. The INR need to have gone down to below to 1.3. For the other anticoagulations, the DOACs, those you can actually stop within 48 hours, or even depending on the type of surgery, even within 24 hours. But I know many guidance give 48 hours. So for warfarin, again, the rule of bridging, if you're using the low molecular weight heparin like Lexane, you put the patient can actually be on that, and then as you just omit the dose the night before. So that will depend on but for the DOACs, those you can actually stop them within 24 to 48 hours.
Okay, so I think that brings us to the end of this session. So let's give a big round of applause to our panelists and speakers. And Dr. Morgan, thank you for that excellent case. So we'll have one presentation from Cosmos now before our lunch break. Thank you. I don't know if we've reached our 41st winner, Carol, for the stethoscope. You'll check. Okay. Took a number? 35. So just 6 to go. There's only 6 to go. Vote now, but utakuwa number 41. The link is on the KP group, Facebook link. Go there, go to our KP page, then you like. So you're 6 away. If you click now, definitely, you'll be like, you're very, very close. So maybe as we save on time for the presentation, where will lunch be served? So
who's going to start us off in the afternoon, and we'll try and keep time to be done by at least 4:35. So we are stepping a little bit away from what we've been discussing, from genetics, which has been very exciting, to rheumatology. And then we ended up having we went, a bit down south to the hemorrhoids, and then came back up to the heart and talked about heart failure and patients with atrial fibrillation. And now we step a little bit away and talk about the role of in terms of vitamin B12 deficiency. Our next speaker is Dr. Eric Jenga, the current president, National Kenya Association of Physicians. He's also the treasurer, Kenya Diabetes Study Group. He's a consultant physician endocrinologist, and he's also section head and full-time faculty at the Aga Khan University Hospital. Loves to rap, an all-time favorite of all of us. Welcome, Dr. Eric.
Thank you, Dr. Roslyn, for that kind introduction. Good. So we're going to look at vitamin B12 deficiency, and we'll look at specific causes, predominantly in the diabetes realm, metformin-associated B12 deficiency. I want to thank the sponsors who made this possible, Troika. They're going to show us after my talk. We'll have a quick demo of how to use their product, Naso B12. I also want to acknowledge Dr. Anne Wairagu, who was able to provide me. She was supposed to do this talk, but she's now in Cambridge, representing Kenya Diabetes Study Group in the research realm. So I want to acknowledge her in terms of providing me the material. And in fact, I'll show you the wonderful work she did for her MSc endocrinology course. She actually did her thesis on the prevalence of B12 deficiency in patients with diabetes. So thank you, Dr. Anne, in absentia. So that's the outline of our talk. We'll have the introduction. We'll go through B12 metabolism, etiology of B12 deficiency. We'll zero in on metformin-associated B12 deficiency and the mechanisms for that. Then we'll look at diagnosis, management. Then from there, the team will show us how to use intranasal B12 for treatment of B12 deficiency. So B12, as you all know, is a water-soluble vitamin, just like folate or folic acid, also called cobalamin, and it has a unique structure in that it contains cobalt in the corrin ring. We don't endogenously produce B12 as human beings, but animals are able to synthesize B12 through specialized bacteria in their gut. That's in ruminants as well as in poultry. And once this B12 is synthesized, it's absorbed into the bloodstream. And then from there, it's stored in the liver in these particular animals, as well as in muscle tissue, which we then consume as human beings. And also dairy products, it is secreted in milk. So again, also you can get your B12 from consumption of both milk as well as other dairy products. It has a very crucial role, as you're aware, for your neurologic functioning, neurocognitive function, optimal nerve conduction, as well as hemopoietic function and optimal cardiac functioning. Those are sources of B12, like we said. There's basically your meat, your milk, your dairy and poultry products, as well as cereals fortified with B12. So it's a lovely show, which our kids all like. You guys all know Magic School Bus and Storybots. You know Storybots? Who is the creator behind Storybots? Interesting. Do you know whose idea? And it's actually he's making a lot of money out of it. Do you know who made Storybots? Snoop Doggy Dogg. Yes. Storybots is Snoop Doggy Dogg's own children's show. Magic School Bus. You guys all know this. So the idea about Magic School Bus is that when they're trying to describe scientific things to kids, they get into the bus and then you actually go through various processes or pathways in the body. So we're going to get into all of us to Ingia Magic School Bus. So we're going to go to Ingia. Let's go through B12 metabolism. So it starts here. So first we consume our protein and dairy products, and then we have the B12 now being separated from your protein and dairy products by what is referred to as salivary hydrochloride, as well as your gastric proteases. Once B12 is separated, it's then linked to transcarbalamin 1, also referred to as haptocorrin, and now you have a B12 haptocorrin complex or B12 transcarbalamin 1 complex, okay? From there, you come now to the level of the small intestines, and now you have your pancreatic proteolytic enzymes, which now degrade that particular complex. And then now it releases. So now you had your haptocorrin B12 complex, your pancreatic enzymes come in, they now degrade that particular complex, it's broken down, and now B12 is freed up. Once B12 is freed up now, it now binds onto, and your transcobalamin 1 comes from your salivary glands. Once it's freed up after it's broken down in the small intestine, it now binds onto intrinsic factor at the level of the terminal ileum. And now you get your B12 intrinsic factor complex, okay? Once you get your B12 intrinsic factor complex, that now proceeds now to the terminal ileum, and it binds specifically onto a receptor called QBAM at the level of the ileal mucosal cell. And then from there, this is an active process. It's calcium dependent, so it requires energy. It requires energy. It's an active calcium dependent process. And that now will enable absorption across the ileal mucosal wall. Once you have your B12 intrinsic factor complex absorbed, within the enterocytes, you have lysosomal degradation now of your intrinsic factor within the enterocytes of the ileal mucosal cell. That B12 now again is released, And once it's released, it's now going to be bound onto transcobalamin 2. Okay, now you have a B12 transcobalamin 2 complex. That complex now will be transported from the enterocytes into the circulation by what is called the multi-drug resistant protein 1, okay? From there now, it comes to this level, at the level of the circulation. It can go two ways. You can have it going into the liver. So your B12 transcobalamin 2 complex goes into the liver, and there you proceed to have degradation of your transcobalamin, freeing again the B12, which is now actively going to be stored within the liver, and there it can be released into the hepatic circulation. And these stores tend to be viable for up to 3 to 5 years, okay? Also, you can have the same particular complex, B12 transcobalamin 2, going into the bone marrow, where again, at both these steps, it will bind onto a specific receptor referred to as transcobalamin 2 receptor, also called CD320. The same way, you have lysosomal degradation of transcobalamin 2, just like what we saw in the setting of the liver. Free B12 is now released, and this B12 now can be channeled into 3 distinctive pathways. It plays a role, as you know, in genomic stability, that's your DNA and RNA synthesis. So one pathway it goes into is conversion of homocysteine to methionine through methionine synthase. And you'd also tend to have what is referred to as the conversion of your 5-methyl tetrahydrofolate to give you tetrahydrofolate, which is very important in the RNA and DNA synthesis. And then the last pathway is that you tend to have methyl malonic acid or methyl malonyl CoA, which now gets converted to succinyl CoA. And that's again through methyl malonyl CoA reductase. And that eventually will lead to the production of succinyl CoA, which is now channeled into energy production cycle. That's a tricarboxylic acid cycle. Okay? So tumeenda magic school bus vizuri. Sindio? So you see how it goes, and that's how the whole pathway of how we actually have it channeled to those distinctive pathways, as well as how it's stored in the liver. Again, just highlighting that particular pathway. Remember that folate and B12 are required for you to convert your homocysteine to methionine. And that's the enzyme that we talked about, methionine synthase. And folate acts as a methyl group donor in this particular reaction. And this one is your predominant energy production for your tricarboxylic acid pathway, leading to ATP production eventually. Okay, good. So back to B12. So it's a micronutrient. We require about 2.4 micrograms per day for our average daily consumption. 50 to 60% of it is absorbed and stored in the liver, and you can maintain these stores for up to 3 to 5 years before you have manifestations of B12 deficiency. It's important, like we said, for your neurologic function, hemopoietic function, optimal immune functioning, DNA, RNA synthesis, as well as optimum cardiac functioning. We've talked about the pathways that are distinct. So let's look at what B12 deficiency is. And there's no clear consensus with regard to the actual cutoffs and guidelines. But usually we say at least less than 150 picomoles per liter or 200 nanograms per liter. Below that is defined as B12 deficiency. And the highest prevalence is seen in areas where we tend to have food insecurity. So we're talking about our low to middle income countries, that's sub-Saharan Africa and parts of Southeast Asia. And we look at other distinctive definitions about what is vitamin D deficiency, what is subclinical, and what is overt B12 deficiency. So as you can see here, Africa, 70% prevalence of B12 deficiency, and is linked to food security. Remember that. Same 50 to 70% also seen in India. Europe, on average, US, 20% is a prevalence of B12 deficiency. So we see it right there at the heart of the highest prevalence regions for B12 deficiency. And like I said, again, this is linked to food security. So as you can see here, there are various distinctive indices that we use to check food security in different parts of the world. So Kenya, we rank 87 out of 117 for the Global Hunger Index and 152 over 189 for the Human Development Index. So you can see we fairly rank high up, not too bad, but at least here we're not doing too badly. But the key thing, remember that in those areas where you're not able to access meat and dairy products, predominantly because of food insecurity, either because of conflict zones, wars, droughts, which is very prevalent in Africa. Climate change is another major issue. Then expect to have B12 deficiency being rampant in those areas. So this is now looking at local data. There are two distinctive studies. We had Njagi et al., who had a very good subset of data with regard to B12 deficiency. So overall, this is what Dr. Werago did with her narrative review for her MSc degree. So she found a prevalence roughly, you can see the range is quite wide, 5 to 41% in sub-Saharan Africa. A study done in KNH by Njagi et al., there was one in 2015 and another in 2019. They found that the prevalence roughly in Kenya, it was coming to around 8% for these particular people. And that's for people who have a B12 deficiency in the setting of diabetes specifically. And again, 18% had borderline levels of B12, that's between 208 to 300 in the diabetic cohort. So this specifically looking at B12 deficiency in patients who have diabetes, regardless of their therapy or choice of drugs in that particular setting. Let's go broader into the world, looking at the global prevalence now of B12 deficiency. The largest registry we have is a NANS registry. I don't know, you can move this. It's blocking. How do you? Yeah. This is talking. Move that. Move it up. Yeah, perfect. Yeah. So the NANS registry is the largest distinctive registry looking at B12 population at a global perspective. So as you can see there, it's 2.6 to 7.5%. And also we have another NANS registry, which also quotes at a different timeline, between 1.6 to 2.6%. This will show you that even B12 deficiency varies from year to year. And there are various factors that can impact that. So climate change, food insecurity, conflict can actually make the B12 prevalence vary globally from time to time. If we look at older adults, we know that B12 deficiency is decreased in elderly populations. You can see the prevalence is actually much higher, 5 to 14%. And in the NANS review, the prevalence is around 3 to 5% for all adults above 60 years of age. So the older age group are more prone to developing B12 deficiency. So what are some of the causes? You can look at congenital causes or inherited causes, transcobalamin deficiency. Remember, if you look at all your those mechanisms we're talking about, you can have abnormalities, genetic abnormalities, either in your QBAM receptor, either in your intrinsic factor production, either looking at the parietal mucosal cells, mitochondrial disorders. All those factors will contribute as genetic or inherited causes or inborn errors of metabolism for B12 deficiency. So transcobalamin is an important transport feature. So all those transport proteins, transcobalamin 1, transcobalamin 2, also your multi-drug resistant protein, which is required to convert to transport your B12 from the enteric cell lysosomes into circulations, are all places where things can go wrong and you can get deficiencies. That, so if you're vegetarian, food insecurity, drugs like metformin, H2 receptor antagonists, PPI use, blind lobe syndrome with bacterial overgrowth, and early malabsorptive causes. So that basically means your inflammatory bowel diseases, people who've undergone surgery, bariatric surgery, ileal resection, gastrectomies, all individuals who are prone to getting those conditions, as well as pancreatic insufficiency, so chronic pancreatitis, and tapeworm infestation can all lead to B12 deficiency. So metformin, as we know, that can also be a distinctive cause of B12 deficiency. And the key risk factors include high metformin dose, longer duration of living with diabetes, longer duration of actually using metformin, higher BMI, non-Black ethnicity, and interestingly, better glycemic control. Those are your predominant risk factors for B12 deficiency with metformin, but usually it occurs much later, 5 to 10 years. It may not be as common as we think, but there are no clear guidelines as to how we actually should screen that, but we'll discuss that shortly. And how does it occur? So number one, it reduces your intrinsic factor production. You have altered gut motility. You can have bacterial overgrowth, which is common in the setting of diabetes. You can have intrinsic factor vitamin B12 absorption. This will occur at the level of the ileal cell mucosa where it was binding onto QBAM. Remember, it was an active process depending upon calcium. So again, that can be interfered with here. Also, with regard to the liver, you can have decreased clearance, for example, of your transcobalamin, which can lead to B12 deficiency. Altered bile acid metabolism and impaired reabsorption, all these factors contribute to that. And then once you affect that, you will tend to have impairment in your neurologic functioning, as well as impairment in your DNA, RNA synthesis pathways, and hematopoiesis in general. So all those will be long-term complications of B12 deficiency. What do the guidelines say? So we don't have any clear guidelines as to when to screen for B12 deficiency in the setting of diabetes. What dose should you actually supplement these particular patients who we actually pick this up? How often should we be doing B12 screening in our diabetic patients? What is clear is that if you have demonstrated evidence of B12 deficiency, either through neurologic manifestations, hematopoietic manifestations, there's a definite benefit in or efficacy in treating these particular patients, as shown by this meta-analysis by systemic review by Pratama et al. Daily supplementation, you can consider depending on the severity, whether you're going to use oral or parenteral routes or intranasal routes, as we'll see later on. So you can either have overt clinical manifestations, but you can have subclinical deficiency. And that's where you have now biochemical deficiency, without any overt clinical symptoms. That's people who are in your range of 150 to your 390. Those are people who have now subclinical deficiency, but they don't have overt clinical manifestations. But they could have subtle manifestations. When it gets very severe, that's when now you get your subacute combined degeneration of the cord. That's now seen in very severe scenarios of vitamin B12 deficiency. You can have your psychiatric manifestations, depression, dementia, delirium, and you can have your distinctive hematologic features, which we'll discuss also shortly. So symptoms: cognition, memory problems, cognitive impairment, learning difficulties, mental health, irritability, insomnia, mood swings, neurologic, paresthesias, numbness, spasticity, myelopathy, and in severe cases, quadriparesis if it's very severe, even sphincter involvement at some times. Blood, pancytopenia, macrocytosis, megaloblastic anemia with hypersegmented neutrophils. We can have hyperplastic bone marrow, glossitis with regard to specific clinical manifestations, arterial stomatitis, abdominal pain, weight loss, infertility, hyperpigmentation, other things that you can look out for. So subacute combined degeneration of the cord, that's one of the most severe manifestations of B12 deficiency. And you tend to have either the lateral or dorsal column, which is actually involved. So there you tend to have impaired tactile involvement. You will tend to have impairment in your proprioception, vibration sense. If you have your lateral corticospinal tract being involved, then the initial thing is increasing stiffness. Then you can also have hyperreflexia, and you'll also tend to have upper motor neuron signs being manifested in this particular patient. So you have your ankle clonus and positive Babinski sign. Like we said, it can progress to paraplegia with quadriparesis in the severe setting, and sphincter involvement, like I said, involving the bowel and bladder in very, very severe untreated forms of B12 deficiency. So key things, to look at your history, look at the dietary history, look at your GI symptoms, which can point towards malabsorption, alcohol intake, chronic intake of medications, your PPIs, H2 receptor antagonist. Look for symptoms of anemia and also your neuropsychiatric manifestations. Physical exam, you'll do a neurologic evaluation. You can look for pallor, jaundice, glossitis, hyperpigmentation, and your full neuro exam in the setting of severe B12 deficiency. Hematologic, the key thing, we know that megaloblastic anemia is a subset of macrocytic anemia. So you tend to have hypersegmented neutrophils, more than 5 lobes, and you tend to have a pancytopenia, so low WBC, low HB, and low platelets. How do you actually diagnose B12 deficiency? So you can do your overt B12 assay, but remember it has a very low sensitivity and specificity. Or you can actually do your holotranscobalamin 2. Those are the 2 distinctive plasma assays that you can actually run. But the best is to demonstrate biomarkers of metabolic vitamin B12 deficiency. And these include your methylmalonic acid as well as your homocysteine. Now, it's crucial to remember that you can have B12 spuriously being elevated or reduced. So spurious elevation in B12 occurs in things like alcoholism, chronic liver disease due to any distinctive etiology. That's your cancer, alcoholic hepatitis, viral hepatitis. And again, you can also have spuriously low B12, multiple myeloma, HIV, pregnancy, oral contraceptives, are all areas you can look at low B12 levels. So remember to look at those confounders as you look at your distinctive assays. So what is more accurate are your biomarkers of metabolic vitamin B12 deficiency: methylmalonic acid and homocysteine. The most sensitive and specific is methylmalonic acid because homocysteine can be interfered with in the setting of B6 deficiency, folate deficiency, as well as chronic renal disease, chronic kidney disease, and hypothyroidism. But methylmalonic acid is not interfered by any of these factors, even folate deficiency. It's the most accurate, sensitive, and specific marker for B12 deficiency. So by definition, plasma assay of B12 less than 200 with clinical signs, be they neurologic or hematologic, and you demonstrate the biomarker, specifically methylmalonic acid or homocysteine. So therefore, normal is more than 400 for optimal genetic function and also neurologic function. Subclinical 150 to 399, overt deficiency less than 150. Subclinical, like we said, you can have impairment with regard to neurologic deficits, depression, cognitive deficits, impaired DNA synthesis because of uracil missing cooperation. And again, your biomarkers are raised. So remember, when you have B12 deficiency, your homocysteine goes up and also your methylmalonic acid goes up because these are the precursors for these particular intermediates of B12. Again, remember that an elevation in homocysteine gives you what kind of risk? What's the risk of having chronic elevated homocysteine? Yeah, gives you increase in cardiovascular events because it's prothrombotic. As endocrinologists, it's a very common referral we get from ophthalmologists. And they always ask us to do homocysteine. What is it? So there are these patients who go to ophthalmologists and they get macular edema with either chronic retinal artery occlusion or chronic retinal vein occlusion, and they're not diabetic. So one of the key things you have to look for is homocystinemia in that particular setting. You get such kind of referrals from the ophthalmologist. The most accurate marker of B12 deficiency is what is referred to as the 4C B12 index. You take all the 4 parameters into account. That's your vitamin B12 plasma assay. That's your plasma transcobalamin 2, your plasma holotranscobalamin 2, as well as your methylmalonic acid and your homocysteine. These are all now grouped together into one formula, log 10, B12 times your holotranscobalamin, in brackets, your methylmalonic acid times homocysteine. So that's a distinctive formula that you use. And the beauty about this formula is not influenced by age, folate or B6 deficiency, as well as reference ranges, which can change from different geographic regions. So that's the formula that you can use. And this is the most accurate way of assessing in totality B12 deficiency. Sorry. So other tests, if you think about things like pernicious anemia, you can check your intrinsic factor autoantibodies. You can check your gastric parietal cell autoantibodies, serum gastric levels, if you're thinking about pernicious anemia. Bone marrow is not required as an invasive test. If you're looking about subacute combined degeneration of the cord, you get your hyperintense lesions predominantly seen in your posterior columns. So let's look at management. And there are various forms of management that we're going to incorporate, but let's look at the journey of how B12 supplementation has evolved. So we know it's highly concentrated in liver of animals. So they used to use liver therapy in 34, then we went to intramuscular injection in 1949, then high dose oral therapy in the 70s, and now we are at an era where you can use intranasal drug delivery of B12. So you can consider parenteral preparations, oral preparations, intranasal or sublingual. So key thing that even if you replace, most of the symptoms will take around 6 to 8 weeks to resolve. The longer you've had B12 deficiency and the longer you've had symptoms, the more likely those symptoms will take longer to resolve or may not resolve completely. Even after you've completely supplemented and you're not deficient of B12, and you now have your normal plasma biomarkers as well as B12 levels, you still could have subtle neurologic manifestations like neurocognitive impairment, as well as fatigue persisting. And again, symptoms can reappear with normal biomarkers, as you can see here. So like we said, treatment, you can either consider oral or parenteral. If you're doing injectable forms, normally we say it's 1,000 micrograms, at least once or twice a week for up to 2 years. Or you can do alternate day until symptoms resolve. Then you can do monthly thereafter for subsequent supplementation. Of course, you know, oral supplementation has its drawbacks. You can't use, for example, in extremes of age, like infants, for example, it could be difficult to administer this. Or you have poor absorption with malabsorption, comatose patients, people who are NPO because of surgical procedures, those who are vomiting, can't take in through the oral route. Parenteral complications of injection site, you have to have a health personnel to administer that. An allergic or anaphylactic reactions can be seen, cost of treatment being high. So if you're able to use this new route, it has a very distinctive advantage. Number one, the bioavailability as seen in this particular study, if you compare intramuscular as well as intranasal delivery of B12, you can see there's a very rapid rise in your initial plasma concentration of B12, and there's bioequivalence all through, even if you look at longer durations between intramuscular route and intranasal route. In this particular perspective, open label RCT, where they're looking at 2 distinctive phases, the treatment phase, maintenance phase, and looking at the B12 levels over time. Treatment phase is alternate day for 2 weeks, that's 7 doses. Maintenance phase, it's weekly for 4 weeks, that's 4 doses. All through, you can see that they're able to maintain the B12 levels at least above the threshold of 400 picograms for these particular patients. And again, if you're looking at rise in HB, there are at least 7 doses will give you a rise of 1 gram per deciliter, and the 11 doses will give you a rise of at least 1.64 grams per deciliter. And a single dose of 500 micromoles, remember each actuation of the intranasal spray is 250 per nostril, so it gives you 500. That will maintain your B12 dose at least above 400 for at least 5 days. Hence the rationale of using the once a week for your maintenance phase for dosing. So advantage, easy to administer, same bioequivalence with your intramuscular route, can be done by the patient without any clinical personnel being there. high rates of absorption, and you're able to maintain those levels above the threshold of 400 picograms. So this is Dr. Werago. She's currently in the UK. That was her presenting one of our studies at KDSG, which we're currently running. And that was her dissertation thesis topic for her MSc. So metformin-associated B12 deficiency in patient type 2 diabetes in sub-Saharan Africa. She did a narrative review. So she's one of our champions and pioneers. We're very happy and proud of her. They're there together with Dr. Kelly. And I just want to end there. So remember, global registry, B12 deficiency, 2.6 to 7.5%. Okay, so it's actually commoner than we think. Very prevalent in low to middle income countries, which have food security as a major issue. Remember, your B12 absorption is affected by age. So the older you are, the less likely you are to absorb your B12. Long-term use of metformin is normally linked to higher risk of B12 deficiency. And again, remember about your biomarkers. The most sensitive and specific is MMA, methylmalonic acid. And again, now we are in an era that we can now deliver B12 safely. So I'm going to ask the B12 team to quickly come and demonstrate for us. Now, each of us are going to use this thing. Kila mtu afungue. Kila mtu. Everyone has one.
Let's leave that to the experts.
The one that home, they can watch the video. So the video is there.
Okay, thank you very much.
Point, but I personally still feel it's a very useful drug. So generally, even for diabetes, for patients who are intolerant to metformin, it's an excellent drug for insulin resistance and improving insulin sensitivity. So at the lower doses, I think the fear that came was because of the cardiovascular risk potentially associated with rosiglitazone. So pioglitazone at 15 milligrams is considered safe. However, the only thing that I am concerned about with pioglitazone for the patients that I've used it on is weight gain. So they do get significant weight gain, but most of it is fluid, I would say. It's like more of edema rather than visceral fat weight gain. So studies have shown its benefit in muscle D, confirmed steatohepatitis in patients with type 2 diabetes. And that's, I think, what Dr. Murunga also alluded to, is if your patient does have type 2 diabetes, then it is a drug to consider. But remember to be cautious with patients with heart failure, patients with osteoporosis or, osteopenia. So those are, I think, some of the risks. And then monitor for weight. If there's significant fluid overload, then you need to stop it. That's my take.
That is very well articulated. Thank you, Dr. Saira.
Honestly, we still use pioglitazone because we really are yet to get another drug like resmetirom. I think is not even in the country yet, and even the cost implications. But then one of the things you have to be cautious. I've seen people prescribing 30 milligrams, which is the dose we use in diabetes treatment, rather than when we're treating muscle D. It's only that there's a subset of patients who, when tested, if you have a genetic risk, Ilovi, genetic risk of bladder cancer, then perhaps you'd not want to use pioglitazone. But as of now, I can tell you most of our patients, because of that risk of progression to cirrhosis, that we are now consciously screening. So one of the things I wanted to actually throw the question back to you is we do quite a number of our LFTs, and you see an elevated gamma GT or ALK-phos. What would you do? This is a patient, you're a doctor in Mashinani, we don't have access to gastros. What would you recommend for these patients who are, say, BMI of above 30, about 35? You find a gamma GT that's elevated, the patient is not, there's no history of alcohol intake. Would you then proceed to say, maybe this is a patient, once you have done the FIB4 score, this is a patient you'd want to do fibroscan, and then later on maybe put them on medication as well as lifestyle modification, or not? Because we're finding so much of this deranged liver function test, and we really don't know what to do with it. You know, the problem I think we have when we're doing wellness checks is we do them, but then we go looking for trouble because a patient will say, I found this elevated. What do you do?
Thanks, Rosie. In a patient like that, we have to try and figure out what is going on. It may not only just be the muscle D. Do an ultrasound, definitely. They might even have things like gallstones. causing that, especially if they're in the bile ducts, choledocholithiasis, because many, often, it might be something of that nature. They'll need follow-up, more than one test, more than one LFT, because maybe they drank a lot the night before, some alcohol, and it could be high. So you've got to tell them now, abstain from alcohol, let's check. But I would definitely do an ultrasound. A lot of these patients, we have to screen for hepatitis B and C, especially because those could have long-term implications in terms of chronic liver disease. And then you're right, doing the FIB4 is a great way, especially if you're out there. It's a very quick thing because you may not have access to the FibroScan. Even here in Nairobi, it's really not accessible. Very few places have a good machine. And you do the FIB4. If it's high, like we've seen, then you need to go to the next level and try to either do, because now that tells you that the patient could have fibrosis. Then you either try to see if they can get a FibroScan or send them to a gastroenterologist for further assessment. But obviously that may not be available every time. So then in that case, then you assess the patient. Now, if you're talking about, they have fibrosis and you think they have muscle D, maybe you've seen it on the ultrasound, they fit the profile, they might be diabetic or overweight. Then how do you handle that? Number one, they have to lose weight. We talked about 10% of the body weight. They need to lose 10% of the body weight, at least. You just have to encourage them. It's not an easy process. For very few people will manage to do that, but you just have to just walk with them along the way. So that's the first thing. Now, remember, you've ruled out hepatitis B, C, there's nothing else. Now you're centered that this is what you're dealing with. Then if the FIB4 was high from that calculation, then at this point you have to consider, could you go into pharmacologic? If they are, so you've done the lifestyle, they're losing weight, exercise, all that. If they're diabetic, that's when now you start thinking, maybe we go to pioglitazone. They may not be able to afford semaglutide out there. And with semaglutide, it's just mainly the injectable one that has been shown to help in these situations as opposed to the oral. And so if you're out there, then you'd consider, as you said, going to that low dose of pioglitazone. If they're not diabetic and the fibrosis is starting to go up, then you have to now, think, how can they lose the weight? If normal lifestyle is not working, you've got to think about, if they're very overweight, is bariatric surgery an option? What about endoscopic therapies? Is balloon? There are new things which are emerging where you can do endoscopic suturing or even surgical. But otherwise, now there are generics available of semaglutide, and it's getting cheaper. So I think one will look at all those options based on the FIB4. If the FIB4 is less, then in that case, then just continue to push with non-pharmacologic.
Any online questions? I don't know who's checking our online questions. Online questions? Scroll down.
They're just asking for the notes.
Perfect. Okay. So I think we can close. So Linda, over to you. So.
Thank you so much. I think they're just asking for the talks because of the new terminologies. So on behalf of KP Nairobi branch, thank you to all of our participants, our sponsors.
Close this session. Close this session.
Okay, no, sorry, we're closing this session, my session, not the conference.
Okay.
Yeah, so the next session.
Okay, apologies for that.
Sorry.
So Dr. Saira will now take us through the last session.
B12 deficiency, Eric.
Yeah, yes.
Surely. Yeah, so I
It's
think,
obesity.
all of us are quite tired, I think, at the end of the day. You can see if the chair himself wants to close the session, then we are at the tail end. I don't know who is going to listen to us, but I just really hope I get a few ears just to take you through this very interesting case that we had. And we have an excellent panel that I would like to call upon on the stage as I start the case presentation. We have Dr. Nicola Okech, who will be the endocrinologist for today. Well, she is an endocrinologist every day, but she'll specifically be our endocrinologist for this case. Welcome on stage, Dr. Nicola.
You won't be able to see the slides, so after your presentation.
Oh yeah, if she can see them from there. Is that okay? Dr. Ajua? Dr. Ajua is around? Yes, Dr. Ajua is our gastroenterologist, and Betty Okere, the nutritionist. So, could I get the... So this case was actually referred to me by a neurologist. Who would have thought? A neurologist referred to me this case just because their patient had a condition known as idiopathic intracranial hypertension. How many of you know what that means? I believe all of us do, right? So the patient actually came presenting with a history of known to have idiopathic intracranial hypertension. Our patient is a 44-year-old female. Currently, she was not on any job because she had these significant headaches due to the idiopathic intracranial hypertension, which were disrupting significantly her job. But otherwise, she used to work as on a desk job most of the time. She was referred for the management of obesity in relation to idiopathic intracranial hypertension. So the neurologist called me one day and said, you know what? I've read this paper that semaglutide does very well with idiopathic intracranial hypertension. What are your thoughts? I said, okay. Does the patient have obesity? Yes. Either way, refer the patient to us. So that's how the story started. So she's also got a history of bronchial asthma, long-standing. And these are her home medications when she first saw me. She was on acetazolamide, gabapentin, and budesonide formoterol as an MDI that she was taking for asthma. So the way I take an adiposity-based chronic disease history or obesity history is using an ABCD framework. And that's based on a barophenotype study that I came across and I presented as well. And it makes my life much easier because I tend to remember what to ask for and try not to miss out on stuff. So A stands for adiposity. So if you can see, this is like how the adiposity came into being. So the onset was gradual. She had generalized body weight distribution. And we see that she was working for long hours as an administrator, which included long sitting hours. So she was more or less on a sedentary lifestyle. As an adolescent, she already was on the higher side at 70 to 75 kgs of weight. She's had this long-term inhaler use, steroid inhaler use, and also used prednisolone on and off for asthmatic attacks. Interestingly, she also had a history of post-traumatic stress disorder after loss of her child or loss of a pregnancy in 2021, and she used a couple of antidepressants for over a year, and this made her gain even more weight. Okay, when we look at the B, we look at behavior. So looking at her lifestyle itself, so she reports good eating habits. She's been on some diets, but not on any specific diet. She had never seen Betty Okere or any other nutritionist for that matter. And if we look at her physical activity, then she did have limited. She had some knee joint pains and had an element of early osteoarthritis. When we look at C, we look at the comorbidities, complications, and potential causes. So when you look at the comorbidities, she had actually, like the IIH, I've already talked about the asthma that she had. And additionally, now when we look at the list of complications, we screen for some of these complications in patients who have obesity. So she had degenerative joints on x-rays. She did have a low risk score, interestingly, on the stop bang. She did not have any known history of diabetes, hypertension, muscle D or dyslipidemia, but she did have gastroesophageal reflux disease. And that's why Dr. Ajua is here. So she did have symptoms of reflux, which were managed on and off by PPIs and antacids. She did have irregular menses over the past several months and oligomenorrhea, but no other symptoms specifically suggestive of polycystic ovary. Like she did not have hirsutism or acne, did not have any scalp hair loss. She did not have any features of hypothyroidism or Cushing specifically, nor of any hyperprolactinemia, but we have noted that she was using steroids and no other additional medications. When we look at D, that's dysfunction. So she did not have obvious dysfunction, but we have seen she had this knee joint pains which limited her from conducting physical activity, okay? How about E is the expectation. So whenever you are discussing with a patient about weight, you have to know what is their expectation. You know, like in our culture, people like what Dr. Murunga said, women like to be a little big, especially the older women. When they lose a bit of weight, the problem I get, most of them come and tell me, I don't look like a grandmother anymore. And that depresses them actually, and they don't want to lose weight. So you look at what the patient expects out of this whole journey that you're taking them through and why they expect what they expect, okay? And then I've added the F to say family history. We usually tend to forget that. So you can see that there's the parents were both of normal weight, but the brother was also having obesity, but there was no other chronic illness in the family. So on examination, really nothing too dramatic that I noted. I checked for syndromic features. I did not find any. She had this generalized body fat distribution. And you can see the BMI was in the morbid obesity category. She was not of Asian descent. So this is considered as morbid obesity. And you can see her waist circumference and waist to height ratio. So this is a novel, let's put it in quotes, as a tool or a rather measurement that is showing cardiovascular correlation rather than only looking at the BMI. And current guidelines and the current upcoming guidelines are going to be including these measurements. Her systemic exam was otherwise unremarkable. So this is our case, yeah? And I've just put up this slide to tell us that we are kind of moving away from just describing obesity as obesity, but moving towards an ABCD description. It's adiposity-based chronic disease, whereby you're looking at obesity or adiposity as a chronic condition which can lead to issues related to your functional disturbances, medical and biomechanical disturbances, as well as psychological disturbances. And if you look at this, this is just to show us what the BMI classification of obesity is in both Asians and non-Asians. And just quickly, before I move to our panelists, I want us to look at this particular flowchart for obesity diagnosis, because we'll focus more on the management aspect as we move to our panelists. But as you can see, the BMI classification alone is no more used to define obesity and its associated impact on an individual. We have to look at the BMI, waist to height ratio. So if your BMI is above 30, of course, that's classified as obesity if you're not an Asian. If your BMI is above 25 and any other complications with the waist height ratio of more than 0.5, that's already significant as a definition for obesity. And then you can see the clinical impact that you have to also assess for your patient, the way you have seen us do. Then you have to do your staging of obesity, do an initial management plan, move ahead and put them on a long-term management plan where intensification, adherence counseling, and lifestyle modification forms the key. So I'll now move to our questions, okay? So at this point, it will be a story of this patient. I'll stop here and ask our endocrinologist, at this point, how would you have worked up this patient, first of all, and what would you be looking for specifically? And what do you think, as far as you've seen, she's been on multiple medications and all, what do you think could be some of these medications that could be associated with obesity? Are there any alternatives?
So thank you, Saira. So when you're looking at patients who present with obesity, one of the first things, of course, is even as you're doing your BMI, is also to do a body composition analysis, because body composition analysis also allows you to follow up the patient. And I'm sure Betty will talk about that. So when it comes to evaluation, you basically want to look for the conditions that will probably lead to obesity and the conditions that come about as a consequence of having obesity. In addition to that, you also want to look at certain things that might influence follow-up. For example, if you choose either pharmacological management or bariatric surgery. So when you're looking at conditions that may cause, you want to screen for your thyroid. So you do your thyroid function test. Then you want to look for Cushing's. So you'll do your overnight dexamethasone suppression test. And then, of course, conditions like polycystic ovarian syndrome, those ones you have to screen for because these patients also present with obesity. When you're looking for the consequences, the most common thing, of course, with patients who present with obesity is metabolic syndrome. So you want to look at their HbA1c. You possibly also want to do an OGTT. You want to look at their lipid profile, their uric acid, liver function test, possibly if you can, and you're suspecting, as Dr. Murunga had alluded to earlier, muscle D, you want to do your fibroscan. And then, of course, you also want to look for other things because these patients will present with osteoarthritis. So you're looking at their joints, you're looking at their scans. And patients with obesity also present with conditions that we know, obstructive sleep apnea. So sleep studies are very important in these patients. And I'm sure Dr. Ajua will discuss the issue of GERD. So upper GI series is also an option when you're evaluating these patients. In addition to that, there is a group of patients, for example, those who may be considered for bariatric surgery, that you would also want to do probably an abdominal ultrasound to rule out cholelithiasis, because in the setting when you opt for doing surgical procedures, you can also do a cholecystectomy at that point. When you're talking about the medications, when we look at this particular case, the patient has been on some medications that would probably lead to obesity. So the use of steroids on and off could be one of the factors. And then anti-seizure medication, gabapentin, has been shown to cause obesity. And in this case, you would opt maybe to change her to something that like lamotrigine, which doesn't cause obesity. Patient who's had post-traumatic stress disorder, maybe they were on antidepressants. We know very well the antidepressants that we use haloperidol, quetiapine, or olanzapine. Those ones are known to cause obesity. So we really want to give them options. And what I think is available is aripiprazole that has been shown not to cause. Then, of course, patients with diabetes, insulin, sulfonylureas, pioglitazone. We've discussed these things just now. That's why we were saying even Dr. Murunga had given the talk for us. So we want to give medications that either promote weight loss or are weight neutral. So you want to look at your GLPs and your SGLT2s and your DPP4s if they're available. Other things in ladies is hormonal contraceptives. So you want to look at those things and give them maybe different options like barrier methods in order to assist with contraception.
Wow, thank you so much, Nicola. I gave you a handful and you took it very well. Maybe we move on to Betty. All of us here are actually really waiting to hear you talk. Seriously. So this is the current diet of the patient. I hope you can see it. What they take for breakfast is what most of our patients take, but this one is a little bit more aware. You can see that they're actually taking multi-grain bread. They take about 1 to 2 eggs or chicken pieces. And occasionally they go for avocado. Someone really nice talked to them somewhere. They take 2 small bananas as well at breakfast every day. Snacks, you can see mostly snacking on cucumbers, yogurt. Sometimes they even go overboard and take mandazis. For lunch, you can see the typical lunch, dinner, most of the time the food that they're taking, ugali, spinach, sukuma, salad, meat, steak, meat stew, and they put all their fruits at dinner time usually. Okay, so in this particular patient at this time, I've seen the patient and I said, okay, at least let's start first with dietary modification. What would you advise to this patient at this point? And in your own knowledge or experience, do you use only BMI as a marker of obesity assessment?
Thank you very much, Dr. Saira. So for starters, BMI cannot be sufficient as the only means to try and assess for adiposity. I know the challenge that we have in most places would be not having anything else to use for screening. But in the absence of that, if after you've used BMI, because it can be very subjective, what about the waist to height to weight ratio? There's the waist hip circumference. and then you find the ratio. That is also another easy one because all of us probably would be able to find a tape measure somewhere. If you don't have a waist circumference tape, that would also be an indication. In some areas, you can also check for the use a fat video caliper to just check for distribution of adiposity in the body, if it's available. If you have a very sophisticated facility, then you can go for the DEXA scans and the MRIs. I haven't used those myself, but the most common one and the one that nowadays most of us are using, I'm using that as well, is the body composition analysis. There are scales that would be able to define for you which weight are we looking at, so that even when the patient starts losing weight, then you're not just happy because of the physical appearance of the patient, but you'll be checking, are they also losing the muscle mass, which you do not actually want to lose. And one thing that I'm seeing commonly now is for the patients on semaglutide, yes, the weight loss is there, but most of them are also coming with very, very low muscle masses. And you might never really be able to recover your muscle mass even after weight loss, especially as you age. So that's something that we also need to look at. Yes, it's a fast means of losing the weight, but so many other things to consider. How about what this patient is eating? So at least for breakfast, it is defined. I can see some tea there, multigrain bread, hoping it is actually a multigrain bread and not colored. And then my question to this patient would be, if they're trying to reduce their calories, they were trying to minimize the amount of carbohydrates that they were that they are consuming. Then for the tea, for example, what kind of tea are they taking? Are they taking the typical Kenyan tea where the milk is more than the water? Does it have sugar? And if it has, how much? How much are they willing to start reducing? Because as we look at this patient, we also have to know what is it that they can be able to do and what would they struggle to do? What are the challenges that they would be facing? So if it's the tea, then it's the milk. Can we go for English tea as opposed to the thick African tea as we know it? Can we reduce the amount of sugar that is being put in there? Occasional avocado. So if I'm given the option for this patient, if I'm given the option of a banana versus the avocado, then the banana will come with a little bit more carbohydrates than the avocado would come in. And if you're looking at the back end in terms of the lipids, then they would be better off with the avocado. I go to the snacks, hoping they're not taking all this at the same time. But then I would go for low calorie and higher nutrient. So yes, the yogurt would be there, but what kind of yogurt are they taking? Is it a plain yogurt? Is it a flavored yogurt? If I go to lunch and the dinner, they have also indicated that they have a sedentary lifestyle. So if they have ugali and spinach, how much of it are they having and how much of the protein are they taking? And probably just to encourage them that instead of trying to eat the mandazis at snack time, then that is when they would redistribute their fruits so that they do not have hunger pangs in their next very large meal. But that would be where I would start from.
Wow, thank you. Okay, I think we'll move on. And so these are baseline tests, like from what Dr. Nicola said. As you can see, the thyroid function tests were normal. It's like almost as if the order that Nicola put them at. So you can see the TFTs were normal, the overnight dexamethasone. So just to tell you, an overnight dexamethasone suppression test is a really simple test to assess for high cortisol production. And you know what you do? You tell the patient, take 1 milligram of dexamethasone. The tablets come in either 0.5 or 2. So if it's 0.5, they'll take 2. If it's 2 milligram, they take 1. I mean, half of it. So they take that at exactly 11 p.m. the night before the cortisol test. Remember, doing only a random cortisol test to assess for high cortisol is useless. Okay, the place where it has some value is when you are checking for low cortisol, but not for high cortisol. I think that's fine. Sorry, yeah. Thanks. So basically, so you'll give your dexamethasone at 11 p.m. and check for the cortisol in the morning, 8 a.m. So that's what defines the overnight dexamethasone suppression test. For this patient, it was normal. We did the hormonal assay for PCOS. So because she had irregular menses as well, everything was basically normal. UECs, LFTs were normal, but her fasting blood glucose was a bit elevated at 5.8 with a cutoff of 5.6 and an HbA1c of 6%. Which is in the pre-diabetes range. Her uric acid was normal, and you can see her liver function tests. ALP was slightly elevated, but the rest of the tests were within normal ranges. We did her FIB-4 score, which was actually normal. It was less than 1.3. And her lipid profile, you can see, had LDL of 2.3, Triglycerides were normal. HDL was also not too bad, in spite of her being physically inactive. And her cardiovascular evaluation was basically unremarkable. So she came back with all these results, and we now started discussing options of weight loss. And we discussed about the aspect of pharmacologic therapy, because she had seen a nutritionist by this time. She had changed her diet. And after much discussion and realizing that she actually had, she was ready to go on to pharmacotherapy as well. So at this point, maybe I'll put a question to Nicola, is what would be your options for pharmacotherapy for such a patient, especially considering she already has complications like IIH, she does have pre-diabetes, as we have seen, she has osteoarthritis setting in. What would be your options for this patient? Let's imagine cost is not an issue.
So specifically for this patient, I would probably opt for a GLP-1 receptor agonist, mainly because of, her weight, high BMI, and her comorbidities. So that would be my first recommendation for her. However, there are other options available for pharmacological management of weight. And they range from using Orlistat to using phentermine to using even, if tirzepatide, if it was available for her, because tirzepatide does give a greater weight loss than semaglutide. So when it comes to the way that they act, semaglutide or GLP, GIP usually generally work centrally and peripherally to suppress appetite and also to slow gastric emptying. And then the phentermine does suppress appetite as well. And Orlistat is a pancreatic lipase inhibitor, so it does prevent absorption of fat. So those are the options that would be available for her.
So FDA approved?
Yes.
Yes.
But just to mention semaglutide, if this patient did not have obesity, it's not approved for IIH. It's not FDA approved.
As yet, yes.
Yeah, as yet.
Yeah, there are studies clearly that are showing the benefit with IIH, but the mechanism is through improvement of obesity. So I agree with you. Great. So our patient now started semaglutide. So it's as if Nicola was sitting in my clinic. So she started semaglutide at 0.5 milligrams once a week, was very happy that she has an option. Lifestyle modification, she had intensified and she continued with that. And now at this point, maybe I'll just ask a question to Dr. Ajua, because now you remember this patient had gastroesophageal reflux disease. So what are our concerns with starting this GLP-1 receptor agonist? What is it that we should be warning our patients on? Why is it that I'm starting at 0.25? Maybe just take us a little bit through that, and what side effect profiles should we be looking at, especially in this patient?
So, good, thanks for the interesting case. So, there's a lot of focus so far on pharmacological methods of managing obesity. Frankly, unfortunately, I'm on the opposite end for many years. I've always been a firm believer that we should slowly switch, generally worldwide, for those who can afford, to tackling obesity using one of the bariatric methods, either surgical bariatric methods or endoscopic bariatric techniques. Frankly, that's where my focus and my thoughts are, because pharmacological actions, we have had them for decades and decades and decades, and our patients rarely ever go into what they call remission for diabetes. The obese patients rarely ever make it down to normal weights. So I know the pharma guys won't love us very much, but that's the truth. So regarding the GLP-1s, so the issue with GLP-1s that we have found so far are basically the GI manifestations. You need to watch out for, it causes a bit of bloating, it will cause nausea and vomiting actually in some patients. Abdominal pain, not so much. And then diarrhea or constipation. Those are the four major things that it gives in terms of GI manifestations. And the reasons for those ones are quite clear. Because of the stasis, it sort of induces a gastroparesis, basically. Slows down gastric emptying time. And of course, the longer your stomach is full, the more likely you are to get other GI symptoms, especially if you're prone to having reflux. So that's the main problem which we have with
and while at it, would you then have recommended It's just a question off the cuff. Would you have recommended that we put her on PPIs as we give her semaglutide? Would you be doing that kind, like the way we, even with metformin, sometimes, you know, if they do have already got some GI issues and you want to introduce and give it a trial, would you put a PPI along with starting?
Yeah, you could do a PRN use of PPI, yes. It will be,
Okay,
it will work very
great.
well. The other thing, also the other trick with the semaglutide is start always with the lowest dose. Do not go to the higher doses to begin with, because the symptoms, of course, the adverse effects are more when the dose is higher.
Yeah.
So what has been shown so far is also the age of the patient matters and the obesity level or the weight of the patient in terms of the BMI. So there's found that those between the ages of 40 and 60 have slightly less symptoms than those who have who are above the age of 50 and 60. And those who were found to be at a higher weight on initiation also tended to have higher adverse effects of semaglutide.
Excellent. So other things that you also need to look out for is ask for a history of thyroid cancer in the family. Medullary thyroid cancer, if they have, then you want to try and be very cautious when you're using these agents. Also, any history of pancreatitis. So that's another thing that you need to be cautious with some of these agents. And also, which I'll ask Dr. Nicola at some point, is the aspect of retinal involvement, which studies are now showing up, but we'll discuss this as we come on. So in this patient, we gave her 0.25. She tolerated quite well. So I increased the dose. She actually lost 1 kg weight in a month's time. I saw her after a month. She had lost 1 kilo, but at least she had not gained. So when your patients come, the expectations realistically, you first visit, you have to try and tell them that you don't expect a huge weight loss, but at least they shouldn't have lost or rather gained more weight. That's your first success, right? Now you're starting at a very small dose. Some patients take longer to lose weight. Remember, she can't physically be so active. So it's mainly dependent on what she's eating and that small dose of semaglutide. So we increased the dose to 0.5 milligrams, but she came back in 2 weeks with worsening GERD symptoms. She had worsening reflux. I even put her on a PPI, but she still had issues and she had diarrhea, just like Dr. Ajwa said. All her stool tests done at that time were normal, and we reduced the dose back to 0.25 milligrams once a week. We reviewed her in a month. What's interesting is she couldn't even tolerate now the 0.25 milligrams. And in retrospect, she told me, oh, even at the first time, I did have a bit of nausea, but because it was helping me, I continued with using it. She interestingly had also developed a pruritic rash, which she attributed to the semaglutide. And so we had to hold the semaglutide at this point. We also attempted phentermine, which Dr. Nicola mentioned, but she could not tolerate it. She started having headaches, again, GI side effects. So now I'm in a position where I'm a little bit stuck, right? So are there any other pharmacological therapeutic options available at this point, Nicola? And like precautions, I think I've already mentioned, but the aspect of pancreatic complications and malignancies and ophthalmologic complications that have now been shown to be associated, could you please mention a bit on those?
Yeah, I mean, now with pharmacological options, we are a bit limited for her. You've already tried her on GLP, which would actually give her the highest amount of weight loss. But I mean, there is Orlistat. The problem with Orlistat is that because of the way it acts, it causes patients to just have a lot of discomfort, GI issues, a lot of soiling of the clothes because of oil, from the prevention of the lipase activity. The other option is naltrexone. I'm not sure whether it's available locally, but it's also an option for pharmacological management. Now, you've already mentioned the precautions that you should take in patients who have a personal or a family history of medullary thyroid carcinoma or a history of MEN2. Those patients should not be initiated on GLP-1 receptor agonists. When it comes to data on the complications, now it's very interesting because preclinical studies did actually show benefit in the eye. But you see, preclinical studies are mainly done in animals. But now when it came to the clinical studies, that is the SUSTAIN-6 and the LEADER, it was actually shown that using of the GLP-1 receptor agonist did increase the risk of a worsening of the diabetic retinopathy. Now, it's not too clear why there was a difference between the preclinical studies and the clinical studies. What is thought is that, one, they did not give enough time for the study because these complications tend to occur 5 years down the line after you've initiated treatment. I think the LEADER and the SUSTAIN either took 2 years or 3-point-something years to do. The other thing is that with proper glucose control, of course, we know that diabetes retinopathy can sometimes worsen, so that could be one of the things. And then in the beginning of these studies, they did not actually set out to study complications of the eye. They were actually cardiovascular outcome studies. So there could have been a bias towards selecting patients with severe diabetic retinopathy who were actually put in the cohorts who were to receive the semaglutide. But nevertheless, that data is already there. When it comes to malignancies, there has been shown to be some benefit in breast cancer, prostate, endometrial, ovarian cancers with the GLP-1 receptor agonist. But the flip side, it does increase the rates of pancreatic cancer, and that is usually related to the risk of pancreatitis. So what GLP-1 receptor agonists tend to do, they cause increased proliferation of beta cells and differentiation of the ductal cells in the pancreatic. So when the cells differentiate, they do block that duct and cause increased incidence of acute pancreatitis, which can become recurrent, chronic, and predispose patients to getting pancreatic cancer.
Thank you very much. And now that jumps us now to, so Nicola told us we are limited in pharmacotherapy, right? So our role kind of we are hand-tied. So then we say, okay, Ajua, come in. Ajua, what are you going to do from here? Is there any other procedures which you have mentioned in the beginning, the aspect of device therapies like balloons, and could you tell us a little bit about these devices? What do you think we should use? How long is the durability, sustainability? And at what point would you say, okay, this device is not adequate and we need to push to step 3 now?
Good. So thought you never ask. So here we are. So as I said, I'm a big proponent of even starting with these, to be honest. So endoscopic bariatric techniques are really getting a lot of relevance in the world. Many people are actually moving away from the surgical techniques. Now, the surgical techniques for the last 4 decades has been probably the gold standard. The Roux-en-Y gastrectomy has been the main thing that has been used, bypass. Problem with that procedure is the complications have been slowly getting a little bit out of hand. There's leaks of the anastomosis in the anastomotic sites, there's stenosis of anastomotic sites, etc., etc. So the worry is now is the surgical technique and skill available to us might be a little bit of an issue. I'm talking about not only in Kenya and Africa, but even abroad, it's becoming a bit of an issue. So most people are trying to see how they can move towards now the endoscopic techniques. So endoscopic techniques have come a long way. And the most common and most basic one probably is the device, the balloon, the gastric balloons. So currently we have available 2 types of them, essentially. There's a type which you can swallow by yourself, and basically it opens up in your stomach. And that's the Aluron balloon, I think. And then there's the other one, which is now the one which is placed endoscopically. The choice of which to use for me is quite clear, and there are reasons for that. I always go for the endoscopic balloon. And the reason for that is because it is very, very important that there are 2 or 3 almost contraindications for having a balloon put in your stomach. One is if you have a hiatal hernia. Ideally, if you have a hiatal hernia, grade 3 or 4, you should not have a balloon placed in your stomach. The reason for that is because you have increased risk of the balloon coming a little bit upwards into your esophagus. So that's a big risk. And number 2, if you have any gastric pathology, if you have an ulcer, for instance, you ideally should not have a balloon put. So the query which I have been raising with the companies who have their Aluron balloons, where guys are swallowing it, is you do not know the state of that person's GI system. What are the risks which you're putting the patient to? One of my patients, I put my 5th five patients before, 5 patients ago. I did the scope and she had absolutely no symptoms. I did the scope to put the balloon, ready to put the balloon, and she had a huge ulcer in her duodenum. So I just came out with my scope, treated her for H. pylori, and she came back after a month and a half. We rescoped, no ulcer. We put the balloon and she did very well. So those are the risk benefits for the different types of balloons. So that's the balloon technique which we have. The thing with the balloon, you have to also make sure is the patient does not just take the balloon, put in there, and then goes off and continues with a normal lifestyle. The lifestyle modifications must be emphasized. It's very, very important. So the diet must continue and exercise is extremely important. The issue with the balloon many people are worried about is the issue of the side effects. So the side effects occur for mostly for the ones I have put 1 week and a half at most. There's a lot of cramping of the stomach. There's a lot of retching and nausea and things like that, which we manage very successfully with medication. So that usually is not a big problem. The problem you have now is people going back to their old lives after they remove the balloon, because the lifespan of the balloons, the endoscopic ones usually are 6 months. There's some newer ones which are coming out which are about 12 months. But after that, you have to remove them. You can place another one after a certain period of time again, which is fine. The issue now is weight gain after you remove the balloon. That's been a big issue. And the reason for that is because most people have advertised themselves, they put balloons and stuff. You put the balloon and then he tells you, off you go, see you in 6 months. The lady will come back in 6 months' time, and 6 months after that, she'll be double the size she was. So the outcomes are really good in terms of the weight loss. We've had 17% to 20% of total body weight loss from baseline, which are pretty good results for most people. Most of the ladies I've put it in are quite happy. Yeah, so that's the balloon. So the very important thing is the balloon has to go together with the other methods, which are very, very important. So if I could take you through now the other 2 or 3 methods. We have endoscopic sleeve gastroplasty. We're able to actually reduce the size of the stomach, almost similar to the surgical techniques using endoscopy. We're able to suture the stomach, the greater coverage of the stomach into a very small tube. So you end up reducing the size of the stomach quite well. It's a very good technique. Nobody is doing it here yet, unfortunately. It's not that difficult to do, but the threshold for the learning is a little bit high, but eventually that will come on board for sure. It's a very good thing which is coming up and is replacing a lot of the surgical options. Another method is using what they call a sheath. So we're able to put a sheath into your duodenum with an endoscope. So that sheath comes out into your stomach and then it goes along the lining of your duodenum. And it stops somewhere just about the jejunum. So what that does is food that goes out of your stomach into your duodenum, it bypasses the cells which absorb nutrients within your duodenum. And with that, you end up losing a good amount of weight. So it's a very, very good technique, which is also available abroad. Quite excellent. I think something which will be done here soon. The other thing and final thing which we're able to do using endoscopy as well is we're able to actually use a balloon, a hot balloon, put it into your duodenum. We fill the balloon with hot water. And what it does is it ablates the cell lining of your duodenum. So what that does is new cells will regenerate. And it has been shown, actually, interestingly enough, that the new cells that regenerate, actually, they have less absorption for a lot of nutrients. And number 2, it actually has been shown that it actually improves your insulin, reduces insulin resistance and improves your glycemic control.
Yeah, just hot water.
Hot water in a balloon.
Hot water.
So you put a balloon into the duodenum with the endoscope. You inflate the balloon with very hot water. The water ablates the cell lining of the duodenum.
Through the balloon, right?
Yeah.
Because the message you may have, people will actually start drinking hot water.
No, not
from today, right?
Please don't drink the hot water, please. You'll get esophageal cancer.
The esophageal malignancies, don't start doing that.
No. It's using a balloon within the
It's amazing. When I even put up this question, in my mind, it's just the Allurian balloon and the endoscopic balloon. And it's amazing that there are all these techniques available. And very soon, Ajwa, I think maybe to the president, we should be sponsoring people like this to go and learn these techniques. Probably, and I think these are things that as the Gastro Society, some of you could be taking up and taking it as a subspecialty. Excellent. Thank you so much. So Betty, Ajwa has gone in fix that endoscopic balloon in our patient, okay? My concern is, and many patients, that's what they say, is what dietary modifications do they need when these devices are in place? Because we are going to see more and more of these devices being used with more specialists on board and them getting a little bit cheaper as well. So what dietary advice would you give? And in the same regard, maybe you could touch on the dietary advice post-bariatric surgery as well.
Okay, thank you. So one of the few things that I insist a patient must do, even if they want to go for bariatric or balloon, you must be able to demonstrate some degree of discipline towards doing the right thing. Because it's one thing to place the balloon, and then you come back after 6 months and you're probably getting on to be worse than what you were before you started. And again, for the risk of increased GI symptoms that would be undesirable, then you probably would want to do a PPI therapy, probably 7 to 14 days before that, just so that when the balloon is in place, then we don't have a lot of reflux and all that's going on. The other thing would be slowly try and reduce the caloric intake of this patient weeks towards, usually 4 weeks to 6 weeks before they go in for the balloon, so that by the time, because remember, after you started the balloon, you probably need only 300 to 600 calories in a day. For someone who's probably been consuming 4,000 calories in one day, that's very little food.
And that's the challenge we face usually, is this transitioning, you know?
Exactly. So you have to start tapering them down before they go into the balloon. And then when we are doing the liquid diets, for example, it has to really be monitored in such a way that we can get as much nutrients as we require. So we most of the times look at the macros only, and in a liquid diet, you might get that from the glucose and everything else, but you might not be able to get the micronutrients in. So then at the end of the day, maybe 3 months later, we are talking about somebody who is deficient in micronutrients, and that's not a very good thing. And the same thing would happen to people who go on bariatric surgery. And then once they get to the 3rd month towards the 6th month, how do you ensure that they're at least getting 1,000 calories or 1,200 calories, and that they are able to maintain that? And once they come, so the 6 months are over and we're trying to maintain what is the least that we can do, 1,200 to 1,500 with increased exercise that is monitored. Also, when it comes to when the balloon is still in there, what is the risk of alcohol intake? Of course, we say no alcohol at that point. Caffeinated and all those fizzy drinks, it's out. High sugars, they'll not come with nutrients. That's out. How do they drink their water? Do they? And I see most of us when we think we feel thirsty, what we do is have water and gulp all of it down, and the next thing you go is you go to the loo. So that what has not helped you. So are they able to sip little bits of water in between their meals, and to just help them with ensuring that they're properly hydrated, usually 2 liters and above of water. Maybe not use a straw, because that would also cause ingestion of a lot of gases and worsen the bloating. And while we are counseling these patients, whether it is we're going to use the pharmacological approach, the surgical, the balloons, devices, or just a lifestyle change, we also must understand where these patients are coming from. What is their concern? You mentioned one, an elderly Indian lady would say, I do not want to look like I'm not a grandmother. Or somebody will come and say, if I change how I look, my partner may think I'm up to no good. Okay, and those are concerns. Or the fact that I have this status in society and there's a way I should look.
Or even interestingly, they say I'll be blown away by the wind. How
Yes.
many of you have got this?
I have got
It's
that
very
enough
common.
times, but I always say, if I have never been blown away by the wind, you will not be blown away. And also, what is the patient willing to give up? When we got stuck on the pharmacological aspect, for example, and the only thing was left was Olistat. And then the question is, from what the patient was eating, how fatty was it for the Olistat to be relevant? So it wasn't relevant. Yes, they have all this osteoarthritis and, they are unable to move much, but do we have low impact exercises that they can engage in? Can they say, I want to learn how to swim? So they'll have learned a sport, they'll have managed to lose some weight, and they'll be happy about it. So again, what do they want? The goals should be in collaboration or in agreement with the physician or the dietitian. Don't write them down for the patient. They must be doable. Even if it means the first 1 week, they are going to just give up a teaspoon of sugar, and in the next one, they'll give up the second one. Or instead of having all their fruits together with the main meal, they'll move them to the next meal. And then the frequency of the follow-up. Most patients will be referred to a dietitian, and once they come, all the knowledge you have 6 years and above, they want it in one day. I can bet you they'll only live with one thing. So the frequency of the follow-up is also important. You'd rather spend 2 weeks seeing this patient every so often until they master the art, and then you can see them after every 3 months. And if cost is not an issue, then they should as well do it. But seeing a dietitian today, and then you see me again when now your sugars are terrible and you have every other thing, may not really help, because we always start from zero.
Wow, excellent advice. I think that applies more or less even to bariatrics. So we'll probably take it as, also by extension to the same, the dietary advice and slowly reducing your calories and then remaining on low level calories still. Your body can tolerate it depending on the procedure, isn't it? So, so here then this is the last question, I believe, for you, Nicola, because we cannot leave here before just having a little bit of information now on the last part, because now Ajua put in the balloon in this patient. She lost 10 kilos in the next 6 months. But now Ajua had to remove the balloon because after 6 months, of course, it has to be removed. And after that, the patient started gaining weight again, which is usual, right? So now we move on to the aspect of bariatric surgery. So Nicola, what are the indications for bariatric surgery generally? And, just tell us overall, what are the indications? And do you think this patient should be sent for bariatric?
Yeah, so this patient is a good candidate for bariatric surgery. One, because of the high BMI. She has a BMI of 42.2, I think, if I remember correctly. And also due to the fact that she has not done well on medical management. So the indications for metabolic or bariatric surgery are any patient with a BMI above 40 kgs per meter squared, irrespective of whether they have or don't have comorbidity. Any patient with a BMI of 35 with a comorbidity, so either diabetes, hypertension, dyslipidemia, and any patient who has a BMI of 30, maybe they have diabetes and they are not doing well as long as they are on optimal treatment. So that is for the normal, that is for everyone except people who are of Southeast Asian or Asian descent. So those ones would have a lower cutoff, and that would be 27 kgs per meter square. That is irrespective of whether or not they have a comorbidity, and maybe 25 with a comorbidity. So there are options, and I was actually also quite impressed by what Ajua said. I didn't know those options for endoscopy are there. But when it comes to bariatric or metabolic surgery, there are mainly two kinds of procedures. So it could either be a restrictive procedure or a malabsorptive procedure. So when you're thinking about restrictive procedures, are just the ones that generally reduce the size of the stomach. So those would be things like sleeve gastrectomy or gastric banding. When it comes to malabsorptive procedures, so there's the Roux-en-Y, gastric bypass, and then there's the biliopancreatic diversion with or without duodenal switch. But what is done locally, and what at least I know, maybe Ajua can expound on that, is sleeve gastrectomy and Roux-en-Y. But for now, this patient, when you consider the way she has presented, restrictive procedures would not be an option for her, mainly because of the fact that she's had a history of GERD. And because with the restrictive procedures, they have that small pouch and intragastric pressures are very high. So it's likely to worsen the gastroesophageal reflux. So for her, I would probably cancel her to maybe opt for Roux-en-Y gastric bypass.
Excellent. And sorry. So I think that brings us more or less to the end of the case presentation. And this is just to take us through a little bit on the summary of what we have discussed so far. You can see the medications that could cause increased weight gain as far as our different categories are concerned: antidepressants, antipsychotics, diabetes medications. Insulin can lead to weight gain if taken over long term. Sulfonylureas, and this, if in such a patient, you'd substitute towards your GLP-1 receptor agonists or SGLT2 inhibitors, which you would be expecting to be associated with less of weight gain. So you can just have a look at that. These are the different agents that you can use in replacement of those that can. And if you remember in the very first slides, I mentioned something about staging of obesity. So there's this Edmonton obesity staging system that you can use to stage obesity based not only on your BMI and anthropometry, but also on your association of the functional, the medical and mental evaluation of your patient and the complications that they've developed. And you can see that you can stage your patients in the different categories based on these aspects that they have, and this is how the staging happens. And you can see the different modalities of treatment then that you consider for the different stages, not only looking at your anthropometric measures and looking at the patient as a whole. When you're starting exercise training, unfortunately, Dr. Boyd is not here, otherwise I would have made you all stand up and do exercises, including those online. But generally what you need to keep in mind is first start slow and go high gradually with flexibility training, then balance training, then add on aerobic, and then resistance exercises. So it's just as a summary. And this is a guideline that it would be really nice for you to see, looking at beyond BMI. And just to expand, when you look at it, you are going to have these different aspects of management, asking for permission. Remember what we said about expectations. Ask for the patient's expectations, discuss with the patient, and make a plan that the patient is agreeable to. Then you advise on the different management modalities that we have discussed today. Second is to assess their story. You saw the whole history that we took. Advise on the management based on what is acceptable and basically suitable for that particular patient. And then you need to assess again, once the patient comes, you agree on their goals and you assist with their goals and with their long-term management plan. So maybe just as a last point to all of you, what would be your take home for our participants for moving from here?
So for me, it's just to emphasize that diabetes is a chronic and relapsing condition. So it is lifelong management. Obesity.
Yeah, mine would be about the other approaches which we use for weight loss and the rest, apart from the bariatric techniques, endoscopic bariatric techniques and the rest, and medications, and that's exercise. So one of our colleagues posted on the KP group about a questionnaire which they had done and what people are answering in terms of why they don't do exercise, and there was a very hilarious part which I remember seeing. And one of the reasons a number of people, that 70% of guys said, I don't exercise because exercise makes me tired. Well, I laughed and I was like, yeah, that's the whole purpose of the exercise. But anyway, so exercise is extremely important. And I know many people don't have time to do the 170 minutes per week. But here's the thing. High intensity interval training is probably the best form of exercise on the planet by a country mile, no doubt about it in my mind. And high intensity interval training only requires 20 minutes of your time. And that's all I do. I do 20 minutes. 20 minutes. I can assure you the legacy of that stuff within 2 years is amazing. A number of people, me included, when I started it, I used to do it almost I barely have to struggle with my weight after that. So there's a huge legacy effect similar to what metformin does for diabetes. So it's something which I would encourage people to take up. You don't have to run a marathon and all those things, no. Just 20 minutes of your time, you heat it in and you heat it out and you're done for the day. And you're done almost for your week, pretty much. It's an extremely good method of exercise. There's so many different types. Therefore, there's something for those who have issues with their knees and all the rest. Then there's now the really intense training for those who can't keep up. And it's extremely, extremely good. And I tell you, I can assure you it works very, very well for most people. It is probably at the top of the list of the best exercises in the world for those who want to maintain good weight and good health. So there are lots of videos on YouTube. You can check them out. For those who are able to do the extremely high-end ones, there are guys like Chris Harrier, amazing, amazing stuff which you'll see on YouTube. So I encourage a lot of people to move into high-intensity training. Forget about going out and jogging along the roads, getting robbed and getting hit by motorbikes and all that crap. So you can do this in your bedroom, easy, 20 minutes, and you're done. So it's something which I would encourage guys to take up. And number two, diet. Diet. You cannot outrun a bad diet. That's the truth of the matter. So in terms of diet, intermittent fasting does wonders. Intermittent fasts, and also watch the quantities of food you eat. Really drop down on your carbs as much as you can, because you cannot intermittent fast and during the times when you eat, you now go and load up on carbs like crazy. It's not going to work. Yeah, so those are the main things now, together with the other techniques. Thanks.
Thank you, Ajay. You have actually, I think, half of Betty's.
Thank you.
Contribution.
Mine, yes, we all agree that obesity is definitely a chronic disease, and therefore it requires a multidisciplinary approach. So the same effort as physicians you have to introduce pharmacological interventions is the same effort we should have to try and ensure that we send the patients to the right people to have the discipline to do the right thing and to ensure that they are eating well. And one of the two people, actually, I won't mention their names, physicians, when they send a patient to me and the patient goes back to them, the first question, did you see Betty? Yes, what did she say? Because they'll know when they are lying. If you didn't see her, now next time, please don't come for your appointment. Make sure you go and see her first, because I think diet is key. There is no need of spending so much money to buy so much medication when your problem is just the food that you've eaten. Thank you.
Thank you. And the battery goes off, telling us to
go home.
Batteries as well. There was one nice take home that I had, just very small. I don't know. Anyway, if it doesn't come on, that's fine. But like what you said, my last slide was just about teamwork. So it's all a multidisciplinary approach, the way we have set here. The people in the team that are missing, I must say, is the counselor, because counseling is extremely important when we are doing obesity management, and adherence is key, because patients lose hope very quickly. First of all, the aspect of obesity itself has a psychological or a mental element, and then the aspect of the weight loss journey itself. So that's what we need to do. The counselor and the other person is the exercise specialist and the bariatric. So it has to be a whole team-based approach when we want to address patients with adiposity-based chronic diseases. Thank you. And thank you to our amazing panelists. Thank you so much. Any burning questions?
Yeah, so there have been experiments on multiple balloons. There are dual balloons and triple balloons. The side effects have been so bad. Most people have not gone to the 2-in-1s and 3-in-1s. The single balloon tends to be good enough. And now there are those balloons which you can now actually slowly increase the size of the liquid which you put. So you can start at half a liter, and then after a month or so, you can actually increase to 600, 700 mLs, and so on and so forth. Yeah.
Any more questions? Ajua. Sorry. How come it's not working? Yeah, where is Betty? You can take up the question on mukbang.
Basically, it's just being in that state of just wanting to eat. You know, you've seen food and you really, really want to eat. Probably you don't even know when and how to stop. And that's why the issue of the counselor comes in, because again, food is a very social thing in society, and how people relate with food is very different. Sometimes we probably come from a place where there was no food, and then all of a sudden there is food and you're trying to quote unquote restrict. So there are people who psychologically relate that to, if I don't eat it, then actually not doing justice to the state that I was in before. But I think it all boils down to discipline. We had a discussion earlier on with Carol, and we realized at the beginning of a healthy diet regimen, it is difficult. But the moment you overcome that difficulty, it becomes such a part of you that even if you see a lot of food, you put off, or you will actually serve that food in lots and lots of quantities. But the moment you start eating, you realize that there is a certain place you can't pass. So it's an issue of discipline, really. Takes time. Does the patient have support? Sometimes you're the only one, or you tell this husband to go home and eat, half a cup of ugali as an example, and they come from Western Kenya. Then the wife will be wondering how many other homes they have and where else they've been eating, so that they're able to only eat that and be satisfied. It must be a supportive environment.
So the truth is we cannot cover obesity in 1 hour, clearly. But we are going to be hopefully in the very near future having a full obesity symposium coming up for a full day. But my take home was this: keep your waist circumference to less than half your height. That is the waist to height ratio, okay? And the whole aspect of teamwork. Any more questions? Nicola, I think you want to say something?
Yeah, so I just had a comment based on what Betty was saying with the mukbang eaters and the counselor, the need for the counselor. One of the things that we really have to evaluate for, particularly for those patients who are seeking bariatric surgery, is eating disorders. So things like binge eating disorders or night eating disorders, those things really have to be screened for, because if you don't deal with them pre-surgery, they will show up post-surgery and the patient will gain back the weight.
Okay, thank you very much, all of you. And I think I'll hand over to Dr. Ajwa to close the session. Thank you.
So I guess we've come to the end of our one day symposium. So it's been a really good day. The weather notwithstanding. It's been like Siberia up in here today. I don't know why. So thank you all for coming. For those who are online, thank you for joining us. We hit the highest we hit was we hit almost 350 or something, almost 400 people at some point. That's a pretty good attendance. You can clap for yourselves on your sofas. Good. So we'll be doing this twice a year. That's our plan from now going on, starting next year. So please stay tuned to our adverts and our flyers going forward. A couple of people we want to say thank you to. The companies who have supported us, Pharma. Don't be worried. I'm a big fan of you guys, even though I mentioned using endoscopic techniques for reducing obesity. There's still, we can all work together. There'll still be work. Not everybody can afford a balloon, so things will be okay. So thank you very much to, in no particular order, Getz Pharma, Cosmos Limited, Galaxy Pharma, Sun Pharma, Savia, and Troika. So thank you all very much. This could not have been possible without your support. And looking forward to seeing you all again. We want to say thank you to our vendors who have also helped sort us out. The reviews I've seen so far online are really impressive. They've said it's been hitch-free, sound and video have been excellent, which is really, that says something. So thank you very much, KNH Webinars and CMOuse Studios as well. I found out to be a very interesting name, CMOuse. I don't know if the founder is here. I would like to understand how he came up with that name, but it's really cool. So CMOuse Studios, thank you very much. Explode Media, thank you very much. Even though thank God we're not in America, neither are we on an airplane. I'm told on airplanes, you're not allowed to say bomb, explode, and all that stuff. So Thank you, Explode Media. And thank you to Movenpick Hotel for hosting us. Lovely facilities as usual and some nice food. Yeah, I do enjoy a good meal. Don't be fooled. I do enjoy a good meal. So thank you very much for hosting us, Movenpick. And thank you also to our organizing team, Carol, who is our in-house coordinator nowadays, and Zipporah. Thank you all. Thank you to the faculty and all the speakers who have donated their time to come and give us presentations. As you can see, none of a single one of them put up a slide for those things are called what? The first slide, disclosures, the disclosure things, yeah. So if somebody saw them in my tent, we don't know about it, but I don't think anybody saw them behind the tent. So thank you for giving up your time on a Saturday in the freezing weather to come and help educate all of us. Thank you all very much. And finally, to the organizing committee of KAP, Nairobi and National, we thank ourselves very much. thank ourselves very much. Thank you all for the hard work and plenty of meetings online and physically. So let's go out and enjoy the Saturday. Life is short, is what I always say. Yes, life is short, so don't waste it sitting in symposiums for more than 8 hours. No, we have already done a good amount of it. No, that was not wasted, of course. I mean, do not waste any more of the time. So now that we've come to a close, that part is done. Now it's time to go and do other fun things. Life is short anyway, as we say. So, yeah, no. You sleep when you die. No, we're not going to sleep. No. Sleep when you're dead. So let's please go out, enjoy yourselves. Those who are at home on their couches, get off your couches, maybe do one set of HIIT exercises, and then go out and have a drink. We don't mind. A little bit of alcohol will not give you math LD, I assure you. So enjoy your weekend, everybody. We have a group photo before we go. Thank you.